Hello, Sharat.
Hello, Jan, how are you?
I just got a telephone from somebody from our society that they cannot get in with the link that they've been given.
Okay, I'll just give me a moment.
Okay,
Hello, Jan. How are you?
fine. Hey, hi, hi Rahul.
How are you?
Everybody ready?
Yeah, everybody is ready.
This is incredible. But I don't know. Well,
Is it Philip? Are you talking of Philip, Jan?
pardon?
The person who called you about the problems, is it Jan? Is it
No,
Philip?
One is
Philip?
myself.
No,
is
Philip.
somebody else, but he didn't call me.
Acha, he didn't call you. Oh, all right, okay.
Was Rolf Hunkeler called me.
Rolf, okay. I'll just check into it.
He said when he gives the password and so it says not known, person not known.
Okay.
And he was resending all these links to the whole society. So it would be probably a problem for many people.
Can I send you one link where they can auto register? Do you have it, Jan?
Well, send it to me.
I'll send it to you.
Okay.
So they can just click on that link, create their own username, password.
Yeah, well, I think they did register all of them, but whatever. You can give me the link, so I will send it to them.
Sharad, are we making this Facebook Live?
Facebook, I have no idea because it can be done only with the Facebook admin guys. So either this.
The hospital's locked down too.
No, we're still working. Just urgent cases. Everyone coming to hospital have a COVID test.
Okay.
So Sydney has been on
Close the
hard
door
lockdown
here,
for
because
a
otherwise you will only hear Portuguese.
Yeah, they sort of locked down too late. So now it's everywhere. It's getting there.
I get the feeling that when the world recovers from COVID, Australia will get it.
Yeah, well, we are now just starting to get it. So actually, New Zealand will be the last one, I think.
Marburg, go.
Melbourne, the case is still low. They closed very early. Sydney closed too late, so now it's peaking.
Unmute, Barbara.
Ah, Barbara is here.
Yeah.
Yeah.
Welcome, Dr. East. A
I think
rose
the
amongst
panel is
many
complete.
thorns.
Yeah.
Hi.
Hi, Barbara.
Hi.
Yeah. So the panel is complete. I think we should be
Hello.
on in a
Hi.
few minutes.
Sorry, I'm
Yeah.
cleaning out a cottage.
If any of you get complaints regarding logging problems, just let me know. Let us know.
Yeah.
We have direct login links now available.
Yeah.
Okay, just send
Thanks
it
very
on my
much.
WhatsApp and I'll forward it to people.
Yeah, I'll send it to you. Yeah, I sent it to Jan just now. I'll send it to you.
Sharad, send
It's
it
the
to
same
me.
one, you know it. It's the same
Sharad,
one.
send me as well.
You know it. It's the same one which you are sending to everyone.
Good job, Ram, and the committee. I'd have to say, very nicely organized event.
Thanks, Andrew.
When you look back, 7 weeks back, we just had the proposal. What do you think about LOD? I said, well, I will think about it. And then Ramana said, well, don't think about it. Let's do it.
All right. I think we're good to go because people.
2 minutes. 2 minutes.
Yeah, but we could actually start the transmission so that people at least know.
Transmission is on. Transmission is on.
Oh, is it? Okay.
We are live.
Yeah,
Yes.
yeah, we are live. We are live.
All right. Okay, cool. So what's Barbara doing in the open skies?
I'm sorry,
Barbara,
I'm
what are
cleaning
you
out an
doing?
old cottage.
All right.
It's a
we-
disaster here.
We
At
can't
least
see
one
you
person
now.
is
Absolute
usefully employed.
disaster.
So what's happening?
Barbara, we're appointing you as, after Ram has spoken, we're appointing you as chief chairperson, and myself and Oroshi will be in the background. Okay. There's beauty before age.
Well, we call it ladies first.
Yeah, we call it in Czech, stick the devil in first.
All right. So Pramesh, should we start now?
Yes, sir, we can.
All right. I'm good to go then. If you say 1, 2, 3, I start.
You have dedicated 5 minutes, Ram. So you can start at 4. Yeah.
All right.
So we have given time for chairpersons. We have given time for everyone to speak. So I think,
So I won't need.
yeah,
more.
it is 4. It is 4. We can start. Yeah.
All right.
Good to go.
So good morning, good afternoon, and good evening, dear friends, ladies and gentlemen across the whole wide world. It is such a pleasure to be with all of you on this historic event, which turned out to be historic because of you and more than 10,000 of you who have registered for this event. And today we want to discuss a topic about which there is limited amount of science and knowledge, and probably the experience of experts doesn't really rub off on the rest of us. So this is one of those things which I believe is an inch wide and a mile deep. And I can tell you that as someone who has designed the program, I could add more subjects, more talks on this particular topic. So it's really not all that one can know about loss of domain, but certainly a substantial amount of working knowledge that any surgeon interested in the field of hernia surgery could hope to get, and in the most attractive and assimilable form. So this is an effort by multiple global societies of hernia surgeons and general surgeons. And we all hope that this is the first of several such initiatives, and we can all actually start working together rather than working individually, separate, because I believe that together we are stronger and apart we are just weak. So let's sit back and enjoy the rest of the day or evening. And I would like to introduce Professor Jan Kukleta of Zurich, Switzerland. He obviously doesn't need any introduction, but before that, let me hand the podium, virtual podium, to Barbora East, Andrew, and Hiroshi Hirokawa. Please.
Me first? Okay. Barbara.
Thank you. Thank you very much, Roman, and congratulations to such a fantastic idea and being able to pull it off together. It's I also believe that my fellow Czech does not need any further introduction. I feel a little bit sorry that he was given the history topic, being the eldest out of the speakers. I think it's a little bit unfair on him, but I'm sure that you're going to enjoy his lecture very much. Thank you, Jan.
He's the most authoritative person on history, as far as I can tell you.
Okay.
Well, may I share my screen?
Yes, sir.
Yes. Well, Warm welcome to all of you, all the faculties and all the attendees, because I've been shocked when I read for the first time the number 10,000. I know India is big, but 10,000 is a lot. 10,000 people interested in a very special topic. So I wasn't that angry about the topic, because I know, once you get dusty, you just have to do something against it. So I probably learned a lot just by that topic. And just on behalf of the Swiss Association for Hernia Surgery, I'd like to welcome you all, because our society has got 59 members, and the Indian group, abdominal wall surgeons, are over 4,000. So there's a little disproportion, but that doesn't make the difference. So, well, these are my disclosures. The most important that I love hernia meetings, but in person. I'd like to see you again, Barbara, like the last time we did. Well, the history of loss of domain, it's a kind of a privilege and a burden to talk about something where it's so little written about and so little actually standardized, but I took the chance and made the best of it. History of an enigma. Well, I remembered that somebody from Argentina, whose name is Goni Moreno, 1940, published something, and he published it in English, because it was always the same objections. But the South Americans and North Americans, more of the time, they are devoted to this type of procedures that were maybe very peculiar for us. So I talked to Juan Carlos Mayagoitia in Mexico. I mailed with Fernando Carbonell Tatay in Valencia in Spain, talked to several Argentinians if they have anything more than that, what we know about this guy. Because some hernia topics have a long history, others don't. For example, the term ventral hernia was for the first time used in 1728 by a French surgeon, Garangéot. But what about this topic, loss of domain, in the past? In 1912, the French Academy gave out a booklet about how to treat big hernias with bandages and trusses. And 1984, when I opened my surgical office in Zurich, I bought myself a famous standard surgical Bible, which was Lloyd Nehu's Mastery of Surgery. In that book of 1,400 pages, there is no chapter on abdominal wall hernias. How do you think anybody would care about complex hernia or even loss of domain? And this was 1984. Yeah, there were some people. Goni Ivan Moreno, the surgeon who recognized the importance of volume of hernia and used the terms right of domicile and second abdomen already then. 1940, he published for the Argentinian Society something, or it was unique technique. He was injecting oxygen first in a patient with an incarcerated incisional hernia, and the patient did well afterwards. So this was apparently for the first time that the pneumoperitoneum has been used for therapeutic purposes, called progressive preoperative pneumoperitoneum. Well, let's use his words. The disproportion between the abdominal container and its contents, second abdomen, lost the right of domicile. It would be an embarrassment if you would put all these contents suddenly back to the cavity. And because of the excessive tension that you would need, he was afraid of recurrences. Well, he must have had LOD in mind. These are the original drawings. He published it in English in 1947 in the Journal of Surgery. Well, the effects of sudden increase in abdominal tension, he realized that the weight reduction principle was insufficient. He realized that intra-abdominal pressure was important, not the number of liters, because the useful effect to enlarge a cavity was by the pressure of the gas and not by the liters. And there is no relation between the number injected of air and the intraperitoneal pressure. Well, there are different classifications of abdominal wall hernias, but none of those mentions the volume of hernia sac. Loss of domain versus loss of right of the domain. Well, Parker, in his paper 2019, raised the discussion whether it was correct loss of domain or loss of right of the domain, because contraction of the lateral strap muscles would decrease the abdominal cavity volume. That was a truly loss of cavity volume. An early adopter of progressive pneumoperitoneum, Dr. Johnson, published in 1972, something that he believes that abdominal viscera stay in such a long time out, they lose the right to belong inside of the abdominal cavity. Whatever it is, but the anatomical and functional changes were already known to Jean Rive in 73. He called it eventration disease. Muscle that retracts laterally, hernia enlarges, disuse atrophy, irreversible muscular fibrosis, strap muscles get shorter and thicker, the intra-abdominal pressure lowers, that causes descent of diaphragm and respiratory dysfunction. The mesenteric and bowel wall edema causes increase of the content, and the unsupported spine causes chronic back pain. Also, Parker was right when he called his paper what exactly is meant by the loss of domain. He wanted to find out the definitions. He found 1/3 had a written definition, but 2/3 used the word of loss of domain as a concept without any definition. And only 1/4 used volumetric definition. We will hear from Eduardo Tanaka afterwards. I will leave it here. Of course, that the cutoff threshold or percentage proportion above which loss of domain becomes clinically significant is of importance. This is what we would like to have. Well, Samuel Parker used another 19 surgeons as experts in a Delphi consensus and found out the definition, which is in my eyes not much better than anything which was said before, but a ventral hernia large enough that the fascial closure either cannot be achieved without additional reconstructive techniques, or it cannot be achieved without significant risk of complications due to the raised intra-abdominal pressure. Why are we so concerned about the loss of domain? Well, the primary closure can cause intra-abdominal hypertension and abdominal compartment syndrome. The World Society of the ACS, that I had no notice about until I prepared this topic, demonstrates very nicely with increasing intra-abdominal pressure rises the mortality of the patients. Substantial loss of domain causes recurrences, and there is no consensus until now on the loss of domain threshold predicting postoperative failure. So what are the lessons that we've learned from the past? We have several ways how to reduce the risk of ACS. And today I may add one more. We will hear about it later in the session 3, the perioperative expansion of abdominal wall called fascial TENS. And if I ask our captain what he sees on the horizon, he would say, yeah, fine, it will be a good content. But humble myself, I would say today will become historical. And I wish you all a great conference. And donate the next 30 seconds to the next speaker.
Thank you very much, Jan. It was breathtaking. It was actually, you've done your homework very, very well, haven't you? it was very nice. I think Friedrich Kalinowski is going to be very happy for the donated 30 seconds. It's a person that I think deserves a little introduction because he is not probably as chronically known as many of the other surgeons around the globe who dedicate their effort and time to abdominal wall repair. But Friedrich is very unique. And I remember a few years ago, I tried to publish a study which was talking about some very basic physics. And so many journals have turned my article down because they said it's not interesting, it's not important, and it's hard to understand. And he was the person who actually grabbed my hand at one conference and he said, I read your paper, it was actually interesting. And since then, I have heard his talks a few times, and I must say he is able to present these physical principles and all the things that I believe all surgeons should understand and should have very good knowledge about in a way that everybody can understand it. He's done a much better job than myself, and I would like to ask him to talk about the biomechanics of the abdominal wall. Thank you.
Thank you very much, Barbara. Thank you very much, Jan. I think I tried to share my screen. I hope I did it right.
Yes, it does.
And so we talk about durable mesh repair. I thank Ramana for inviting me to have me here. And I thank all the participants to listen, because it took me almost 30 years as a surgeon to understand that biomechanics is the basis of what we do. And to do a lot of domain repair durably requires some knowledge. And so we do 5 slides on a bench test. We do 4 slides on computer tomography of the abdomen with Valsalva's maneuver. And then we do some clinical strategy and some results. The results are from a register. Ferdinand Köckerling opened a new page in the Hernia Med registry, and it's called Stronghold. It's 10 hospitals donating patients to this. And I want to thank Markus Büchler, head of the Department of Surgery, who supports this since 5 years now. So here you can see the bench test working. It was built in Hamburg with the Technical University, thanks to Michael Morlock and Matthias Vollmer. And it pushes like COPS, 1 second push, 3 seconds relaxation. And you see what happens. The energy going into the system moves the tissue and the mesh differently. It depends on the characteristics of the tissue and on the characteristics of the mesh. And you can calculate from the data you obtain what you need to do, the critical resistance or retention force. And you can see the gained resistance of impacts related to pressure. What have I actually achieved during my repair? And the first thing you want to know, what is actually the retention force of my mesh? So people call this the tackiness. You know, the tackiness of meshes can be classified by this bench test. Since we do not do a full cough, we call it dynamic impact strain. And if any reconstruction holds more than 400 of these impacts in 10 repeated experiments with different tissue types, you know, there are pig tissues and there are bovine tissues, and these tissues come from different animals. And so we have all kinds of trained animals walking around and lazy animals always standing. And so it's a variation. And if it holds 4,250 of these impacts, we believe it's a fairly good retaining mesh. And so it gets a factor or a coefficient of 1 or better, and we call it a disc class A mesh. And the other meshes, they fall behind. And the mesh with the lowest retention force was withdrawn from the market since it had high recurrence rates in the registries. So we believe this is a guidance. What does the mesh do? And in order to get a handle on the calculation, we used the proposal by Tullo and de Bow. They proposed you use the mesh defect area ratio. And this is for a round mesh and a round defect, but you can calculate it for any sort of kind of defects and any sort of kind of meshes. So you can get a mesh defect area ratio as a figure. And if you multiply this or add influences to it, you get a grip factor, which is the gained resistance of impacts related to pressure. So this grip factor, you calculate as the mesh defect area ratio times the mesh factor times a bonding factor for fixation, a position factor for wherever you put the mesh, underlay, sublay, IPOM, onlay, and a closing factor and other factors as well. And it's published data, and you can look it up and figure out. Otherwise, you give me a call, you get my phone number later. So when you want to calculate what you need, you must recognize that with increasing hernia sizes, you need to have higher grip values. And this line here is called the critical resistance. If you are surpassing this critical resistance, you are in the green area here. You will have an adequate grip. And if you are not surpassing this resistance, the critical resistance, you have too low a grip. I mean, if you have a patient who is not coughing or not walking around or has no other risk factors, maybe this grip is okay, but you have a higher risk of dislocation and recurrence if you have an inadequate grip. And if you have an adequate grip, you reduce this. So you can calculate it, you can adjust it to the tissue stretchability, which we will talk about 2 slides from now, and you can adjust it to the tackiness of the mesh and to other factors as well. Another point is the defect closure, and these are 2 clever students from our lab, and they did an extensive study of what you have to do a defect closure durably, and you can suture defects up to 7 centimeters if you have a no mistake strategy. You mean you have to do a flawless suture. With a stretchable suture, you use a small stitch, more small bite approach, and your suture tension should be in some area range, fairly low, and the incision to suture ratio should be at least 1 to 4.4. So, and then all defects were held tight against these 4,250 pulse loads. So if you do not have this kind of strategy or you are uncertain about it, you should use a sandwich reconstruction technique. We talk about it in a minute. Next thing, abdomen computer tomography with Valsalva's maneuver. People have been looking at the hernia sac, and this is where the definition of loss of domain is coming from. And as you do a Valsalva, the hernia sac extends and pushes forward. But we look at the abdominal wall, and in this guy, a 42-year-old guy with a recurrence after IPOM for a fairly small hernia defect, about 2 centimeters. 1 year later, he had this kind of opening, 10-centimeter opening, and it stayed almost stable during Valsalva. So he has a stable abdominal wall here with those circles. But if you have an unstable abdominal wall, you will have much more variation in those, and you have to analyze more carefully. You have to do at least 12 assessments, and this costs you about 45 minutes to 1 hour of manpower. So we looked for better ways to do this, and we used artificial intelligence and picture analysis. And with artificial intelligence, you can see here an unstable abdominal wall. The defect is the red area. The rectus muscles are the blue shaded ones. And as you push, the abdomen opens. It's a person, 57-year-old, with repeated incisions, short bowel syndrome, and the defect almost triples during this procedure because a new defect opens. So this is one thing. Defect area increases with an unstable abdominal wall. And the other thing is you get notches and stress concentrations. If you have a mesh in this guy, 30 centimeter wide and 45 centimeter long, you will still have distortions at the edge, and you need to close these with good fixation. So this is what you get from this analysis. And in the broader spectrum, the healthy abdominal wall has a strain of about 1 to 1.5 centimeter, and the herniated abdominal wall has a strain of more than this, 90%, 6 centimeters. And if you have a loss of domain, you have strains of 10, 12, and 14, 18 centimeters. And if you do a progressive pneumoperitoneum, you reduce it to lower values. So you reduce the strain with a progressive pneumoperitoneum. I believe the same is true for Botox. So the next thing is, what is our strategy? First, use the computed tomography to assess the abdominal wall, and then maybe use Botox or progressive pneumoperitoneum. Then think about how to create large enough a space to put your mesh in. Use a disc glass A mesh if possible, or adequate fixation. And if you cannot close the defect or have other problems, you can build a sandwich. And for the skin and skin and subcutaneous defect, you can use an advancement flap. And this advancement flap closes it. And I think you should resect the umbilicus to reduce contamination. So what are the results of this? It's not all loss of domain patients in here. It's 1 year results. You have no recurrence, no chronic pain in this group from 4 hospitals, and all patients which were below 62 years old returned to work. So thank you very much for your attention.
Friedrich, thank you very much. Another star lecture, and clearly a lot of work we need to do in assessing our patients in addition to clinical examination. But moving on swiftly, it's a great pleasure to introduce a fellow European, Johan, who's really, I guess, a disciple of some of our old European stars, Professor Clement, Chevreul himself. So it's an absolute pleasure for Johan to talk to us all things anatomy relating to loss of domain. Johan.
Thank you, Andrew. Dear friends, dear Dr. Ramana, congratulations for the organization of this event, and thank you for this opportunity to speak about structural and anatomical changes in loss of domain. First, remember the different definition of loss of domain published in 2014 by the EHS, in 2016 by the French, and in 2020 by Delphi Consensus. This definition seems the best. An incisional hernia with loss of domain is first too large and then too voluminous, with high risk of postoperative hyperpressure after the repair. So we will try today to explain these difficulties in an anatomical point of view. But it is really difficult to draw general conclusions because a loss of domain is always different among patients in terms of size, location, with patients suffering in age, weight, tissue quality, and wounds are all different with several different comorbidities, as you can see among this drawing with all these patients. So for the reason, it is very difficult or impossible to make general statements, but we will try today to explain these difficulties in terms of anatomical changes. One more slide with several patients explaining that they are all different in terms of anatomical changes. Here is the summary of this presentation. We will first see how the loss of domain implies changes in the abdominal wall muscles and how it interferes with the motricity. Then we will see the changes in the abdominal pressure, in the respiratory functions. Then we can see the local changes and the visceral changes. So using these 5 points, we will explain how the process is complex and how the treatment is difficult. I have to see that all these considerations have been already explained since long time, in particular by Jean-Rive and colleagues from Reims here in France. First, the musculature and the trunk motricity. The muscles are a complex dynamic cylinder inserted on the lower wall of the thorax superiorly and on the upper edge of the pelvis inferiorly. So we can see relative and opposite movement of the thorax in relation to the pelvis, given the inclination, the rotation, and the flexion. Hence, the motricity and the mobility of the spine comes from the contraction of the abdominal muscles. And the spinal muscles posteriorly are the opposite muscles giving the extension. Second, there is a torque of tension. The muscles are a dynamic system under tension inserted in the linea alba in the middle, and they give divergent traction of this torque of tension with opposite action of each side. So the linea alba should be intact for correct dynamic mechanical system. Knowing this concept, what are the consequences of a division of the linea alba during loss of domain? There is a rupture of this medial tendon with anterior disinsertion of muscles. And we can see first a sagittalization of the rectus abdominis muscle as it was drawn using this original drawing of Reeve. And as you can see on these two slices of CT scan on this patient. This sagittalization is very important during loss of domain. Second, we can see a retraction of the lateral muscles. As you can see here, the muscles are retracted in posterior part of the abdomen. Third, due to this retraction, we can see an atrophy and fibrosis of the lateral muscle. It has been shown already in 27 with a muscular degeneration, sclerosis. The muscles are stiffer and less elastic in the posterior. In fact, there is three areas to explain this atrophy. Superiorly, the muscles insert on the ribs cartilage with short fibers, so here the retraction and atrophy is irreversible. In the inferior part of the abdomen, there is no muscular fibers since the muscles are made of large aponeurosis part, and this part is not concerned by the retraction and atrophy. The important is in the mid-level, the muscles are inserting in the spine with long fibers, and here in the middle, the retraction and the atrophy is partially recoverable. We can say that strap muscle fibers become shorter and thicker. Fourth, we can see back pain because there is this muscle retraction and atrophy. There is the sagittalization of rectus muscle and a diastasis of rectus muscle. So there is a spinal counterbalance to move the abdomen with spinal deformity and chronic lumbar pain. And fifth, there is an increase in the volume. Thanks to Pascal's principle and due to intra-abdominal pressure, there is a traction of the lateral muscle and the diastasis increase. So Reeve called that an open double door. The hernia gradually enlarges, giving a second abdomen. So to conclude about the muscles, in case of loss of domain, we have a sagittalization of the rectus abdominis muscle with retraction of these lateral muscles that became atrophic and fibrotic, giving some changes in the abdominal wall motricity with back pain, explaining the progressive increase in the loss of domain volume. The second important thing comes from the lung function and respiratory function. Normally, there is a synergic action between the abdominal wall and the diaphragm. During the inspiration, there is the contraction of the diaphragm and the relaxation of the abdominal muscles. And during the expiration, there is a relaxation of the diaphragm, and in case of effort, the lateral muscles become the main expiratory muscles. So the lateral muscles regulate the intra-abdominal pressure. But in case of loss of domain, there is the retraction of the lateral muscles and the viscera are out of the abdominal cavity. So there is a significant reduction of the intra-abdominal pressure. For this reason, there is a diaphragmatic descent with a progressive flaccid paralysis of the diaphragm, giving a respiratory dysfunction with a restrictive lung disease with a total lung capacity inferior to 80%. This thing has been explained by Reeve as a paradoxical respiration. During the inspiration, normally the diaphragm moves down and there is a counterpressure from the abdominal muscle. But in case of loss of domain, the incisional hernia inflates during the inspiration. During expiration, normally the diaphragm relaxes and the abdominal wall inflates. But in case of loss of domain, during the expiration, the incisional hernia reintegrates the abdominal cavity. It is the paradoxical respiration, giving a restricting lung disease getting worse. And this thing can be explained with this patient. When he coughs, the incisional hernia inflates, but normally it should reintegrate the abdominal cavity. So we have seen the muscular changes, the changes in respiratory function, and changes in intra-abdominal wall pressure. Now, what are the local anatomical changes? During loss of domain, the skin getting very thin with chronic ischemia of the skin and the risk of trophic ulcer. Moreover, the omentum can be infected with the risk of intertrigo microabscesses. So during loss of domain, there is a high infectious risk explained by the anatomical changes. And as you can see on these small drawings. And lastly, what are the visceral changes? During loss of domain, there is an important circulatory disease. Due to low abdominal pressure, there are a portal venous stasis and a potential risk of thrombosis. For this reason, there are a mesenteric and bowel edema with congested bowel, and that give an enlargement of the viscera become heavier. It is called as a splachnomegaly that can give diarrhea and abdominal pain, and that makes the reduction even more challenging. This protrusion of visceral content can be here shown on these three patients with a high splachnomegaly, as you can see here, due to the edema of the bowels, making the reduction very difficult. So to summarize, what are the anatomical changes during loss of domain, why it is so difficult to treat, and what are the solutions? First, concerning the abdominal wall muscles, we can see the sagittalization of the rectus abdominis muscle, the retraction of the lateral muscle, and the atrophy of this lateral muscle. First, that explains why the Botox may help, because it plays a role against the retractation of the muscles. And second, that explains that for us, the ideal treatment is the complete closure of the abdominal wall, the reinsertion of the lateral muscles in the midline, and the restoration of a functional abdominal wall. And that explains that the Reeves technique may be the gold standard for incisional hernia, because this technique implies the frontalization of the rectus muscle in the midline. Second, concerning the changes in the abdominal pressure and the risk of progressive increase in the volume, the ideal management is a prior evaluation of the loss of domain with the calculation of the volumes to anticipate the postoperative hyperpressure. Third, concerning the respiratory function, there is a high risk of postoperative respiratory failure, and the solution to enlarge the abdominal cavity are the Botox, the component separation, and the preoperative pneumoperitoneum. And in Reims, we use always the preoperative pneumoperitoneum because it plays a role, again, the diaphragmatic descent, because it is a preoperative rehabilitation of the diaphragm. And finally, concerning the local changes with the risk of trophic ulcer and the visceral changes with the splenomegaly, a wound healing is necessary, and the weight loss play a role, again, the splenomegaly. To conclude, during loss of domain, there is structural and anatomical changes that have been already explained years ago by Rive in Reims and colleagues, with the decrease of the intra-abdominal pressure and consequences, the risk of respiratory failure, the visceral and vascular changes, and the static changes. So the incisional hernia disease, as called by Rive, is very challenging. It is not only a defect to close. Thank you very much for your attention. Dear friends, dear Dr. Ramana.
Thanks
Thank you
very
very
much, Johan. I hand over to Roshi to introduce the last speaker.
Okay, thank you very much. The last speaker, that's Professor Eduardo Tanaka from Department of General Surgery, Hospital das Clínicas, University of Sao
Paulo.
Reported. Can you hear me?
Yes, sir.
Yes, I can. Yes, we can hear you well.
Okay, sorry. He came up with and first reported the famous Tanaka index and is a leading expert in loss of domain treatment in not only Brazil, but worldwide. Professor Tanaka, are you ready?
Yes.
Okay, his presentation title is What is Loss of Domain? If you're ready, could you please start your presentation?
And starting my presentation. Good morning for everybody. And my name is Eduardo Tanaka, and I'm talking from São Paulo, Brazil. And I'd like to thank the organizing committee for the invitation, especially Dr. Rodrigo Galego and Dr. Ramana for the invitation. In behalf of Brazilian Hernia Society and the Abdominal Wall and Hernia Reconstruction Group at Hospital das Clínicas of Sao Paulo. I will start my sharing my presentation, and I will talk about and try to answer what loss of domain means. For the ones who doesn't know our hospital, this is a picture of the hospital complex that is the biggest public healthcare system in the Latin America. I have no conflict of interest and have no disclosure. These are two examples of two patients with giant incisional hernias with loss of domain that we are going to talk today. So what is a loss of domain? There are patients with a second hernia that behave like a second abdomen. There are large hernias with a large part of the abdominal content outside of the abdomen, inside of the hernia. Loss of domain means that there is a large irreducible hernia. Means that we have a shrinkage of the abdominal continent, and the viscera lost the right of domain side of it. yeah, I can say that it's a little bit of everything together. So how can we answer this question? So lots of specialists has a lot of different definitions, and the two authors had the same question. Parker and Halligan described this article and making a systematic review for the definition of loss of domain. Because this definition is important, because the treatment of the patients with this kind of hernia leads to serious physiological complications, and identifying it and adequate treatment may avoid undesired results and disastrous catastrophes. Loss of domain may increase the intra-abdominal pressure when correction, and in extreme cases lead to abdominal compartment syndrome. The treatment may have increased wound complications if there are no special attention to the soft tissue above hernias, and may lead to more hernia recurrence. So it's crucial to identify those patients, because loss of domain may have a prognostic value, and these patients may be aware to preoperative management and improvement of their conditions. So the contents of the hernia sac lost the right of domain inside the abdominal cavity, and those patients has a shrinkage, thickening, and contraction of abdominal wall that leads to a reduction of abdominal volume. And the aim of all hernia treatment is return of the hernia content back into the abdominal cavity and reach adequate reconstruction of abdominal wall. So, is it possible? Always. We have to think, even the surgeon has this kind of doubt, and in which cases is it impossible? So there are some tools that we can use to answer this question. And one of the tools are the CT scan and the volume calculation. So to define loss of domain, the same authors, Parker and Halligan, joined 20 expert surgeons in abdominal wall reconstruction and tried to make a international Delphi consensus, trying to reach a definition for loss of domain. So the first written definition was achieved, and the written definition is a ventral hernia large enough such that simple reduction in its contents and primary fascial closure either cannot be achieved without additional reconstructive techniques or cannot be achieved without significant risk of complications due to raised abdominal intra-abdominal pressure. So it's big, broad classification and definition. And the second aim of the study was make a volumetric definition by Delphi consensus. And they analyzed two methods that make a volume calculation. One of them is our method, Tanaka method, and the other method is Sabag method. For those who doesn't know us, and these are simple explanation about it. So we have the abdominal content and the hernia content. The Sabag uses total peritoneal volume that is a sum of abdominal cavity volume plus hernia sac volume. And the loss of domain is defined when there is a hernia sac volume divided by total peritoneal volume greater than 20%. In our method, we divide the volume ratio is reached dividing hernia sac volume by abdominal cavity volume, and the loss of domain is defined when the volume ratio is greater than 25%. So the Sabag method was described in 2011, and they use special software to reconstructive calculation of the volumes of the incisional hernia and the abdominal cavity. So the ratio is above 20%. Our method was described in 2010. We don't use any computer software, and we compare the hernia and the abdominal cavity with two ellipsoid forms, and then we use the mathematical formula to calculate the ellipsoid. So both hernia sac volume and abdominal cavity volume are multiplications of the largest diameters of each cavity, anterior, posterior, lateral, lateral, and craniocaudal diameters, multiplied by 0.52. These are a picture showing the lateral diameters of the abdominal cavity and the hernia sac, anterior, posterior diameter of the abdominal cavity and the hernia sac, and the craniocaudal diameter of the abdominal cavity and the hernia sac. And we classify as hernias with loss of domain that are greater, the volume ratio is greater than 25%. Unfortunately, the Delphi consensus chose the Sabag method for the volume calculation. But they tried to reach also the volume ratio for loss of domain threshold, but there was no consensus about it. This was a shame because this cutoff, this threshold is the key for, in our opinion, for the adequate treatment of these patients. The Fafage author published in June this year in 2021 at JACS this article named "Can hernia sac to abdominal cavity volume ratio predict fascial closure rate?" using our score, the NAC score. So why he chose our method? Because of its practicality, and other methods use a CT scan and a special software, and needs a radiologist, a specialist to volume calculation that is not always available for it. And our method is relatively quickly done by a surgeon that has basic knowledge of CT imaging. More importantly, it can be done anywhere, even in the seeing the exam in the computer, so it can be used daily basis in the daily practice. So in conclusion, the authors conclude that the VR cutoff of less than 25% has a great result predicting the complete fascial closure. That is the same experience that we have in our service, because all the patients that has volume ratio less than 25% doesn't need any augmentation technique and goes directly for the surgical abdominal wall reconstruction and doesn't need any special key for accomplish the aim of complete fascial closure and abdominal wall reconstruction. So this is our algorithm for the treatment of the patients. All patients that has big hernia with suspicions of loss of domain are submitted to CT scan, and all the patients with volume ratio less than 25% go directly to surgery with complete fascial closure. And we always use only technique. Intraoperative intra-abdominal pressure monitoring is not necessary in these cases, and we almost always achieve abdominal wall reconstruction. In the patients that has volume ratio bigger than 25%, some methods of abdominal augmentation may be needed, as preoperative pneumoperitoneum, or other chemical augmentations like Botox, or even abdominal content reduction, like, for example, bariatric surgery if BMI bigger than 35 and the patient has comorbidities, or BMI larger than 40%. And those patients are then submitted to surgery with that aims complete fascial closure. In intraoperative abdominal pressure is monitored to avoid intra-abdominal hypertension or even abdominal compartment syndrome. If there is any suspicions or elevation of the pressure, other techniques of surgical augmentation of the abdominal cavity are done, or in extreme cases, visceral reduction are done to reach complete fascial closure and correction of abdominal wall, reconstruction of abdominal wall. I should highlight that since we have used bariatric surgery perioperatively, none of the patients needed visceral reduction, and all patients had completed abdominal reconstruction adequately, not needed bridging or any other surgical bridge or something. So these are examples of patients that we have treated successfully. Thank you. This is my email for any.
Thank you very much, Dr. Tanaka. Are there any discussion time?
I think
Yeah, we have about
minutes.
8 minutes for discussion. Yeah.
There is no question in the chat box.
Well, let's kick off some questions. Frederick, I have a question for you, and that was your very interesting description with your two researchers that you could close a suture closing up to a 7-centimeter defect with complete reliability, but you gave quite strict details. So 0.7 millimeter stitches, 1 Newton force on the suture. And you made a very interesting comment that one fault is one too many. Now, we're surgeons. We don't have inbuilt attention-ometers in our fingers, although we do to a degree, but limited. The ability for spatial awareness to be accurately place sutures 7 millimeters apart is also. But do you see in the future that abdominal wall closure will be mechanized or robotized to produce these very precise suturing characteristics?
I think you are right. I think this is an area which needs standardization. You know, it's not a lot of training you need to put in, but you can train people in doing very reliable closures. And, you know, it's quite common these days. Every handyman has a license to weld or a license to put in windows or things like these. And I think the next step for our trainees could be to train them in fascial closure. This would be one way. And ultimately, I think we could have a mechanical tool to do it, like a sewing machine. And then you have a high reliable suture line. You know, the other point I didn't point out in the talk is you cannot cure a faulty suture line reliable with a preventive mesh. This is another area we need to look at. But for the first experimental results, there is an area for improvement as well. So I think it's interesting, and I appreciate your question.
I
I have a question for Jan. Can I go?
Yes, please do.
All right. So Jan, I have this question about the South Americans in the management of loss of domain hernias. And we do know that they have their own unique terminology. And one of the terms that has been traditionally used is catastrophic eventrations. And one of the people who was very early in managing this surgically was Alfonso Albanese. So one thing I want to know, and I know that you have been aware of his contributions long before anybody else, are what exactly did Albanese do, and are his teachings still followed?
Well, in South America, of course, in Spain too, because his name is Albanese, and he published his way of anterior component separation in 1946. And you remember, I sent you the drawings. Actually, Ramirez did not copy all. He just used a part of it. You know, the technique of Albanese implies a long tail of external oblique, which is in the end sutured to the short tail of internal oblique. And that gives a distance. Well, you gain distance, but you have more stability on that. And the second adding to that was a Carbonyl Tati's technique of using an onlay mesh in that situation. And this is something that in South America is, many surgeons are very familiar with this. And since they started now using Botox too, so one of their publications recently, about 40 patients with hernias over, if I'm right, 12 centimeters, none of them needed component separation. And they are familiar with component separations. So it seems like it would be something more to add to this. And since they communicate, and I believe that they are online now, because I informed Juan Carlos Bayagosia, who's from Mexico, who is one of the protagonists of the hernia surgery in that continent. So they are probably participating. Maybe we will hear something from them, from their sides.
Thank you.
Can I have one little comment? if I may, I am. All of you have spoken about the potential solutions. Just missing a little bit, and I understand I'm very biased now after spending a year with Andrew. Nobody has mentioned the peritoneal flap repair. What are your views about it? Friedrich, I would like to ask you, have you ever measured the stiffness of the peritoneal sac? Do you think it's really as thin as the peritoneum, or is it actually a higher quality tissue? And the others, do you still believe it's bridging even after seeing all the lectures about it and seeing the excellent results? Do you think that's actually a way how to avoid or how to solve part of the issue?
Yes, I mentioned it in my clinical slide. I find it a very valuable technique to avoid sandwich repair. And we did not measure stiffness, but from the clinical approach, I think there is some variation in it. And you have to consider it as a good tissue for ingrowth of fibroblasts, because the fibroblasts in it have been trained, so to say, to create the hernia sac during the production of the hernia in the first place. So I think this is valuable tissue. It's been applied with good success in clinical practice, and it's a good technique. If I would have had more time, I could have pointed this out in more detail, but since I've been biomechanical and not so much clinical in this talk, we put it just in this one slide, transversus abdominis release for creation of space or peritoneal flap repair. These are the two approaches to avoid sandwich repairs. Thank you very much.
Barbara, you're a star disciple of the technique. I'm just conscious of time, Ram, and I think we should maybe wrap this up and move on to the next session. So thank you very much to the speakers in this session. Thank you to my co-chairs of Barbara and Roshi. We really appreciate all your input, and there is a talk to follow on the peritoneal flap, but it's not the only way to fix hernias, but it's the only way that I can fix them. Ladies and gentlemen, Ram, once again, you're an absolute star. Let's move on to the next session.
Thank you very much. I'd like to call upon Dr. Prem Kumar Balachandran to introduce the moderators for the next session, please. Thank you.
Greetings to everyone. I'm Dr. Prem Kumar Balachandran from Chennai, India. It gives me a great pleasure to coordinate this next session. This session will be on pre-operative considerations, and I have great pleasure in inviting the chairpersons, Dr. Luciana from Brazil, Dr. Rodrigo from Brazil, and Dr. Ken Loy from Australia. I request the chairpersons to please go ahead with the proceedings.
Hello, everyone. Good morning from Brazil. Hello, Luciana. Hello, Ken Loy.
Good evening from Sydney.
Thanks, Ramana, for the invitation. This is really amazing.
Hello.
You're the man. Hey, Lu.
Hello. Tudo bem?
Hello, tudo bem? Okay, I think we can start. The first speaker of this session will be Professor John Fisher from Philadelphia, US, and he will talk about CT considerations. And then we will have the comments of the expert, Professor Eric Pauli from Hershey. John Fisher, it's all with you, my friend. Thank you.
My name is John Fisher, and I'm an associate professor of surgery and a plastic surgeon at the University. Hi, my name is John Fisher, and I am a plastic surgeon and an associate professor of surgery at the University of Pennsylvania. It's an incredible privilege and honor to be speaking at the Loss of Domain Global Summit 2021. And it's a privilege to be speaking about imaging and loss of domain hernias. Is it just about volumes? These are my disclosures. Of course, we don't have a great consensus definition for the complex surgical issue of loss of domain. And because of that, there have been many postulated factors that have been used to describe what represents loss of domain. And they're summarized in this terrific review by Parker and colleagues. The best definition that we have is summarized here, which is the result of an international Delphi consensus of expert surgeons that indicates that loss of domain is a ventral hernia large enough such that simple reduction in its contents and primary fascial closure either cannot be achieved without additional reconstructive techniques or cannot be achieved without significant risk of complications due to the raised intra-abdominal pressure. I think that this definition really does an excellent job capturing the important concepts related to why the measurement and quantification of features in loss of domain is so important, because the need for reconstructive techniques and also the risk of complications really, I think, surrounds the issue of loss of domain, because the question boils down to, can we successfully close them, improve quality of life, and avoid significant morbidity? And we'll talk through some of the pathophysiology of incisional hernia and why it's a lot to do with volume, but not just about volume. So many of these patients who I've treated over the years, these are loss of domain patients, certainly not all of them. Many of them are just big hernias, but they come in different sizes and shapes. And what's really important, I think, is there's a lot of differences across these defects with respect to the size of the hernia sac and the contents, the structural characteristics of the abdominal wall, the amount of abdominal wall retraction and fibrosis and stiffness. So it's not a one size fits all for repair, and it's probably not a one size fits all for really what clinically matters with respect to hernia, because I've had great success in compliant abdominal walls with massive loss of domain. And we've had smaller defects that are really rigid, and we've had challenges closing these folks. And so I think we have to think about this across multiple different dimensions. And CT imaging certainly is a cornerstone in abdominal wall reconstruction for identifying, quantifying, and integrating those morphometric relationships, with respect to the abdominal wall, its contents, the volume, the relationships with respect to the rectus width, the size of the oblique muscles. A lot of these things really kind of give us important data points with respect to what we're going to need to do, the need for advanced techniques, and the potential for the risk of perioperative complications. And here's 4 different patients with different disease states, all with some form of loss of domain. And so we'll kind of talk through each of these types of scenarios where we have big defects but compliant abdominal walls, moderate sized defects with other unique challenging factors, including intra-abdominal obesity and how that factors in, as well as fibrosed abdominal walls. So the key questions which we've already articulated is, can I fix this? Can I close this? Do I need a release? And will my patient experience a complication? And imaging, as we're going to see, can really help answer some of these questions. And we've got some great emerging literature on this topic that really, I think, has been driven by the need to understand loss of domain outcomes for patients. So quantitative volumetric image-based thresholds for clinically significant loss of domain really focus around that 20% number. And again, there's lots of different types of definitions, and we'll talk about Tanaka versus Saba definitions. And then we'll talk about different approaches for measurement, linear measurement versus computational cross-sectional surface area measurements, even 3-dimensional reconstructions. Then we'll go all the way back to kind of simplified linear measurement tools that have great applications in practice. But the consensus seems to be around 20% based upon the literature. What does that mean? We got to talk about an important set of definitions. This is the classic article on peritoneal volume is predictive of tension-free fascial closure, Saba and colleagues. TPV, total peritoneal volume, abdominal compartment volume, and hernia sac volume. When we talk about the Tanaka method, we're talking traditionally about linear measurements of the hernia sac and the abdominal cavity, and then computing using a simple formula the relationships. The Saba method is a computational method that volumetrically characterizes the hernia sac volume relative to the total peritoneal volume. Tanaka, a little more practical. Saba, probably a little bit more representative of reality, in the sense that the Saba method is always below 100%, whereas Tanaka, you certainly with large hernias can go above 100% loss of domain. And so I think that we have to just recognize the two definitions here, but also we'll talk about some of the computational aspects that kind of play into these kind of calculations and these equations. Of course, the importance being here is that the prediction of tension-free closure had very much everything to do with whether or not the loss of domain measurement was present or not. That is, if it was not a loss of domain, tremendously high odds ratio predictive of tension-free closure. The converse being, if there's significant loss of domain, more than 20%, hernia sac volume over total peritoneal volume, lower probability of tension-free closure. And again, I think that that's really what's important. The two methods we just discussed, I went through this. Tanaka, typically based on linear measurements and an ellipsoid formula, and typically measuring that hernia volume over the abdominal content volume. Saba is based upon areas slice by slice, software determined, a little more labor intensive, but still nonetheless very, very important and interesting. The literature is emerging with more and more types of approaches. This is an example of a recent article published in Hernia from 2020, a terrific article by Martra and colleagues showing the use of three-dimensional computational software analysis that calculates intraperitoneal volume and intrahernia volumes. Can be done by the surgeon alone, doesn't necessitate slice-by-slice counting. I think very, very interesting for potential applications in practice. Another interesting article that I think is a very clever article showing a nice correlation between simple surface area and volume computations that can be done rapidly and within a traditional two-dimensional CT without having to do any extravagant 3D reconstructions. This article by Al Mansour shows a great correlation between some of the kind of pioneering ellipsoid formula work by Tanaka and some of the more refined, complicated three-dimensional reconstructions that have been done. So I think it's very encouraging, and this type of kind of pioneering work suggests that ultimately, and for practical reasons, we'll hopefully be able to get to a simple set of routine cardinal measurements that correlate well with the complex volumetric calculations. Or alternatively, maybe we'll get to a very simplified solution that can automate three-dimensional calculations that are clinically relevant. This just summarizes that, but I think what's important is to recognize the different ways to calculate it. But fundamentally, what really matters is the relationship between what's being measured and what is happening to the patient and the outcomes that are achieved through that. So I think as I go through the rest of this talk, we're going to really talk about the patient's health conditions and some of the other important aspects of the abdominal wall-like compliance. So spoiler alert, the CT scan isn't everything, nor is a volumetric measurement. Of course, these CT scans are done typically statically, and it's an isolated measurement in a supine abdominal wall, and it doesn't really communicate to you anything about the patient's underlying health conditions, and it really doesn't tell too much about compliance. What I think is more important to appreciate really is this complex set of interactions that happens when you operate on a patient with their underlying health and the perioperative physiology that is created as a direct result of your repair relative to the defect size, the abdominal wall compliance, and the surgical maneuvers that are used. And these surgical maneuvers can include mechanical releases. They can even include preoperative chemodenervation. And we'll talk about what happens with respect to the key morphometric features when we do these things. And so it becomes a dynamic thing in which the abdominal wall and potentially its volume and compliance and its morphometric characteristics may be changing both before surgery with chemical components and then intraoperatively and in the early postoperative period with mechanical component separation. We have to recognize, I think, some of the pioneering work and also the physiology of hernia, which we know in chronically unloaded skeletal muscles becomes fibrotic, reducing compliance. And so for these big defects or these chronically present hernias, we have altered abdominal wall compliance, which just means that the abdominal wall is going to become tighter and the pressure is going to go up for every amount of volume that we change it. So very, very important to recognize. What's most interesting is work like this, classic work by Greg Dumanian and colleagues, that shows that loss of domain patients, just as the simplified figure shows and the really, really nicely done pre and post-operative CAT scans and the functional respiratory measurements show that in loss of domain patients undergoing mechanical component separation, the release allows for increased total abdominal volume, so abdominal wall expansion, minimal change in the structural position of the diaphragm, and no changes in key respiratory parameters, specifically the FEV1, the forced expiratory vital capacity. So these really, I think, are important because the external oblique and perhaps the TAR represent effective extrinsic tools that we can use to quantifiably and significantly alter the volumetric features of the abdominal wall and perhaps make it more compliant. Here's a great case in which we used both preoperative chemodenervation to lengthen the abdominal wall and then aggressive mechanical component separations to volumetrically expand the abdominal wall. And then we also used preoperative weight loss to reduce intraperitoneal contents. Again, all these things working in different dimensions, in different ways to potentially avoid complications, achieve tension-free primary fascial closure. And fortunately and luckily, in this particular case, we were able to achieve that. Another case example where it didn't work out that way, 43 plus centimeter wide defect, trauma abdomen, massive loss of domain, highly fibrotic abdominal wall, weight loss, chemical component separations, perhaps the world's most aggressive mechanical external oblique release down to the table, taken apart in its entirety, did get the fascia closed, that's for sure. And we got a piece of mesh on, but unacceptable intraoperative physiology with a rising lactate, perhaps as a result of complete or temporary occlusion of the vena cava, resulting also in altered respiratory mechanics and clinical instability. Thankfully, we recognized this, took it apart, let the patient cool off, did a bridging repair at about a week, and he's alive and with us. But again, an example of sometimes the physiology and the patient's health conditions really, I think, are the most important considerations. So let's talk about this because I think those pulmonary complications can be devastating, and we can't operate on the abdominal wall or, of course, not a loss of domain defect without thinking about the respiratory mechanics and physiology, because the abdominal wall does indeed include the diaphragm. And so this article by Mammers and colleagues highlights the fact that in multivariate logistic regression, the hernia volume really, I think, is predictive of the potential for postoperative respiratory complications. So very, very important, the interplay and the dynamic nature of the abdominal wall and the impact on respiratory physiology. Another article that I think really underscores why it's so important to think about not just volume, but morphometric features. This terrific article by Cobb and colleagues shows that CT imaging can help aid in understanding who may benefit from a release. And it's the relationships between the defect and the size of the rectus and other things that help us understand who may need a release. And I think that this article doesn't relate particularly to loss of domain, but what I think is that these relationships, volume relationships, length relationships in the abdominal wall speak to the feasibility and the tolerability of a reconstruction. And so I think that they have to be applied in a similar way in loss of domain. And I'm thinking that in the future, they will be. So a terrific article from Todd Henneford's group looking at CT measurements to predict component separation in a similar way, but then taking into consideration an advanced technique called principal component analysis, where a blend of factors is thrown into the analysis. Really cool study in which they're able to predict not just wound complications and the need for component separation, but also recurrence, characterizing structural features, adipose features, patient health conditions. They found some really terrific stuff. They found that width, length, and area were associated with morbidity and the need for a release. And they found that the need for release occurred at specific areas and width. So very, very important. So I think this is probably where we're going to have to go with loss of domain, in particular, because it's not just the size of the defect, it's the size of the defect in the particular patient that it's being repaired in, and that has an influence on the outcomes that we care about. Another great article from the literature published in Hernia 2019, showing that, again, complications and need for component separations, very tricky business. Visceral fat volume was associated with reherniation. Hernia sac and sub-Q volume were associated with SSI. So a lot of information inside these CAT scans that we have to be thinking about. And so ultimately, I think the way we bring this all together, I think is going to have to be consideration of not just the volumes, but the patient health conditions. And I think that, applying techniques like were used in this article, again, from the Carolinas group and Todd Henneford's lab, showing that integration of multiple components to measure and characterize and predict outcomes is probably the direction that most of our work in loss of domain should go, because it's not just solely about volume. So in summary, I think CAT scan imaging is so important in abdominal wall reconstruction because it contains so much useful information, both for surgical planning and prognostic indicators of complexity and surgical outcomes. We've seen in the literature, soft tissue can predict SSI, key defect features are associated with morbidity, and key volumetric and length ratios like SABA and the Cobb and Carbonell data on rectus diameters have an impact on the ability to close and release. And so it is a lot about volume, but it's just not only about volume, it's about the relationships between volume and the abdominal wall structural features. I think ultimately blending risk factors, those volumetric features, the relationships between them, and also the patient health conditions, as was done in some of the work by Henneford's group, is going to be really important in predicting outcomes in loss of domain defects. Cross-sectional imaging, really critical because it's going to help us integrate data into our operations and help us understand what type of level of technical complexity will be needed and predict clinical outcomes. And lastly, nothing ever seems to be about just one thing. And I don't think that loss of domain is just about volume. I think the clinical relevance of loss of domain pertains to safety and efficacy of the repair. And this, in my opinion, my humble opinion, relates fundamentally to the patient's health status, the key morphometric features of the defect and the abdominal wall, and secondarily, the extrinsic maneuvers, both before surgery, like chemical component separations, and during surgery, perhaps like mechanical external oblique release, that can alter this volumetric anatomy. And thus, volume is a lot to do with a loss of domain, but it's not just about volume. Thank you.
Great talk. I think we should move on to our next speaker, Dr. from Qatar. I think we have now, as John has mentioned, that CT is not the everything. So now we're going to look at the fragility scores and assessment of patients. So at the end of the day, it's patients that matters. So we can start the talk. I don't think we need to introduce this guy now.
No, I think Eric Palai needs to comment on John's talk. I'll go after that.
Yeah, I'm happy to do that, guys. First off, thanks for having me, John. As always, an awesome talk. You know, I think that in many ways, John characterized a lot of the things that I think about when I'm looking at CT scans and backed it up with a lot of hard data. You know, there are a lot of things that are seen on CT scan imaging when he and I and others are looking at these images that are not related to simple volumetric measures. And there are things that we haven't been able to figure out ways to calculate and automate yet. We look at the visual evidence of compliance of the lateral abdominal wall. And I think that surgeons have a good understanding of how to look at a CT scan and get a sense of whether it may or may not close. And I think that in general, we're pretty good at knowing whether the technique that we're going to apply to a patient is going to work. But as John showed you in that case with the very large loss of domain hernia after trauma, sometimes we get it wrong despite all of our experience. And I think that, as John pointed out, that understanding that connection between the volume relationship and allowing 3D calculations to be made that can then reliably predict our ability to use an external oblique release, a transversus release, a peritoneal flap herniaplasty, to tell us which option is going to be the best for that patient to give them the best outcome is very helpful, because there are times where we apply a technique in the operating room and we don't know that we're going to fail in our technique until we've already done the separation. And I think the goal would be to avoid that problem as we move forward. So kudos to John for summarizing kind of the current state. And I applaud everybody who is on that list of citations, in particular, as we move from a relatively straightforward Tanaka calculation to something that is 3D, automated, and predictive, like Dr. Henneford and Dr. Augenstein are doing with their patients. So thanks once again for having me.
Yeah, sorry, Eric, we didn't nearly get you to talk, but you're going to appear again later anyway. So without ado, I think Ram is a superstar here. So I don't think we need to introduce him. So you're going to tell us about the fragility score of the patient. How do you come up with that, Ram? Tell us.
All right, I need to share my screen. All right. Okay, let me know that you can see my slides moving, and I just need to know that you can see it moving, and then I'm good to go.
It's going well.
Thank you.
It's fine. Yeah.
So, ladies and gentlemen, this is a very common admonition from old professors that I have come across, that you guys shouldn't do fancy procedures and let patients die. A hernia is a hole, you just patch it or plug it, and that's it. It's a simple operation. Now, I could quote Nassim Taleb and say that no, the human body is a complex system, and we deal with complex patients and complex hernias, and there are lots of things that are not really mathematical and predictable. But instead, I would just simply say that, sometimes you got to take risks to do the big things, to do something worthwhile. So, ladies and gentlemen, we have to answer some questions about the risk aspect of hernia surgery. So what are the most important of these? Who are our patients who are at risk? Can we predict those risks? Can we reduce the risks? And lastly, having done all this, can we improve the outcomes? Now, let's have a bird's eye view of how risky major surgeries are. And I refer to this article by Billy Moria on JAMA, where various major procedures are listed, and there is a head-to-head comparison showing that there is a significant number of AWR complications that puts even pancreatic surgery to shame. So clearly, we are looking at serious stuff, and our patients are even coming back for readmission, and around 4.5% of these patients have been readmitted for various reasons. So what are those reasons? So this gives an idea about the complications. The commonest complications are this surgical site infections, ileus, and bleeding. So these have been the commonest reasons for readmission in these surgical patients. Now, this is a question that I'm going to keep asking repeatedly. Can we predict the risks? Ultimately, everything depends on that and how you talk to your individual patient. So if we look at the commonest reason for readmission, which is surgical site infection, when we are putting in a prosthesis, we are afraid of the mesh getting infected. But if we look at one of the biggest group in this category of our patients, the diabetics, let's look at the infections in diabetics. Control is everything. If your control is not good, this number of infections are going to be double. Now, the Henneford group has quantified the effect of diabetes from 2 national registries, and they have studied only diabetics and compared open and lap ventral hernia repairs. And the findings are kind of startling. When it comes to laparoscopic, there was no difference. Open, the complex procedures, longer times, worse outcomes. Diabetics were older, women, and they had greater complications. So far, not really shocking. But if you look at the numbers in terms of the diabetics, they had a 12% recurrence after VHR. There was a $100,000 extra cost because of mesh infections. And they were 64% more likely to die after ventral hernia repair. So talking of death, once again, if you're a diabetic, there is a considerable chance of death after ventral hernia repair, especially open. And of course, complicated hernias are more likely. Now, this is a study which examined 100,000 hernia surgery patients and explored mesh explantation in the longer term. So what are the things about mesh explantation that we have learned? 1.5% of the cases needed mesh explantation. Staph aureus was the commonest organism, and open operation has 4 times the greater risk of mesh explantation, and the usual suspects, obesity, 30-day infections, smokers, all had greater chance of mesh explantation, and emergency operations had a greater risk of those explantations. Now let's move on from the wound to respiratory system. And we know that respiratory complications in loss of domain or complex hernias is a very, very important cause of morbidity and mortality. So Sal Dacimo and Aurora Pryor, that group has published on this, on who are these patients following AWR who have prolonged intubation, which is a reflection of respiratory complications. So higher ASA groups for sure, severely obese patients, active smokers, and those with a history of COPD. Pretty much plain vanilla. We would have predicted this without any study, but that's it. This is what we know. I'm sorry, I'll just show once more that respiratory failure, therefore, increased costs, length of stay, and mortality, but this study did not really examine the hernia characteristics. So overall, this is from Jeff Blatnick and Mike Rosen's study. 20% of AWR patients had respiratory complications. And after TAR, if the airway plate-to pressure after closure is over 6 centimeters of water, the incidence of respiratory complications is 9 times higher. And if it is over 9, it is 12 times higher. So this is clearly a very, very significant statement from that study. Now, when it comes to the same study, they had an average of 400 square centimeters as the defect area, not the defect size, but the defect area. And clearly, they're not talking of your 5 centimeter umbilical hernias with a large sac. They are talking of the most complex operations that are done on the most complex hernia defects. Once again, can we predict the risks? Now, the Hanniford group has come up with a landmark paper on the CEDAR, which is basically now an app which you can download on your iPhone or your Android phone. So the CEDAR app takes you through starting from your age and BMI and gender. Then it asks you whether there's going to be a contamination of the GI tract, whether the patient has a previous hernia, and whether you're doing skin flap surgery, whether there's diabetes, smoking status, etc., etc. And then it gives you a quantification of the risk of complications and the cost involved in those complications. So this is a validated application and it is widely used. So who are our patients who are at most risk? And can we really do anything about them? Can our patients be optimized? Sean Orenstein is waiting to go in after me, and I will let him do the honors on that. But what are the high-risk markers? If you have had a previous infection, then the chance of your hernia surgery getting infected are significantly higher. We've already talked of diabetics. Obviously, contaminated sites, hernias, probably an independent prognostic marker which affects all patients of all sizes. Immunosuppressed patients, especially transplant candidates, they all have liability of complications. Low albumin is the king of immunological and nutritional markers in terms of outcomes. Again, the obese patient is a separate subject to be dealt with by Dr. Roth. And we have others like sarcopenia, previous hernia surgery, smoking status, and interestingly, old age and high volume centers. So high volume centers tend to have more complications, clearly a reflection of more complex patients and more complex defects being treated. Additionally, we have three more that we need to mention. Outcomes in emergency surgery are worse. If there is liver disease and ascites, it's worse. So those surgeons who are very happy to operate on those cirrhotics with those umbilical hernia stents with ascites, please be cautious. And those patients who have given instructions of do not resuscitate have worse outcomes. Now let's talk about sarcopenia. Sarcopenia basically means something, and we will discuss that in a moment. So sarcopenia is interesting in the sense that the data is all over the place. According to some studies, there is a significantly higher risk of SSOs as well as recurrence. But the Henneford group, this is Katie Schlosser's study, they have done a separate analysis, computerized analysis, and they found no increase in complications, including recurrence. But again, other studies have found greater chances of recurrence. So sarcopenia is something which is estimated by the means of CT scan, by the psoas volume and the area involved, but it has certain problems. It is defined as a loss of muscle mass as well as function. It's not just about the muscle mass, it's also about the functionality. There are issues with the measurement. Where do you measure it? At L3 or L4, etc. You need expensive equipment. And so at this point of time, it's not really fully settled. There is disagreement on its implications, which takes me to my topic of frailty. And this is a very, very important concept for the surgeon dealing with loss of domain or for any surgery for that matter. We typically associate frailty with aging, but is it really that? Or they just look similar from a distance, but are completely different? If you look at the literature, it is clear now that frailty is a predictor of outcomes which is far superior to aging. So you may have an elderly patient who has a good quality of functional existence, who is probably not at a higher risk for complications, but a frail patient who is not as old as that may have worse outcomes. So this is one of the most important things for a surgeon to understand what frailty is. It's basically a state of vulnerability which puts you at risk for adverse outcomes. So essentially, if you become vulnerable and you fall victim to that stress, you become disabled. So it is an important consideration. If you fail the test that life puts you through when you're frail, you're going to end up in a really bad state. Frailty is not the same as patients with seniority. In younger patients, obesity, sarcopenic obesity are very, very important considerations, especially in the developed countries. In fact, in many, many countries, not just America or Mexico. Now, how do you recognize and assess a frail patient? This is such an important question. It's all good to know about what frailty is, but assessment may be by one of two methods. One is the physical method. So you basically ask the patient whether the patient has lost 10 pounds in the last 1 year. The patient feels exhausted. The patient doesn't do anything outside of going to the toilet or something. Patient walks very, very slowly, shuffling, and the patient doesn't have a grip. So this is the phenotypic or physical way of assessing a frail patient. There is another way of assessing the patient, which is basically checking on what are the functional deficiencies of the patient. So if the patient has 5 or more comorbidities like diabetes and heart disease and stroke and so on and so forth, so that is one separate thing. And the patient has Alzheimer's or is depressed, that is another thing. And the functional status is probably one of the most important considerations when we prognosticate and assess a patient needing major surgery. So the Canadians have done a lot of work on geriatrics, and they've come up with a frailty index, which has so many variables. So it's like a binary. It's either 1 or 0 according to each symptom, sign, or test. And they total the number and then divide it by the total number of tests. So it gives you a frailty index. All right. Now, I know that you're kind of getting puzzled at what this is supposed to mean. Don't worry, because the frailty index is validated, but it is not practical. Who has the time to check 70 variables, right? So what we have come up with is a 5-factor modified frailty index, which gives you the same equivalency in outcomes. So you check on the functional status, diabetes, history of congestive heart failure, COPD, and hypertension requiring medications. That's it. Just 5 factors, and you estimate the frailty with the same degree of accuracy. Now, coming back to the question of how you recognize or assess frailty, this matter is not solved. You can do simple bedside or office tests like we have here. So you can ask the patient to walk for a few steps and assess the time needed to walk, say, 6 meters, or you just do a squat test and see how the patient is sitting down and up. So the modified Hopkins score is another frailty assessment, which includes the ASA score, the grip strength, hemoglobin, and documents the weight loss. So this is a pretty popular way of assessing frailty, though it is not AWR specific. This is a general frailty assessment. Now, as I said, this story is not over. You can do risk assessment through multivariate analysis. So you have things like Apache or ASA grading. So these assess multiple qualities or parameters in the patient. And as you can see from this slide, there are too many of them to make any sense to us all. Okay, so you may know the ASA grade, but probably most people wouldn't know the others, and it's probably not feasible to remember all of them. An interesting multivariate risk assessment system is a surgeon's expert opinion. So this is something I will mention once more. And there is a risk assessment using only one variable. So for example, you say that this patient has frailty, or this patient has sarcopenia, or this patient is obese, or this patient is an alcoholic. So this is worse outcomes. That is a very, very simple and reproducible way of assessing a patient before surgery, right? So grip strength is another very popular one. The thing is, in terms of assessing these things, the univariate, which is one variable, that is easy, but it's likely to give you the wrong conclusions. And the multivariate is likely to be accurate, but it's more tedious, and practically most people wouldn't do it. So I think the multivariate assessment by a senior, experienced, and wise surgeon is an absolute blessing to have in a given situation. But in the absence of those situations, these scoring systems and apps are a good way of assessing and trying to prognosticate given patients. So to come back to our professor's admonition that no hernia patient should die, I would now come to the numbers. And if you see this study where open ventral hernia surgeries, more than 55,000 patients were assessed and risk stratification was done. The low risk patients, only 0.3 died, moderate risk 1.8, high risk 8.76. That's not all. the extreme risk patients, 34%, 1/3 of those patients died. So ladies and gentlemen, it's important for us to identify the patients who are at extreme risk and avoid operating on them or counsel them appropriately before taking up these patients. So when somebody says that hernia surgery is simple and you shouldn't have mortalities, again, one can only laugh and crack a joke maybe at the end of it. We are in very, very serious business, but sometimes all we can do is smile, shrug, and move on. Thank you very much for your attention, ladies and gentlemen.
Thanks, Professor Romano, for the always amazing presentation. There are two questions for you before we continue. There's a question from the audience. Has you used CPEX testing as a means to see what patients will fare better post-operatively or not, or actually assesses them to be too unfit to undergo loss of domain reconstruction?
I'm sorry, I just didn't get that.
Do you use a cardiopulmonary test as a means to see what patients will fare better post-operatively?
Yes, absolutely. Because one of the important considerations is the ASA grading, and every patient should be assessed thoroughly from both. All the organ systems should definitely be assessed thoroughly.
Okay. They're too noisy. Okay. And there's a question for our friend Eric Paulai. Does anyone know how I can get my patients to be more frail? That more than 10 libra of weight loss in a year before surgery sounds great. The thing.
I mean, you know, Ramana, on some level, I mean, we try to get these folks to lose weight intentionally, right? And so now you're telling me that weight loss is a marker of frailty. And so you're going to increase their frailty score by trying to get them to lose weight. So on some level, we've got competing interests here, right?
We are talking about different patients, of course.
10 libra is too much. It's hard to reach that. Okay, we have a time now to have some comments by our expert, Anthony Bonavia from Penn State, Hershey. Anthony?
Hi, everyone. Thanks for having me. Ram, that was an excellent talk. So I'm an anesthesiologist and an intensivist. So, you know, in the pre-op clinic, definitely we should have a more robust frailty assessment. The problem is that often it hasn't been operationalized. There's a lot of frailty indices, as you correctly pointed out, and also there's the time constraints. But really, as you pointed out, it is probably the most important assessment is the frailty assessment, because these patients don't usually die in the first month. They usually die in the first year. And as you gave very sobering numbers, 30 to 40% of frail patients die in the first year. And those that don't have, you know, worsening in their clinical frailty score. The question is really what to do about it. So, you know, the assessment has value when talking to patients and considering, as you correctly said, should they have surgery at all? But the other question that comes with any risk assessment is what can you do about it? And there's a certain amount of non-modifiable risk factors, for example, cognitive deficits that you can't really do much about. You can use it to gauge risk, but not do much about it. Probably the thing that you can modify is optimizing their nutrition and prehabilitation, making them stronger. But again, you know, as Eric alluded to too, you have to have a cooperative patient, and you have to have the luxury of time to be able to improve that nutritional status, and strength takes, as you know, weeks to months to fix. So it's a really challenging problem to deal with. But I think, as you correctly pointed out, first we have to operationalize it, have a frailty assessment, and do it routinely and consistently.
Thanks. Yeah. And for the rest, Sean is definitely going to deal with this, I think, better than most of us would have or could imagine.
Thank you. Now I'd like to invite Sean Restein from Portland. to talk to us about preoperative optimization. Welcome.
Good day from Portland, Oregon. I'd like to thank you for the opportunity to speak with you about preoperative optimization. Here's my disclosure slide, none of which is relevant for this particular talk. You know, when we talk about ventral hernia repair, some of these numbers are quite staggering. Talking about midline laparotomies resulting in up to 1/3 or more in ventral incisional hernias. Over 500,000 ventral hernias are repaired every year in the U.S., and the hernia recurrence rates are all over the map, from the low single digits up to almost 1/3 or half of hernia repairs result in subsequent recurrences. And that doesn't even take into account all the peri and postoperative complications like SSI, reoperations, and readmissions. Not only is there the burden on the surgeons, on the patients in the healthcare system, but there's quite a financial burden as well. Looking at Ben Poulos' data showing the staggering figures of over $3 billion spent every single year on the US alone. And this is some older data, so it's only higher from there. And that doesn't even include loss of work as well as disability. And it's estimated that we could save over $30 million every year just for every 1% reduction in ventral hernia repairs every single year, whether that be with decreased recurrences, patient selection, as well as optimizing our patients. One of the things we really want to avoid is this hernia vicious cycle. And this is a great paper, set of papers written by my partner, Bob Martindale, as well as Scott Roth, another one of the faculty speaking today. And this is basically somebody gets their hernia repair. Some of them are going to develop a surgical site infection. That SSI leads to readmission. That SSI, with all the enzymatic breakdown and metalloproteases, breaks down the fascia, leads to a hernia recurrence. Later on, that patient gets another hernia recurrent, another reoperation, their ventral hernia repair. They develop another SSI, another hernia repair, and so forth, this ongoing cycle of complications and multiple repairs. So the big question is, how can we stop this vicious cycle from happening in the first place? And one of the best ways to do that is by going through a set of motions to get this patient in the best repair they can. The main things that I'm going to be focusing on for navigating complex ventral hernia repair and abdominal wall reconstruction is optimizing that patient, having the right patient, the right timing. Other speakers are going to speak to the right operation as well as managing mesh. So when it comes to pre-op optimization, there's 4 main pillars of it, 3 of which I think many of us know, but perhaps prehabilitation is something that doesn't get spoken about that much. The 3 main ones, though, are weight loss, smoking cessation, and diabetes management. And again, as I already mentioned, prehabilitation, which we'll talk about at the end. That's not to say there aren't other important factors, things like dealing with chronic infection, debilitated patients, as well as a host of comorbidities to manage. The first question is, so that's great, who does get formal preoperative optimization? Well, ideally everybody gets optimized, but we especially have to focus on high-risk individuals. People that are actively smoking, or perhaps they have an active wound infection, loss of abdominal domain, which is a large hernia with a good portion of their abdominal viscera outside the abdominal wall, which adds to the complexity of any hernia repair. Multi-recurrent hernias, as well as malnourished patients. The other thing is if there's a need for open ventral hernia repair, especially abdominal wall reconstruction. And I emphasize this because patients that are eligible for a minimally invasive approach, or perhaps for smaller, simpler hernias, they don't have the burden and the degree of dissection and wound healing. And so optimizing those patients aren't going to see as big of a benefits for that as opposed to somebody undergoing an open abdominal wall reconstructive procedure. Well, first thing is smoking. Smoking, data is pretty clear that it increases surgical site infection rate. Where it gets a little hazy is what is that? Is that really truly translate to hernia complications? There is good data to support hernia recurrence and SSI worsening with smoking. That said, there is some mixed data and some early data that is clouding that picture. That said, Sorensen is one of the world's leading experts on smoking, and his data on wound healing is quite robust, showing that a minimum of 4 weeks of abstinence prior to any elective repair is crucial. Now, with regards to how to get somebody to stop smoking, nicotine replacement therapy, whether it be gum, lozenge, or patches. Those can be effective on getting patients to stop tobacco products. And his data also shows that it does not worsen or increase the risk of wound complications. So in our practice, where we actively allow our patients to use nicotine replacement therapy and do not believe it's the nicotine that is the primary culprit in wound complications with smoking. Obesity is a well-known problem, especially in the United States. I love looking at these heat maps from the CDC, looking at over the decades, looking at those color changes throughout the United States. In fact, it's gotten so out of hand, they had to come up with a whole new color scheme to document obesity in the United States. And it's quite staggering looking at these numbers over the last decade, with 2019 being the last bit of numbers shown in the CDC data. The lowest place in the United States is my home state where I grew up in Colorado, just under 24%, but that's still quite staggering that up to almost a quarter of the patients there have reached the level of obesity, tied with Washington, D.C., versus the highest state in the country, which is over 40% of patients with a BMI greater than 30. But not to fret, we're not alone in the world. Their obesity is a global problem, with obesity rates rising throughout the entire world. And I wanted to highlight something pretty interesting. I went through as many of the countries as I could get to get the data to show this is a ranking of our faculty and the countries that we all come from, looking at that. And of course, you see US for men leading the charge with the most obese patient population out of our group of people. So this first table is it's organized and ranked by men, whereas the second table is ranked by women. And looking at, for women, South Africa actually has the highest obesity rate of the faculty of their respective countries. But really, the really important parts is looking at the bottom of that table, where the lowest obesity rates are. And hats off to our colleagues in India, having the lowest obesity rate for men in their country. And when we look at women, Japan just beats India out there. So congratulations to that lower tier group of people in these tables. Why is obesity such a problem? Well, as people gain weight and they become obese, they not only gain weight on the superficial part, but many of them gain weight intra-abdominally, especially with visceral fat. That fat increases intra-abdominal pressure and puts a stress and a strain on any weak part of the abdominal wall, especially hernias or new dissected or fascial tissue, therefore leading to not only the development of primary ventral incisional hernias, but also subsequent hernia recurrences. But that adiposity also leads to metabolic problems and can lead to wound complications, surgical site infections, thromboembolic disease, readmissions, as well as pulmonary complications. And that is such an important one, especially when we're talking about loss of domain. When we take care and repair loss of domain patients, we're shoving all that viscera back inside their abdominal cavity. That increases not only intra-abdominal pressure, that's going to translate to increased intrathoracic pressure. That can lead to greater need for intubation or prolonged intubation and respiratory and pulmonary complications. So it's crucial to tackle obesity prior to elective repair. As far as which numbers, there really is no consensus on ideal BMI cutoffs. Each individual surgeon or surgical practice has their own sort of repertoire for what numbers work for them. And so that's just an individualized conversation between the surgeon and their patient, but it is crucial to delay those elective repairs for adequate and appropriate weight loss. Now, when we look at obesity and diabetes, again, another set of maps that I like to look at, and is almost identical looking at obesity and diabetes maps. That is, they go hand in hand. As you gain weight, diabetes will invariably get worse with the vast majority of those patients. Why is diabetes such a problem? Well, it's all about the microvasculature that gets affected by diabetes with all these significant wound complications. Things like wound dehiscence, surgical site infection, other delayed wound healing, not to mention other perioperative complications. Ideally, we want to get that A1C less than 7 and closer to the 6.5 mark. But it's not just the absolute value, it's also the trajectory of it. You know, somebody comes into your clinic and they have a hemoglobin A1C in the 10 to 12 range, that is definitely prohibitive from elective repair. But as you get better diabetic control, whether it be with their primary care physician or an endocrinologist, and you start to see that A1C climbing down, that's a good sign that they're getting good control and maybe on their path to booking them for their operative intervention. Another part of all this and putting this all together is the counseling. That is getting that patient in the clinic to see you and discussing and really counseling them on all these necessary steps prior to embarking on their ventral hernia repair. I pull out routinely my phone and show them with the BMI calculator where their BMI lies and set some goal weights and BMIs for them so they can have some numbers to go off of. I also use the CEDAR app. This is an easy to use free app made by the folks at Carolinas Medical Center. It's a wonderful way, an easy way, going through 8 simple questions, gives you this number at the end. And this is not an absolute number, but it's a risk calculator as another tool to help guide your decision making on whether to operate or to not operate and delay their operation. And it's nice to show some objective numbers right in front of your patient to tell them and adequately explain to them, this is why I can't operate on you now, but if we can take care of these problems, take care of your smoking, your diabetes, and your weight, which you can do right there on the app, you can see that number, that risk of complications go down, 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 showing them what optimization, how it helps them out. But what else can we do to actually improve their outcomes? Well, this is where it goes to prehabilitation, and as it sounds, it is preoperative rehabilitation. Much of the data comes from cardiothoracic literature, and there actually is very good data on this, with the major goals of improving the physical conditioning and reversing deconditioning. Many of our patients come in deconditioned, especially elderly, frail, and obese patients that perhaps aren't very ambulatory. It also helps to increase their functional reserve. There's 3 main prongs of prehabilitation: physical exercise, nutritional optimization, and psychological support. Step 1 is just to get some baseline assessment. This can be done as simply as in clinic, watch your patient walk down the hall, get them to walk up and down stairs to see how they do and time them on a timed stair climb, as well as perhaps getting them to the physical therapist for a full baseline assessment. Things like doing various endurance exercises as well as strengthening exercises. Again, if you have access to a physical therapist, this can be pretty handy, and programs range from usually about a 1 to 2 month program. So this is something that needs to be thought about ahead of time to get them prepared for down the road operation. And some of this is basic stuff. You don't need to join Gold Gym or do a P90X program to get somebody prehabilitated. This can be as simple as 6 minutes of walking or more a day, doing some basic free weights, using 2 to 5 pound little barbells, which even elderly or frail patients can do, as well as some basic resistance exercise and equipment if they have access. This is one of our flyers from our own physical therapist, and we have a well-done prehabilitation program. And I love this quote from their flyer that says, the best time to start rehabilitation for your surgery is with prehabilitation to optimize your recovery. And this one sentence just kind of summarizes everything I've been talking about so far in this talk. Is there data to support physical exercise for prehabilitation? Absolutely. There's a good deal of data out there. And I'm not going to go through every one of these studies, but to summarize, these studies are basically telling us that pre-op exercise therapy with a regimented prehabilitation program, it improves their post-op function, you reduce perioperative complications, you improve their reserve, and you can reduce length of stay. How about nutritional optimization? And this is, if there's one thing I can talk about and emphasize enough, is nutrition. Hernia repair involves a lot of wound healing, and it takes a lot of nutritional and metabolic support to support that large surface area of wound healing. It's always important to get a baseline assessment, typically with albumin and pre-albumin, so you can check that throughout their course of pre-optimization. It's helpful if we have access to a nutritionist, not only for dieting guidance, but as well as specific regimens and nutritional supplementation to help them out. A lot of what we do for our patients is recommend a various enteral supplementation. And the thing that we recommend the most is Impact AR. And there are other formulations and other manufacturers with similar things, but these are immune modulating formulas. They are high protein, but it's not just the protein. It's other things like arginine, omega-3, and other fish oil fatty acids, among other things in there. As far as TPN, I'm not going to spend really any time talking about it. TPN is typically reserved for patients with fistulas or short gut syndrome. Is there data to support these immune modulating formulas? There's actually pretty remarkable data out there. This first study on the left, we're looking at over 2,000 patients. While it didn't show any change in mortality, it did show a decrease in an SSI as well as an anastomotic leak for patients undergoing GI surgery for malignancies. And even more so than that, looking at this large study, this meta-analysis of over 7,000 patients, showed that the immune modulating formulas reduce overall complications perioperatively, SSIs, anastomotic leak, sepsis, and for the first time, a reduction in mortality with the use of this. So quite remarkable data to support these type of preoperative nutritional supplementations. And then there's psychological support. And this is something that probably gets overlooked by a lot of us. One of the goals is to reduce anxiety. You know, these patients come in, they've got many times a lot of medical problems, a lot of anxiety and apprehension of their current state as well as for this future planned surgery. But the other big thing is increasing compliance. There's a lot of stuff that goes into managing pre-op optimization, all these things we've talked about. So with the help of perhaps a psychologist or a psychiatrist, other things they can do just at home, meditation, relaxation, breathing. These things help increase their motivation and their compliance to really get them down the path and success with preoperative optimization. But there are certain challenges with optimization for these patients. First of all, it can take quite a bit of time. This is resource intense. When patients come to see me, sometimes I see them 2, sometimes even up to 5 or 6 times in my clinic, whether it be in person or doing more telephone and virtual visits, just to get them and track their progress till they achieve the goals that we've set forth. Also, resource utilization. I have the luxury of working at a large academic hospital, so I have access to nutritionists, to physical therapists, to psychologists that can help with all these tasks. But smaller community hospitals or surgeons in certain centers may not have access to this, so that can be a challenge for your patients. And then, of course, there's costs. Even things like the nutritional supplementation, the Impact AR, we have a deal through our pharmacy that we can get these to our patients for about $50 for a case of it. And this is 3 shakes a day for the 5 days leading up to surgery. And $50 still can be cost prohibitive, but if you go online, these things are costing $80 to $120. So it can be a cost and a burden to the patients. Things like nicotine replacement therapy also have a cost, as well as various equipment to help them with their prehabilitation. So to summarize, ventral hernia repair is quite costly to the healthcare system, especially in the United States. Preoperative optimization really is crucial for optimized outcomes for our patients. Prehabilitation, it really requires a multidisciplinary pre-op program that decreases complication rate as well as reduced length of stay. But the bottom line is all of these taken together can really benefit our patients and greatly improve our outcomes. And decreased cost of care is another added benefit that is downstream from all this. With that, I'd like to thank you for your time, and I'm looking forward to the rest of the conference. Thank you.
Thanks, Sean, for the presentation. We are on time. I think we need to keep going. The next part will be unique clinical scenarios. And I want to introduce our 2 moderators now. Heather Bogart from Cape Town, South Africa, and Walter Brunner from St. Gallen, Switzerland. Nice to meet you too. And please, you can take your time and introduce the panelists.
Well, thank you so much. It's Heather Bogart here, and I really want to thank Sean for putting us on the map. Thanks a lot, Sean, for giving us some notoriety. Well, I can't switch on my video, but I assure you that I don't represent the rest of the population. We're going to have some fun now. We're going to do some show and tell. We have some colleagues from around the world that are going to do some clinical scenarios, and so we're going to kick off with my friends in the other part of the south, and that is in Oz. So we've got Rod Jacobs here. Are you ready to start your presentation?
Yeah, it's pre-recorded, so if the text can take it away.
Great, thank you.
Good evening and welcome to Melbourne, Australia. First, I'd like to thank the organisers for the opportunity to contribute to this global summit. My name is Rod Jacobs and these are my disclosures. In ventral hernia repair, we aim to create a functional abdominal wall, ideally with restoration of the linea alba. This requires native tissues to be available and can be quite a challenge in patients with loss of domain. So in addition to the usual preoperative surgical stratagems and risk management, we need to manage the loss of domain and make room. Traditionally, this has been achieved through progressive pneumoperitoneum and cytoreductive surgery, but increasingly chemical component relaxation with botulinum toxin A is being employed to good effect. This case history involves a gentleman who suffered a surgical misadventure following closure of a loop ileostomy that had been fashioned during surgery for a low rectal cancer. He lives in another state and he'd been seen by a number of surgeons who felt that he couldn't be helped. As you can see from the CT scan, he had balled up retracted lateral muscles, he had a 22 centimetre wide defect with a large extra-abdominal component containing small and large bowel. On examination, the bowel loops were relatively immobile under the skin graft. The edges of the defect were palpable and the upper abdominal soft tissues also were relatively mobile. And so after extensive discussion with the patient and colleagues here and overseas, a plan was formulated involving chemical component separation, admission to hospital for progressive pneumoperitoneum, and then abdominal wall reconstruction. But there were a number of unanswered questions, including how effective Botox and pneumoperitoneum would be in this man, the potential for a staged procedure, and the risks involved in the surgery. Although not clear from this CT scan, the preoperative Botox did in fact reduce the maximum transverse width of the defect by 6 to 7 centimetres. He was admitted and a radiologically placed catheter produced pneumoperitoneum with the resultant reduction of sac content. And as a bonus, it produced these lovely pictures, some adhesiolysis and some soft tissue expansion, but caused him to have a retroperitoneal hematoma. After evacuation of the hematoma and the gas, meticulous scalpel dissection allowed the overlying skin graft to be dissected off the bowel without any enterotomies. He underwent dissection of the retroactive space on either side and bilateral transversus abdominis releases were performed. The posterior elements were approximated over a phasix mesh. A large sheet of midweight polypropylene was inserted and secured cephalated and chordate, and then drain tubes placed superficial to that. And the midline was closed using interrupted figure-of-8 absorbable sutures placed sequentially. To further offload tension in the midline, the anterior sheath was incised and reinforced with polypropylene grafts. Bilateral skin flaps were raised, advanced and closed in layers over drain tubes, and a negative pressure wound dressing applied. The initial post-operative course was uneventful, but he had a persisting ILS and suffered an aspiration event necessitating readmission to intensive care. Thereafter, his recovery was relatively straightforward and he was discharged from hospital just over 3 weeks later with disappearance on the day of discharge. And when I reviewed him for a colonoscopy 3 months after discharge, He had a well-healed wound and a solid repair. So I think although each case is unique, I think there are principles to be followed, including the multimodal management of loss of domain and having alternate intraoperative strategies available. Thank you.
Thank you so much, Rod. That was really an impressive outcome for a really complex case. Just the kind of thing we like to see. I don't think that we have time for questions, unfortunately, because I'm sure there would be many. So I'm just going to call upon your compatriot, Hugh, to give us his example.
And that's also recorded, Heather. So.
For again asking me to talk at this conference. It's a great honour again. I just wanted to discuss quickly loss of domain with an enteroatmospheric fistula. About 5 or 6 years ago, I had a 65-year-old lady who presented with a cecal valvulus. She'd had previous open abdominal surgery for gynecological reasons, and at surgery it was evident that she had exposure to talc. She had very severe adhesions, and it took me over an hour to dissect from the midline to the right paracolic gutter to perform a right hemicolectomy and division of adhesions. That was all a very straightforward recovery. Unfortunately, 6 months later, she presented with an incisional hernia. Given the knowledge of her previous adhesions, I took her for open repair. Unfortunately, at open repair, she had Swiss cheese defects, and I crossed one of these inadvertently, and she presented 3 days later with sepsis. She was taken back for laparotomy, and it was evident that she had an enterotomy. Unfortunately, a further inadvertent enterotomy was made. After resection of small bowel, she had multiple washouts and then had a back blowout. We were unable to close her abdomen, and it was decided for safety's sake to leave her abdomen open, given that she was incredibly septic and in intensive care for 2 weeks. She had a very difficult recovery and obviously great difficulty in managing her stoma. I learned that you need to have wonderful stomal therapists to manage this sort of patient. And this lady had a very large stomal appliance for almost a year to manage her stomal output. What I learned from this exercise is that you need very significant patience to manage these people. It's psychologically difficult. It's difficult to manage the family. And it's very necessary to own these patients and be completely honest with them and the family. I've seen several cases on AWR and the IHC talking about these, and it's necessary to note from the outset with these patients that it will be at least a year before you can get them closed. I also learned that you need great help from colleagues, both for your own psychology, for feelings of guilt and inadequacy, but also to help manage these people. My very good friend, very great hernia surgeon, and who's also a burn surgeon, Keith Townsend, is used to doing very large grafts, so I asked him to graft this lady. What we also learned from this process was that the enteric content makes absolutely no difference to the outcome of skin grafts. This was completely covered by enteric content the entire time, and it made absolutely no difference. After a good 6 months, we had a much easier stomal appliance. This lady lost a significant amount of weight, and again, prehabilitation with optimization of nutrition, etc., is very important. What is important to note is this skin graft here gets its nutrition from the small bowel underneath. So when we are planning to do a definitive procedure, it's important that that's done, because as soon as that is lifted off the small intestine, it gets devascularized. The skin graft should be able to pinch off the small bowel, and then in this case, with Dr. Towsey's assistance, we resected the fistula and performed a TAR. This lady very successfully recovered and had no further issues, thank God. If we'd needed Botox, etc., it's obviously important to plan the definitive procedure. Thank you.
Thank you.
Thank you so much, Hugh. Another fantastic case for us to all see. I am going to show you a contrast. Maybe it's a bit of a horror movie now. A bit of a contrast. Maybe what not to do. Let me see if I can get myself organized. So hopefully you can see this patient profile coming from South Africa. My patient was 62 years old, hypertensive smoker, also with anxiety and depression on chronic medication. But most importantly, I think she had had very severe burns to her torso as a child, and she had thick mutilating scars over her whole chest and abdomen. Other than that, she was pretty fit. So she had had a story that in 2001, somebody had decided to fix her umbilical hernia, and that had been done with a suture repair. And then in 2002, of course, she presented with the inevitable incisional hernia, and somebody else tried to do something useful. And I think it was at the time when EPTFE grafts were quite popular. And I'm not exactly sure where the surgeon had placed this graft, because when I found it, it was lying under the skin and infected. She came to me 14 years later with a really nasty abdomen, a huge hernia, a chronic sinus with a lot of foul-smelling exudate. And so in 2016, I explanted that mesh, which, as I mentioned, was EPTFE, and it grew some nasty gram-positive organisms, which didn't actually require that much systemic therapy. She got better after the mesh explant, and I really didn't attempt to reconstruct her at all. I simply closed her and left her for 2 years until I felt braver and she was ready. So in November 2018, we decided that we needed to make a reconstruction plan for this lady, and we were following Sean's advice, and we tried to optimize the patient, stopped her smoking, and got control of everything that we could. But in South Africa at the time, there was no access to a progressive pneumoperitoneum, and there certainly wasn't any access to Botox for this indication. And so we were a little bit stuck, but we needed to do something. So we were trying to decide whether to do a TAR or to do an anterior component separation. So this was how her CT scan looked, which looks like all of the ones that I think you will get to see today, which is mainly just terrifying in the amount of abdominal viscera that are actually outside the abdominal wall. But that important aspect that we just heard about earlier on in this session, this patient's physiology and actually the lack of compliance related to her thick burn scars. So we're really stuck, and I don't like doing anterior component separations, but I really didn't think that I had much choice because I needed as much room as possible. So I decided to go for that strategy, left the sac intact, hoping that I could use it for some kind of Edinburgh type reconstruction should it be necessary, made the skin flaps and did an external oblique release together with a rectus sheath division, but there was still no way there was going to be any midline approximation. So the problem is now we're in Africa, we don't have that many options. We certainly didn't have any phasics. So we had to make a plan, and this is a typical African plan. So we made a plan with a double layer mesh, and we put an inlay mesh which we sutured continuously to the inner aspects of the defect, and then we repaired with an onlay mesh over the component separation. And we were very excited because we managed to get a lovely closure of the midline, and we thought that everything was great, except that 1 week later it wasn't great because everything was dead. And she necrosed all of her skin flaps and she was left with this nastiness. So I had to debride her a couple more times. I had to vacuum her for 2 months almost. But it's now almost 3 years later, and she actually has an intact abdominal wall and a skin closure without any clinical recurrence and without any wound. And so what turned out to be an African maker plan ended up with a reasonably contented patient. But I don't think it takes away from the fact that there are better ways to do these things.
Thanks a lot, Heather, and all the others. As we see that clinical scenario is very important, and people dedicated to abdominal wall surgery, especially in open techniques for these cases, are really needed. So we can go to a last case, and I hope we will see another one of those three brilliant cases we saw already. And I can hand over to Tahir Yamil, and I ask you to present your case, please.
Good morning from Toledo, Ohio. My name is Tahir Jamil. I'd like to thank the organizers of the Loss of Domain Global Summit for allowing me to present a unique clinical scenario that I encountered. This is a 60-year-old male who presented to the emergency department in septic shock. The patient had multiple prior abdominal surgeries, including a partial colectomy, as well as multiple prior hernia repairs. It was unclear exactly what type of hernia repairs the patient had had. His BMI was 57. He was ambulatory prior to his presentation. His CT scan that he had in the emergency department showed that the patient had free air, as well as a significant amount of fluid in his abdomen. As you can see, as we scroll down on his axials of his CT scan, the patient is morbidly obese. He has a very large abdominal wall defect. He has significant herniation of the viscera. Again, he did have droplets of free air on his CT scan, significant amount of free fluid. You can see a patient's prior mesh here. Again, the defect is fairly large and herniating all the way down to about his knees. The preoperative CT pictures demonstrate again large abdominal wall hernia. The patient has necrosis or ischemic changes of the skin itself. He did have an ulcer on the inferior aspect of the hernia defect itself. The patient was taken emergently to the operating room for an exploratory laparotomy. He had a spiral tear of his stomach. We performed a partial gastrectomy, debridement of the necrotic skin as well as fascia. He had a temporary wound device placed in order for the patient to stabilize. Here we can see an Apthera wound device on the patient. There did seem to be viable skin that we would hope eventually to close later on. Unfortunately, the patient went to the surgical ICU, and over the next 24 hours, he had increasing pressure requirements. You could see that he had further necrosis of the skin. He went back to the operating room for further debridement. At that point in time, the patient was on 3 pressors. The family was significantly distraught. They thought that his quality of life prior to surgery was not very good. And given all the surgeries that would be required to repair this kind of defect, they did not think that it would be in his wishes to proceed with any further treatment. They elected to make the patient comfort care, and he expired shortly after. Thank you so much, everyone.
Well, if breath, if Tahir, thanks. And I think this was also very nice to see that some strategies will not work, and we are confronted with really horrible things. So I think this is very good to, unfortunately, there's less time to make a good discussion, but I think we have some comments on it. Okay, Heather, do you have any comment furthermore?
If Sean is around, I have a question for Sean. Sean, preoperative nutritional optimization, what is the duration that you start? For example, if you give them amino acids, how long do you give them? Omega-3 fatty acids, how long do you give them? And say Ensure or some broad spectrum formula, how long do you give them?
There's no exact answer for that. So first of all, it depends on what their starting nutritional level is. And this is where getting some baseline albumin and pre-albumin levels can help, because then you can track that along sequentially. Initially, it's usually high protein supplementation until you can reach adequate protein store levels. As far as the immune modulating formula, that's really toward the end of that optimization period just before surgery. So the data that I'm aware of is really that last week ahead of time, really charging up that body, boosting different aspects of the immune system. But as far as the longer duration, that's more generalized nutritional optimization. This is where, if possible, seeing a nutritionist can really help. And this goes both ways for malnourished patients or even obese patients. Obese patients can still be malnourished. And so they still can need not only dieting, but it has to be safe and effective dieting. And Rod Jacobs had asked a question earlier that kind of alluded, that was about this as far as the sort of the counseling with this. And it really has to be an individualized sort of discussion with the patient. What works for one patient may not work for the others. There's 1,000 diets out there, and most of those aren't going to work. So you really need to individualize it for each particular patient. And some people need longer therapy, some people need shorter therapy.
Romano, I've used Impact quite a bit because of the upper GI work that I do. And in addition to that, you only give it to the patients for the 5 days before their operation.
Right. Absolutely the same.
Sean,
so Sean, the other question I had was about setting expectations for the patients and working out what's their least worst option so that you know when to stop, so to speak. I think that's one of the things that's not emphasized enough in the preoperative management is setting realistic expectations.
Yeah, I mean, expectations are for so much for all these patients, for whether it be a weight loss expectation, and that's where it's nice to set some sort of goal with that patient. Maybe that goal is if they start off with a BMI of 60, maybe you have to bring them down to 40, which is still high, but that's an expectation you set with that patient. If it's a nutritional goal expectation, then we want to set, I think, some more defined parameters, get that prealbumin above 20, making sure that albumin is above 3 to a 3.5 or greater. For frail and deconditioned patients, making sure they, if you evaluate their stair climb and they can't even walk up a flight of stairs, you reevaluate them, get through the prehab program, and bring them back and observe them to achieve an ambulatory status before you do this. If they're completely deconditioned, that's a recipe for disaster if you have to do a major reconstruction on them. Hope that answers your question.
Okay. Shan, there's one more question by the audience. If you use the pre-optimization only for complex abdominal wall reconstruction, or you can use the same for small umbilical hernias, inguinal hernias, did it make sense?
Yeah, I mean, I don't know that all this optimization protocol really applies to small hernias or even, in fact, some MIS. MIS really is a game changer from wound healing. Tiny little incisions. Yeah, people can have little dehiscences and small little infections, but there's night and day difference between large open AWR procedures and small little cuts. So I don't think that it applies to it. While I still usually mandate some degree of weight loss, smoking cessation for all my patients, because don't forget, if we do a robotic TAR, let's say, some of those patients may have to convert to an open TAR. So I want those patients to be prepared for the worst case scenario. Now, that said, if I'm doing an umbilical hernia, whether it be open or MIS or inguinal hernia, I counsel them on weight loss and smoking cessation, but I don't harp on it. I don't make such as big of a deal for those smaller, less complex patients.
Okay, one more question about the BMI. Do you have a magic cut number, or depends on the patient?
Oh, definitely depends on the patient, but BMI of 50 is really our hard cutoff. And doesn't mean I'm gonna operate on somebody that's 49.5, but it really depends on their starting point. So if somebody has a BMI of, say, 45, I really want to get them down to below 40, preferably into the mid-30s or lower. If somebody comes into me and the BMI is 60 or 70, I'm not going to get them to a BMI of 30, 35. That's impossible, even if I send them to bariatrics and they're successful with that. So it really depends on what their starting point is. So for example, somebody comes in with a BMI 65, they get a sleeve or a bypass. If I can get them to perhaps just below 40, I think it's a huge win, and they've made a dedicated effort. And as long as they're not smoking and diabetes is well managed at that point, then I'll be willing to take them and do a reconstructive procedure on them. So there is no cutoff specific number. It really has to be an individualized approach. I feel like I've said that like half a dozen times already, but there is no single answer to that.
Okay, perfect. Thank you. Luciana, can you introduce our next speaker?
Yeah, I'd like to invite John Scott from Lexington to talk to us about obesity as a concern in loss of domain. Welcome.
Good evening. Thank you for the opportunity to speak today at the Loss of Domain Global Summit 2021. Today, I've been specifically asked to talk to you about obesity as a concern in loss of domain. This is an outstanding program this evening, and we've learned a lot already, and I think we have a lot to learn as it pertains to loss of domain. As you know, the definition of loss of domain is quite ambiguous. It was first introduced into the surgical literature in 1972 by Willard Johnson, where he discussed that there is no space left in the abdominal cavity in which the contents of the sac have lost the right of domain in the abdomen. Many have described this as a second abdomen or a large irreducible hernia. More quantitatively, people have talked about volumetric relationships, whether it be related to the hernia sac volume to the total abdominal cavity volume, or the hernia sac volume to the total peritoneal volume. I think we really need to firm this up and all make sure that we're talking about the same thing when we refer to loss of domain, but very much so, it's one of those phenomena, we know it when we see it. But clearly there's no consensus. Obviously, this is an example of a morbidly obese patient with a large pendulous hernia with loss of domain, as is this patient here. And the bottom line is loss of domain implies a significant volume of abdominal contents residing in the hernia sac, such that returning into the abdominal cavity will result in a significant physiologic adaptation. And I think this is even compounded greater in the patients with morbid obesity because of the physiology associated with that condition. So we know that loss of domain of physiology has to do with abdominal muscle shortening, contracture, thickening, a reduction in the abdominal volume as associated with that shortening and contracture, increased intra-abdominal pressure, which is certainly made worse in the setting of morbid obesity, which is associated with diaphragmatic weakening, relaxation, often with pulmonary function reductions, which really presents as a restrictive pulmonary pattern. In addition, that hernia results in venous and lymphatic congestion, which results in a further enlargement of the contents of the sac. And we know that the goal of treatment of loss of domain is really to reverse those physiologic impact through lengthening the abdominal musculature, restoring its architecture and elasticity, increasing abdominal volume, improving diaphragmatic function, restoring pulmonary function, reducing that venous congestion, and ultimately restoring the contents back to the abdominal cavity. Now, we know that there are many causes of loss of domain. Again, we're going to focus on obesity today, but anything that causes increased intra-abdominal pressure, the duration of the hernia is a major contributor. Arguably, prior surgical history is significant. In my experience, patients with massive inguinoscrotal hernias with the entire contents of the abdominal cavity in their groin rarely experience loss of domain. I just have not seen that. I know I've heard of others who have experienced that phenomenon, but I think absent prior surgery, the likelihood of loss of domain, even in morbidly obese patients, is quite rare. Obviously, there's patients with collagen vascular disorders which predispose to loss of domain. And many times it's not a single factor. It may be a combination of these factors which results in this problem. We know that hernia formation is often associated with the atrophy and fibrosis of the abdominal wall compared to normal abdominal walls, and even those who have just undergone a laparotomy. And as you can see in this study from 2007, a patient who develops a hernia definitely has less elongation of their abdominal wall musculature. The abdominal wall muscles are stiffer. They have a higher tensile strength and a higher breaking strength associated with them. So our goal when we manage patients with loss of domain is to turn them from a non-operative candidate to an operative candidate. And many times that's through reversal or improvement of their comorbid conditions, as well as managing those comorbidities that can be improved. So what are some of these strategies? Obesity management is absolutely paramount. We'll talk a little bit about progressive preoperative pneumoperitoneum, although it certainly has fallen out of favor and largely related to Botox injections. And then also component separation techniques and what is the impact of component separation as it pertains to loss of domain. Well, I will tell you, when I see a patient with loss of domain and obesity, the first thing we do is have a long discussion regarding their management of their weight. We talk about diet and exercise and the importance of managing their weight, both not only for their hernia, but also for their general medical health, and provide them nutritional education. Many times we'll see patients that have the perception that they're doing the right thing, but they just haven't received that nutritional education that's so important. Common things that we'll hear is that I only eat one meal a day. I already eat very little. I just can't lose weight. And I think by helping these patients with their weight loss management strategies, we can actually get them to a place where we can successfully perform their hernia repair. I do think it's important that they have close surveillance with weekly weigh-ins. That can be challenging, but in the era of telehealth, we certainly have the opportunity to reach out to these patients more frequently. I also think it's important to utilize our medical colleagues as appropriate, particularly in patients with diabetes, as weight loss management in the setting of diabetes can be particularly challenging. Now, my nurse practitioner, Margaret Plymal, obtained her doctorate in nurse practitioner as studying the impact of obesity on ventral hernia repairs. As you can see here, she looked at patients from 2012 to 2015 in our practice. And during that 3-year period of time, she identified 381 ventral hernia patients. These are not all patients who underwent operation, but this is the time of initial consultation. I just want to highlight the fact that in our practice in Kentucky, nearly 70% of those patients were obese, but 20% had a BMI in excess of 40. Now, when we looked at those patients, as you can see here, some of them were able to achieve their goal weight. Some received surgery without obtaining their goal weight. Others never followed up or followed up and didn't have an operation offered. But I really want to highlight the fact with diet and exercise, only 7 of 78 patients that were studied were able to achieve their weight loss goals. Now, those patients who did achieve their weight loss goals were quite successful in their hernia repair, but it took time. As you can see here, patient 1 took a year, and patient 7 took 2.5 years to ultimately lose nearly 100 pounds. But those patients who were successful in achieving their BMI goal had excellent outcomes in their ventral hernia repair, but this represented only about 10% of the patients that we saw with obesity in the setting of a ventral hernia. Now, what is the role of weight loss surgery in the setting of loss of domain and morbid obesity? Well, this is a study that came out of the Carolinas Medical Center more than 10 years ago, looking at 27 patients with a mean BMI of 51 who were offered gastric bypass. Now, interestingly, one of those patients did develop an incarcerated hernia, but only one did. And I think it's important to counsel patients that the risk of them having an incarceration or strangulation event while they're losing weight is quite low, although not zero, but their risk of having a surgical complication or a hernia recurrence while having an operation with a high BMI is quite high. That's particularly paramount in the setting of loss of domain as well. And what I want to highlight is that in a little over a year, they were able to significantly reduce the patient's weight, drop their BMI to 33, such that these patients were able to undergo successful hernia repair. And at 20 months follow-up, those patients who had a second stage ventral hernia repair did not recur their hernia, but those patients who underwent concomitant hernia repair at the time of gastric bypass all failed. So I think it is important to recognize the importance of weight loss strategies prior to hernia repair rather than performing them simultaneously. Having said that, gastric bypass has its concerns in a patient with a large ventral hernia with loss of domain, which often involves a large amount of small intestine within the hernia sac. These operations can be extremely difficult and tedious. There are concerns about the potential for an early small bowel obstruction in the hernia, resulting in an anastomotic leak and catastrophic complications. And I would say the vast majority of surgeons would be reticent to perform gastric bypass in the setting of loss of domain. Now, what about sleeve gastrectomy? That certainly has risen as a more popular procedure in the setting of morbid obesity. And can it be used successfully in managing patients to achieve their goal of a ventral hernia? Well, this paper that was published in 2012 actually looked at patients' successful weight loss, and they were able to identify 18 patients who were able to drop 10 points off of their BMI in as little as 6 months. Now, this wasn't loss of domain hernia patients. These patients need operations for other reasons, largely orthopedic in nature, although one of them was a recurrent incisional hernia. But most of these patients were able to successfully lose weight through a strategy of sleeve gastrectomy. This more recent paper by demonstrated sleeve gastrectomy in the setting of loss of domain and ventral hernia repair. And as you can see in this group of patients with fairly complex hernias, the majority of them were multiply recurrent with anywhere from 2 to 5 previous repairs, with BMIs ranging from 35 to nearly 66. These patients were able to undergo sleeve gastrectomy with significant weight loss at 6 months following their sleeve, and dropped their median BMI to nearly 33. Now, when looking at the outcomes of those patients who subsequently underwent hernia repair, you can see that there were infrequent recurrences, infrequent mesh infections, and infrequent infected seromas. So again, this suggests that a sleeve gastrectomy, when feasible, is a successful strategy in weight reduction in helping patients to lose weight to have a long-term successful hernia repair. Obviously, the challenge is finding the way to get into the abdomen to perform the sleeve gastrectomy. Having said that, in the vast majority of patients, we're able to obtain access laparoscopically, even the most complex hernias, to access the stomach, to minimally dissect adhesions to the abdominal wall and avoid the potential for dissection of the hernia and reduction of the contents. Now, what about the role of progressive preoperative pneumoperitoneum? Many are familiar with this. This is a strategy that's been around for many years, placing a catheter typically in the subcostal region, infusing air into the peritoneal cavity on a daily basis, usually for about 2 weeks until the hernia is reduced and the abdominal volume is increased. And as you can see here, as air is infused into the abdominal cavity, the volume of the hernia reduces, but the contents of the hernia typically reduce as the total abdominal cavity volume is actually reduced. Now, are you able to manage loss of domain in this particular strategy? And you can see here in this study, looking at hernias greater than 10 centimeters of width, the loss of domain definition, again, was not a standard definition. They defined it as hernia contents held by adhesions and cannot be reintegrated into the abdominal cavity. But all these patients underwent progressive infusion of air every other day for a period of 2 weeks. As you can see here, volumes were quite large. Incisional hernia volume, nearly 5 liters, total abdominal cavity, nearly 9,000 liters. And what they are able to look at is patients who had a tension-free closure, where the fascia was closed without complications, and they had 6 patients in which the fascia was not able to be closed despite their preoperative pneumoperitoneum. They actually had 1 patient who died of compartment syndrome, 40% morbidity. These were very lengthy hospital stays of nearly a month, plus or minus 3 weeks. But what they were able to identify is that those patients who had an incisional hernia volume greater than 20% of the total peritoneal volume had a very high likelihood of unsuccessful closure of the abdominal wall, suggesting that that may be an important metric in deciding when a patient has loss of domain and something else needs to be performed. In addition, we know that these patients have significant pulmonary derangements, and what we're concerned about is as we put the contents of the hernia back into the abdominal cavity, that we create significant respiratory embarrassment such that they end up in the ICU or on the ventilator or have long-term sequelae. So in this study, more recently performed in 2018, they looked at the impact of preoperative pneumoperitoneum in obese patients with loss of domain. They instilled 12 insufflations of nearly 6 liters of air, and they were able to increase the hernia sac volume, the abdominal cavity volume by nearly 2,000 cubic centimeters. They were able to reduce the hernia sac volume by approximately 1,000 cubic centimeters, reduce the ratio of hernia sac volume to abdominal cavity volume from 38% to 16%. And at the same time, they were able to improve the pulmonary function test with an FEV1 of 1,000 up to nearly 1,600 and a forced vital capacity of 1800 to 2700. But equally important was the impact on the preoperative pulmonary function test findings and the postoperative pulmonary function tests after the hernia repair. And in many ways, the preoperative pneumoperitoneum prepared that patient physiologically for the impact of having their abdominal viscera restored to an intact abdominal cavity. So what about the role of component separation? I would argue that many times with weight reduction and some of the adjunctive techniques, a component separation wouldn't be needed and a Reeve stopper would be adequate. But what about Ramirez component separation or a transversus abdominis release? Well, we know in this study from Greg Dumanian, looking at 19 patients where he performed component separation in a traditional Ramirez fashion, he was able to actually increase the volume of the peritoneal cavity. So I do think there's some impact and benefit by utilizing a component separation as an adjunct. You can see here the peritoneal volume increased from 7,600 to 8,100 cc's. And he was able to do that without respiratory physiology changes in FVC, FEV1, or maximal voluntary ventilation. What about transversus abdominis release? This is an interesting study that was recently published looking at TAR and the impact on peritoneal volume. What they looked at specifically was the peritoneal index as defined as hernia sac volume over peritoneal volume. They were able to demonstrate that a transversus abdominis
Hello, Ramana, can you hear me?
Yeah, we can hear you. We can hear you.
Yeah. Maybe it's a problem only with the video.
There's a problem and it's fixing
some transmission issue. Now it's okay.
Can I try to put the video again?
I think the backend team will take care of this.
Wait.
When the peritoneal index is greater than 0.3, the transversus abdominis release and likely a component separation is unlikely to get the job done, and you need to consider something other than the hernia repair alone. And that's where Botox really has come into play. I know we're going to hear about Botox later in the session today, but I think utilization of botulinum toxin preoperatively several weeks prior to an operation can actually result in elongation and thinning of the abdominal wall and increasing in the peritoneal volume. And although it has not been well studied as it pertains to obesity and loss of domain, I think this is an important adjunct in managing these patients, particularly when there remains loss of domain after optimal weight reduction. So how do I manage these patients? For me, when I see a patient no different from any other hernia repair, we're going to preoperatively optimize them. Smoking cessation is paramount, diabetes management to drive their A1C as close to normal as possible, MRSA eradication, and really managing that BMI, whether it's through medical weight loss strategies or weight loss surgery, is absolutely essential. We're going to drive their BMI down until their hernia is reducible or until their BMI is 30. Many times we'll examine patients when they hit a BMI 35, and if they still have a significant loss of domain, we will then ask them to lose additional weight in order to get them prepared for their operation. Preoperative Botox after weight optimization, if their hernia sac volume to their peritoneal cavity volume is greater than 20 to 30%, there is some subjectivity to this, and it really depends on the complexity of the hernia, the number of prior repairs, and my sense of compliance of the abdominal wall, which I don't think we have a great way of measuring how fibrotic an abdominal wall is, but with experience, we can assess the softness and the suppleness of the abdomen on physical examination. I think our operative strategy needs to be tailored. I rarely use preoperative pneumoperitoneum, although I think it's important to keep that in our back pocket as necessary. Generally speaking, I will perform a single staged operation with a component separation. Many of these patients will have redundant skin and soft tissues, and I'll perform a concomitant paniculectomy, not only to prevent wound complications, but also to offload pressure on my hernia repair. For the vast majority of the patients, I will perform a transversus abdominis release, but there are circumstances where Ramirez repair may be most appropriate. And I think it's essential that we avoid operation until these patients are optimized. Many of these patients are frustrated. They want their hernia fixed. What you need to make sure that they are 100% optimized prior to their hernia repair, and reassure them that the likelihood of incarceration is relatively unusual, and prepare them for 12 to 24 months. I don't set the expectation that they're going to have an operation 3 months following our initial visit. And again, with these strategies, we can take patients like this with large loss of domain. As you can see on the CT scan, the hernia sac volume is at least 25%. We're able to undergo hernia repair and restore the contents of the abdominal cavity. Patients like this were able to improve their quality of life. This patient who initially presented to me with a large flank hernia following a nephrectomy with a BMI in excess of 50, as you can see here, and again, have a successful repair when we were able to get her BMI to less than 37. So, and obviously one of the things we want to definitely avoid is creating a situation with an open abdomen where we're unable to restore the contents of their hernia to their abdominal cavity and need to perform some form of temporary closure. So again, I want to thank you very much for the opportunity to speak with you today and share my opinions on loss of domain in the obese patients. I look forward to the opportunity to discuss this further with you in the future. Thank you very much.
Thanks, Professor John Scott. We have some questions of topics that will be well discussed in the next session, so we can leave that for later. Now I want to call Professor Eric Paulai and Professor Omar Ghanem to give their comments of this session, and then we can close. Omar?
Eric? Me or Eric? It doesn't matter. To be honest, I just have first a great lecture and presentation by Professor Roth. But I have 4 points, and I'm going to try to be quick with this. Obese patients are almost always malnourished. So this is also a notion that we have to address. I agree with Sean. He mentioned this earlier. I have a patient with a BMI of 104 coming with a almost eviscerated umbilical hernia. I had to admit her for 4 weeks for optimization before I take her to the OR for a bariatric surgery. And her initial albumin with a BMI of 104 was 2.8. And after the appropriate diet in-house for 1 month, her albumin prior to the OR, the day before the OR, was 4.8. So that's something that we need to focus on. Not every patient suffering from obesity is nourished. In fact, it's the opposite. And they most of the time are frail and not healthy. So the other thing is having a set BMI for patients who have or suffer from obesity, and then when do we take them for surgery? Starting BMI and target BMI are very important. And if a patient presents, a patient with a BMI of 77 got a duodenal switch, her BMI dropped to 48, you cannot get this patient to go to less than 40 or 35 as a BMI. You can't. She got the maximum out of her surgery. And then at that time, when they plateau, just use that moment to go to the operating room. This is the best optimization you will ever get. So don't wait till they start regaining weight, because after they plateau, it's only going to go one way, which is upwards. And then you have no more options. The third thing is access. We saw through all of these presentations and also through the published literature, only a handful of publications go above 10 or 12 patients for having a sleeve gastrectomy or bariatric surgery before hernia surgery. And that's the problem with access, because once you decide, my practice just revolves around two practices, just bariatrics and hernias. And for me to refer to my practice from hernias to bariatrics, it takes about 6 months for the patient to get back to me to get their bariatric surgery, although I'm the one who's recommending that they get it. So it's just very difficult, and most of the time patients just lose interest and coming back and doing those sessions. The last thing is managing those hernias intra-op at the time of bariatric surgery. So you're doing a bariatric surgery before a hernia repair in a setting of loss of domain. Sometimes your options are very limited. It's great if you are going in and to do a sleeve and the hernia is in the lower or the lower abdomen, pelvis, or suprapubic area. But that's not always the case. Most of the times they have an upper abdominal hernia, and that is a problem. So how do you manage those hernias intra-op? There's a lot of algorithms. Most importantly, unless the hernia defect is huge and large, like more than 10 centimeters, do not leave it open. You will come back for a proximal leak. If it's a smaller, try to do anything. Recently, I am presenting this hopefully at next stages. I'm plugging those hernias with Omentum with the patch myself. So I just suture it back, the Omentum back into the defect and recreate what we call God's plug. And just to make sure that no bowel goes in, better than doing a primary repair and then in a patient who has a BMI of 60, and then those stitches just upon waking up from anesthesia, just breaking apart and having incarceration again. Thank you.
Eric?
Yeah, I'll just echo a few points that Omar made. Number one, we published our experience in sleeve and complex abdominal wall patients in surgical endoscopy in 2020. I think it's finally in print. But we found a few things. Number one, this takes a long time. The average time from the patient meeting us to getting a sleeve was about 10 months. And the average time for them to get a sleeve, lose weight, and then get a hernia surgery was about 23 months. So when I meet somebody, I can reliably tell them that in about 2 years, they're going to wind up getting their hernia surgery. And when you think about waiting that long, I think there's a lot of fear about people having problems related to the hernia. In our experience of 20 patients going through this, we had 2 patients who had hernia-related problems, neither of which required emergency surgery. They were managed conservatively. I think the second bit of time that needs to be talked about is something that Omar just mentioned, which is a lot of these patients have hernias that are in the upper abdomen. In our series, 90% of patients had hernias that included the M1 or the M2 zone, which means that you have to do something with it during the hernia repair. And my bariatric team, led by Dr. Ann Rogers, basically spent a lot of time taking down adhesions in the upper abdomen. The average time for a sleeve in our series was 120 minutes, plus or minus an extra hour. And so you've got to be dedicated to spending the time to do it. Finally, the thing to think about is complications. While complications after bariatric surgery are less common, in a patient who's got a loss of domain hernia, bleeding, leak can be devastating complications in a way that they wouldn't normally be in a patient who doesn't have a hernia. And so you need dedicated expertise to be able to manage these things. And part of what makes our center unique is that we have dedicated surgical endoscopists who are willing to take on a lot of these problems to avoid having to address the hernia in the event of managing a surgical complication. So I firmly believe that bariatric surgery is a useful adjunct, especially in a loss of domain patient, but it requires a lot of things that are out of the ordinary for a sort of typical sleeve patient.
Okay, thanks Eric and Omar for the comments, and by the powers granted to me, I declare the end of this session. We can move on to the next. Thanks, Ramana. It was a great pleasure to be here today with you.
Thank you so much. Superb, Ram. Thank you. Thank you, everyone.
So thank you, everyone, for this great session. We have all learned a lot. And from the problems, let's move on to the solutions in the loss of domain. So I would invite the next set of chairpersons, Dr. Jan Kukleta, Dr. Sheni Shao from USA, and Dr. Hugh McGregor from Australia. So over to you, chairpersons, for the next session.
Well, thank you very much. That's great. We are a little bit behind the schedule, so I would like to ask all speakers to stay in time. But it's a great privilege when you have to moderate people that you know. And I met all of them. And I met Jenny today for the first time. And I would like to ask you, because I'm raised with ladies first, ask you to introduce Anita Jacobs.
Hi, thank you guys so much for allowing me the privilege of being a chairperson today. I'm so excited to be here at this conference. So I would like to introduce Anita Jacobs, who's going to be talking to us about Botox 101 in the treatment of loss of domain. So I'm going to go ahead and let her get started, and take it away, Anita.
Thank you for asking me to talk about our experience with botulism toxin and loss of domain hernias. I'll also briefly cover some of the other techniques that we use on these patients. As you can't talk about one technique, you need to talk about a suite of techniques to prepare and surgically manage these patients. Next slide. Preoperative preparation is essential. You must manage their comorbidities, get their diabetes under control. Weight loss management is also essential. Ideally, a BMI of 35 or under. We commonly will tolerate BMIs of 40 and under. And certainly we have a group of patients that really are incapable of getting that degree of significant weight loss, but they need to demonstrate a commitment to weight loss and certainly a 5 to 10 kilo weight loss before we'll consider operating on them. Preoperative botulinum toxin, we've been using it in our practice for about 7 years or more now. Every patient with a complex ventral hernia gets it. We are now doing it about 2 to 4 weeks prior to surgery. We've slowly lengthened this preoperative time, but we feel that the additional time
Again.
prior to surgery, but after BTA. Why do we use BTA? Well, it chemically induces a flaccid paralysis of the lateral abdominal wall. In our initial papers, we were injecting all 3 layers. We now do limit it to the obliques, the external oblique and internal oblique. Transversus abdominis is a really important muscle for spine stabilization, and we now choose not to inject it. A small group of our patients with back pains prior to presenting to us, we found they got worse back pain after the injections and really struggled through that 3 to 6 month period of its efficacy. So we now spare the TA. We have demonstrated, and we've published on this previously, that we get a relaxation and elongation of the lateral abdominal wall about 4.1 to 4.2 centimetres per side. In the operation, it makes midline closure much easier. And post-operatively, you facilitate a tension-free fascial repair. It also augments post-operative analgesia although we haven't documented or recorded this well. The procedure we do the procedure in our own rooms. It's an outpatient procedure. We do it under ultrasound guidance, and we broadly use these three areas on the lateral abdominal wall that are easy to identify under ultrasound. You can inject either 2 or 3 layers. From a Botox, if you're using that as your BTA, 100 units per side, Dysport about 250 per side. And we now do it 14 days or more prior to your operation. It can be repeated, so if you didn't get a good relaxation or you want a prolonged relaxation, you can repeat it. This is a real-time video of a 3-layer injection. The fascial layers are quite easy to identify under ultrasound, and that's as quick as it takes to do a single injection. We do use PPP. I'm not going to talk about it much more other than to say we use it to expand the abdominal cavity. We certainly think it facilitates adhesiolysis, particularly of the thin, flimsy adhesions. It certainly identifies area for safe entry, both laparoscopically and open approaches, and it's done routinely by an interventional radiologist. We don't do this ourselves. We also use a minimally invasive external oblique release, our version of a component separation. We have a single paper on this. It's a modified open external oblique release. It divides the external oblique fibres about 2 centimetres from its medial insertion. We do not separate the fascial planes, and you can do it under direct vision. This is our paper on it. Initially, we did use this endoscopic carpal tunnel machine. We don't use that anymore. Once you've actually made your incision and down through your fascia, you find your external oblique fascia, anterior fascia, and open it. You make a tunnel under the muscle, and you can actually divide it under direct vision. This was the image of a cadet from an ultrasound from a cadaveric study. And interestingly, before pneumoperitoneum, we got an elongation of about just over 2 centimetres. During pneumoperitoneum, we got a elongation of up to almost 4 centimetres, and this relaxed after deflating. So it shows that this release can be quite dynamic, and it certainly facilitates closure without needing to separate one fascial plane from the other. A couple of case studies now. 2 case studies I'll show you just to give you a sense of how it works. This is of a 61-year-old male with a large midline defect, 17 centimetre transverse defect with a loss of domain of over 50%. He had significant weight loss. His BTA to PPP was about just over a month. And then he had between PPP and surgical repair was 4 days. So this scan is his initial scan before BTA and PPP, axial and coronal. This is the same axial scan before treatment, preoperative preparation, and this is after BTA and PPP. You can see you've got significant reduction of many of the sac contents, but it clearly defines your adhesions here to the left of midline. The liver is now fully reduced back into the abdominal cavity, and you've got good elongation and thinning of those lateral abdominal wall muscles. This is the same patient, a little bit lower down in the abdomen, again at the lower end of the liver. The liver is now fully reduced as seen before, a few more adhesions, so these are more dense adhesions. And finally, this is the inferior end of the hernia, and here it showed us quite significantly these adhesions were clearly more dense, and we would know we would need to spend a little bit more time and a little bit more care reducing these hernias. The adhesions of these hernias. This is the coronal view of the same man, both pre and post BTA PPP. We were able to demonstrate in preoperative imaging that after BTA and PPP, we had a length gain of 6.5 centimetres prior to surgery and 3.5 centimetres prior to surgery. And he also underwent an external oblique release at time of operation, and we were able to do all his surgical repair laparoscopically, and his midline defect of 17 centimetres was closed. Post-operation, he was extubated. He didn't require invasive ventilation and required minimal ventilatory support in the first 24 to 48 hours, and was essentially breathing on his own. Second case study is not dissimilar, a 71-year-old female who had a total abdominal disaster over a series of operations from a hysterectomy 35 years ago to probably her second or third insertional hernia repair, which resulted in sepsis, mesh infection, a very prolonged admission with multiple trips back to the operating theatre, which her abdominal wall ended up with 5 hernias with a total loss of domain of 55%. Time from BTA to PPP was 6 weeks. Time from PPP to the operating theatre was 6 days. These images, so her upper midline was actually had a small incisional hernia. This is the main part of her incisional hernia, showing a midline defect and also a left flank defect. And this is the lower part of her abdominal wall, which was really patchless. This is her, these are coronal views. So in midline, there's you can't really appreciate the significance of the extent of her loss of domain. But the coloured view on the left is a 3D reconstruction of her axial scans. And all this area here is totally devoid of muscle. It's essentially her guts. Her intestines are falling out through that defect. These are her images, axial images from before and after BTA and PPP. Do note this is subcutaneous emphysema here, probably the most common complication of the PPP. And again, showing again, reduction of part of the contents in the larger inferior component. The lateral flank really hasn't benefited much from the PPP, and the coronal views feel the same. BTA and PPP gave us a total length gain of 3.9 centimetres on the left, 5.9 centimetres on the right. And again, this lady underwent an external oblique release at time of closure. We were able to reduce all the hernia contents. We were able to close all her defects, extensive mesh coverage pretty much from costal margin to pubic ramus and from left to right, but she is closed. The muscle damage from her previous surgery was quite extensive, but she's remained closed now for the 12 months. We are currently reviewing our data on our loss of domain patients. We've got over 35 patients. I can't give you the full up-to-date. We're just finalising it for a report, but we've got over 35 patients now. The majority are males. A loss of domain from 20 to almost 60%. We've been able to demonstrate on imaging alone that preoperative BTA and PPP gives us a length gain of about 4.4 centimetres per side. We've had no complications from the BTA. You do get complications from the PPP, so there is a downside with PPP. All of ours are related to wherever the air can travel, and it can travel quite extensively. We've had no deaths. We've found that sort of a crude guesstimate is if you did on these loss of domain hernias, BTA, PPP, we get about 4.5 centimetres per side, so a total gain of 8.8 centimetres. And if you add in about a 3.5 centimetre gain from each side from your external oblique release, you can get up to almost 16 centimetres. And that's without a bit of pull and tug to get you that final defect closure. This cannot be done without a team, and our team is quite extensive and now quite knowledgeable and skilled, but it's certainly led by my senior colleague and mentor, Professor Nabil Ibrahim, and the imaging and our understanding of BTA and the imaging and our rapidly gaining knowledge of how the abdominal wall functions under BTA could not have been done without Dr. John Reed, who is our marvel. Thank you.
Yeah. Well, thank you, Anita. We have some questions, but we have to save the time at the end of the session because otherwise we cannot proceed. I would like to introduce the next speaker, who is going to be a friend of mine from Guadalajara, Mexico. Tomas Ibarra was probably the first that ever presented some scientific work about BTA. And I'm looking forward, as always, Tomas, I'm looking forward to your lecture.
I have no disclosures. Thank you so much to Dr. Ramana and Dr. Jan to inviting me to give you this conference. Is BTX plus PPP better? My answer is yes, but this combination is not necessary for all cases of blood hernia. Botox is used in abdominal wall hernia patients is worldwide tendency. As you can see in this picture, Each patient present a different grade of problem of the Lute hernia. The Lute hernia is the patient who has a big sag with volume major to 20 to 25% compared with the volume inside of the abdominal cavity. The Lute hernia can be towards the abdomen, the thorax, and the scrotum. The challenge is to prevent the abdominal hypertension and its complications. This is our management, our algorithm of management for these patients is very important, but the most important is to classify these patients. In order to offer the better option management for these patients, we classify them in 5 grades. The grade 1 is the patient who have less than 30% Lute. Our recommendation is use Botox 200 units. In grade 2 is the patients who have 30 to 40% Lute, and our recommendation is use 300 Botox units. In the grade 3 are the patients who have 40 to 50 Lute hernia, and the recommendation is use 400 units of Botox. In the grade 4 patients are those that with more than 50% Lute, and the recommendation is use Botox 400 units plus PPP. The surgeon must to inject 1 month after VTX application, inject 10 to 12 liters of air in 10 days. We must to consider the bulking surgery in these patients. The grade 5 patients are those who present more than 30% of Lute plus lung morbidity. In these cases, the management is similar to the grade 4. In all cases, we diluted with 10 milliliters, 10 centimeters of saline solution, and we apply this solution in 10 points in the abdominal wall, 5 to each side. The days to abdominal wall reconstruction, we need to wait between 30 to 45 days. In scrotal and diaphragmatic Lute hernia, we add 4 points more by side on the rectal abdominal muscles. The dilution in these cases is made with 18 cc of saline solution to apply 18 points of 22 units. Now, let's see some Botox effect. We know that the Botox applied in abdominal wall muscles reduce the defect diameter, as you can see in this picture in a CT scanner at rest. You can compare before and after. Reduce to the muscular thickness, as you can see before and after. Increase lateral muscles, as you can see in this picture before and after. Increase to the abdominal diameter, as you can see in the picture. In these pictures, all measurements you saw has changed. The Botox returns until 30% of the mind, besides paralyzing factor, as you can see in this picture, before and after BTA application in a dynamic CT scanner. The Botox plus PPP effect, the modifications and measurements are better than Botox alone, and it's reduced the hernia sac content. As you can see in this picture, when you see this sac content, it doesn't exist. Now I'm going to show you some patients that we prepare in Guadalajara, Mexico. This patient, female patient, grade 5, we prepare her with Botox plus PPP. And for the superficial plane approach, we decided an hernioplasty low transversal incision. And for the deep plane, we decided Carbonell technique. Here you are the patient before and after with very good follow-up. This patient, grade 4, we prepare her only with Botox, and we decided hernioplasty with fleur-de-lis incision and Reeves technique before and after. Here you are the patient. This patient, female 2, grade 3, we prepare her with Botox only, and we decided to an incision, fleur-de-lis, and Carbonell technique for the deep plane. Here is a patient with very good follow-up. This patient, grade 2, we prepare her only with Botox 2, and we decided to an fleur-de-lis incision, herniabdominoplasty for the superficial plane, and a Carbonell technique for the deep plane, before and after. This patient is a Lud inguinoscrotal hernia grade 4, and we prepare with Botox plus PPP, and we practice an midline incision and stopper technique in remodelation of the scrotum before and after, as you can see in the picture. It's our number of patients. We have only 108 patients, and of these patients, only 14 of them were prepared with Botox plus PPP in a period of more than 10 years. There are no complications secondary to VTX use in abdominal wall. The complications reported are secondary to surgical management of the hernia problem. I conclude saying you that surgeons must to prevent complications due to intra-abdominal hypertension and others, using the abdominal wall expansion techniques alone or in combination. The combination techniques are used mainly in difficult cases. Patients with less of 50% of Lud hernia with no lung morbidity, PPP is not necessary, at least in our patients in Guadalajara, Mexico. Thank you so much for your attention. I'm going to present you this video with the anatomical guidance for VTX applied, how we do it. This technique, you can do it in your office. It's not necessary do it in an operating room. And you can see our marking, and you can see that this way of VTX application is very easy. Valeria, para que escuche las preguntas, hija. Thank you so much again for your attention.
Tomas, thank you for your presentation. Just a very short question. You talk about Carbonell. You mean Alfredo from Spain? Tomas, unmute yourself, please. Unfortunately, we cannot hear you.
Not the technique of
we have some sound problem. but maybe we can clarify it afterwards. So I would hand over to Hugh before it's midnight in Australia.
It's after midnight, yeah.
Okay.
Thank you. It's a great
we are a little bit behind the schedule.
Yeah, all the Australians are going to bed shortly. It's a great pleasure to welcome Dr. Gerian Lill, who is a German surgeon from Cologne. He developed the Fascio-TENS fascial closure device. He's a vascular and general surgeon, and he's going to tell us all about it today.
Hello, this is Gerian Lill. Thank you very much to the chairs and to the organizing team to give me the possibility to talk about abdominal wall traction, if it is a game changer. My disclosures: I'm one of the founders of the Fascio-TENS GmbH. So the current challenges in abdominal wall surgery are in the open abdomen, the retraction of the abdominal wall. The complications increase in the course of time, for example, enteroatmospheric fistulas. And we cannot apply medially directed traction because it's impeded by the prolapsing organs and the edema. Complex therapeutical procedures are the ones you need for loss of domain hernias. High complication rates, we know about those. And in gastroschisis and omphalocele, it's the uncontrolled and unquantifiable traction on the abdominal wall and a difficult positioning of the newborns. So the available primary and secondary therapies for the open abdomen are the negative pressure wound therapy, the temporary mesh, the Bogota bag, and the Whitman patch. And the best outcomes are described with negative pressure wound therapy combined with a fascial traction, either mesh-mediated traction or the Abra system. Available preoperative possibilities are the botulinum toxin, which we also do quite a lot, and the progressive pneumoperitoneum, which I personally don't have any experience with. Afterwards, intraoperatively, you do either the anterior or posterior component separations. So, could abdominal wall traction be a game changer in the open abdomen? And I think our problem is nowadays that we cannot apply the traction medially directed because of the edema. Because if you do apply a horizontal traction, you will augment the intra-abdominal pressure. If you do tear up the abdominal wall vertically upside, then you prevent a loss of domain, and thereby you enlarge the abdominal cavity, and thus you reduce the intra-abdominal pressure, which is very beneficial for those patients. To show you some cases, this is the first one we treated. It was a pancreatitis, a duodenal leakage, and it was a distance of 15 centimeters in the beginning. The abdomen has been open for 3 weeks. We teared upwards, and after 6 days, it was possible to close this patient. This is to show you that there's also patients that are not intubated and ventilated, but awake. This was a perforated appendicitis, 4-quadrant peritonitis, and we closed this young guy who had an initial distance of 13 centimeters within 7 days. This is a perforated aortic aneurysm, distance in the beginning 20 centimeters. We applied a vertical traction combined with a negative pressure wound therapy, and it was possible to close him after 8 days. We closed him after 12 days for other reasons. And this is another exciting case, a young patient, 16 years old, but very tall, with a coarctatio aortae and a reperfusion edema. When we arrived, there was the ribs open on the left-hand side, and we had a median laparotomy. And what we did, we closed the ribs in the first place. We put on a diagonally traction, and therefore we avoided high tension on the made sutures. After 3 days, we had a relook operation. We're able to close on the upside and downside parts of the abdomen. And after another 3 days, so after 6 days, it was possible to close this young man. In loss of domain hernias, I would like to describe our device and our technique. It was first described by Dietmar Eucker from Bale in Switzerland. He did an upwards traction to gain facial length. So nowadays we're working a lot together, and we're doing more or less 12 to 16 kilograms of quantifiable traction upwards for 30 minutes. And we place 6 sutures, at least we do 6 sutures as U sutures, and tear diagonally. So this is one of our cases, infected IPOM mesh. We had to resect a little bit of bowel and the whole mesh. After 35 minutes of traction, this initial gap of 25 centimeters was able to be enclosed. This is to show you how it works in the course of time. A 16 centimeters gap here. After application of the tension for 10 minutes, you can see already an enlargement of fascia. After 15 minutes, you barely see the green towel, and in the end, you can see that both facial edges touch each other. So for the next 5 minutes, what we're doing is we just put on a even more vertical traction. This is a combination described by Henning Niebuhr, a preparation of the subcutaneous tissue, a preparation of the hernia sac, afterwards an attachment of the facial sutures on the anterior sheet, and afterwards, with only an incision of about 10 centimeters, it's possible to let out the traction sutures transcutaneously. The first publication, about 21 patients, shows, for example, patients like this, a huge loss of domain hernia. You can see the CT scan up here. And this patient had 6 operations before, and this is the result after 30 minutes of traction. And we just resaw after more than 1 year, and there was no sign for recurrence. So the results of, with kind permission of Henning Niebuhr, of unpublished data of 50 patients, we had a medium hernia width of 16 centimeters. The medium facial gain was about 10 centimeters. We had a direct closure rate of 90% and a quite low complication rate of 12%, which was 6 patients, and only 6%, so 3 patients had to be revised in surgery. We think that this is due to a smaller trauma and smaller wound cavity compared with component separations. And in the end, we didn't have any compartment syndrome. Game changer in gastroschisis or omphalocele. I know it's not the topic of today, but we think also here it's quite important to have a quantifiable traction of 0.5 kilograms upwards. And I would like to show you this case of a newborn child. On his birthday, it was a huge or giant omphalocele. We put in the mesh. Afterwards, we put in the traction sutures with 8.5 centimeters of prolapsing organs. And after only 2 days, you can see how much the organs have found their way back into the abdominal cavity. After all about 23 days, it was possible to close him. So I would like to come to my conclusions. What might be a game changer in the open abdomen? I think increasing the intra-abdominal cavity in septic patients is very beneficial, so you lower the intra-abdominal pressure. And you have the possibility of an immediate abdominal wall traction because you don't cause, in the end, another compartment syndrome. In loss of domain hernia, minimizing the trauma, a smaller wound cavity should be beneficial, and respecting the integrity of the lateral abdominal wall in terms of avoiding a compartment syndrome. But we have to discuss if smaller mesh sizes due to not doing a TAR and just having the retromuscular layer are a problem. And in gastroschisis and omphalocele, it's the steady quantifiable traction, which makes it easier for the nurses and for the first time, a possible positioning of the newborns. Thank you very much for your attention. So beenden, ne?
Yeah. It would be nice if we could use our video when we have to moderate question to the host. Yes, please. Thank
Jan, can I ask a question, Jan, while we've got these world experts online?
Go ahead.
My wife has her Botox. She tells me that after about 10 days, her forehead's paralyzed. And I'm aware that some people use Botox 7 days, 14 days, 4 weeks, 6 weeks, etc. prior. Can we get a consensus on when the optimal time is to operate on these people?
If I may answer this, it started with Ibarra. He did wait for 4 weeks. The Australian cut it down. The American used it for different type of patients, emergency patients, and they operate in general between 0 and 6 days after the injection. And everybody knows it does not take effect then, but it does take another effect. Analgesia, much better analgesia, that's much faster there before the relaxation effect comes. I think if Thomas is still on, maybe he wants to comment on this too, but he has the longest experience actually. There are several questions there touching this problem. For example, if there are any physiological study on the reaction of the muscles. I don't know. I know probably all of them, but there is nothing that you can address directly. Then there is an interesting question probably addressed to Anita if she's still on. And this was coming from Eric Poli. But there are too many questions at the same time. Difficult to. Yeah, for example, what are the most common complications with PPP? Can anybody answer this around Thomas?
I can, if you want, Jan. It's Flavio.
Okay. Hola.
Hola. So on my practice, I had a few complications of the port itself, a port dislodged. So the catheter dislodged, I need to reposition. Maybe discomfort for the patient after a few days to walk and ambulate. The most fearful complication is DVT with a possible PE. So I put those patients full AC. Usually I don't use vena cava filters, but there are some groups in the United States, they even put filters in all those patients because of the chronic hypertensive state of the abdomen and high chance of DVT.
Well, Thomas is with us. Can you comment on it?
Yes.
Please.
Our experience with PPP is only with 14 patients, as you can see in the video. But we know have complications in these 14 patients. But we don't use the external catheter to make the PPP. We use an internal catheter, like more or less is a catheter similar to the catheter for the chemotherapy patients.
Portacat.
Yes, Portacat. Similar. It's not the same catheter, but similar one. That's why we don't have complications.
Thomas, what's the optimal time to give Botox preoperatively?
The optimal time only for Botox, 30 days. 30 days.
Then there was another question concerning electromyography. I think you wrote something about it, that it's not very reliable technique to assess the effect of Botox. Can you confirm? Or anybody else wants to comment it? Well, in the beginning, you were using electromyography for finding the best points of injection. That's what you taught me, but then it changed. Because you realized that it's not very reliable. There are so many questions there. I knew that we will need 80 minutes, not 8, but we probably have to proceed. So Jenny, did you go through this question? Is there something that you would like to pick up?
Yeah, I think everyone had a great presentation. I think there's some actually kind of interesting questions directed for Gerion, and talking about the complication rates that you have with your fascial tension technique. Do you want to have a quick comment about that?
Yes, thank you. I think the big advantage is that you only have to do an epiphyseal preparation of the anterior sheet of about 2 to 3 centimeters, because this is where we place the sutures, and therefore you don't have a big wound cavity. And I think this is in the end what really helps to diminish the trauma.
Well, out of my own experience, I would say you very often have to enter the abdomen because you have to resolve the problem of the adhesiolysis and so, but I did not have any soft tissue problems at all in my patients. They were all Botoxed 4 weeks before and closed with help of fascia tension in all layers.
Yes, of course. I mean, all you have to do inside of the abdomen, if you have to do adhesiolysis, it's not anything we could change, but I just talk about the different ways of getting length. And I think for getting length, just by doing tracture and only preparation of 2 or 3 centimeters, if this is sufficient, I think we do gain something there.
Oh yes, well, the 50 patients that you put together now, prospective study, actually gained in average 10 centimeters by stretching.
Gerion, can I just ask, is the fascio-tens applied just in theatre, or are these people on the ward with the fascio-tens on, or are they in intensive care, or what where is it?
You have to make the difference between the elective cases. They are used just intraoperatively, and the other ones are mostly in intensive care unit.
Okay.
Exactly. I think it's 2 indications. If you have the septic patients with the open abdomen, this is for the whole perioperative treatment time. And there, I think the big advantages of lowering the intra-abdominal pressure by tearing it up, and you can combine it with a vacuum system. It's not a problem. But if you only do a LOD hernia, then you just treat intraoperatively for 30 minutes.
Great, thank you.
Great, thank you guys so much.
Yeah, well, I think as interesting all these discussions are, we have to continue. I thank all the speakers for their time. Relax in Australia, get up in the United States, and enjoy the conference. Thank you.
Bye-bye, thanks.
Thank you, everyone.
I'll see you soon.
Thank you. Goodbye, friends. It's my pleasure to host the session 4 for all of you. I've been asked to introduce very eminent chairpersons for this session. Madam Andrea Pakula, she's from the California Thousand Oaks. She's the medical director of the robotic surgery at Adventist Health. And Dr. Jacinta Lampron has expressed her inability to join. We have Mr. David Waddell. He's part of the Epworth General Surgery and Gastroenterology Clinical Institute from the Victoria. And we expect the other faculty to join. May I request the chairpersons to take over and initiate the session on this very important topic, operative techniques, a bird's eye view. Over to you, chairpersons.
Thank you so much for the introduction, and thanks to Dr. Ramana and all of the organizing committee for the invitation to be part of this really incredible conference. So I will take, I'm honored to be able to introduce the first speaker, who is a good friend. here in the United States. Probably doesn't need much introduction, but Igor Belyansky from Annapolis, Maryland, is going to be speaking on a bird's eye view. Is there any role for minimally invasive repairs? So Igor, go ahead and take it away.
Hello, thank you very much for the honor invitation. The title of my talk today is Loss of Domain. Is there any role for MIS repair? My name is Igor Belyansky. I am a Director of Abdominal Reconstruction Center here in Annapolis, Maryland, United States. Here are my disclosures. So again, I was asked to talk about loss of domain. And first of all, this is not your typical hernia. When you repair the loss of domain cases, you change the physiology of the patient, and they can have fairly significant consequences for the patient if they are not ready to undergo the procedure. So the first thing you need to consider when you see a loss of domain patient is not whether to book the patient, or you actually should look for reason why you should not operate them. So again, stop and consider the consequences of your potential intervention and get the patient ready for the surgery. Again, with that in mind, the pre-op considerations that you should have is, first of all, how to reduce everything back. You should consider abdominal compliance. Every patient has different compliance. I think we don't spend enough time talking about this, but a couple of ways to change the compliance nowadays is the utilization of component separation as well as addition of Botox, which helps paralyze the muscles, as well as helping the muscle stretch out by addition of progressive pneumoperitoneum. With those procedures, again, you change the physiology. There is a significant risk of DVT. Consider also weight loss before the surgery, because the weight loss overall is also going to decrease the amount of adipose tissue inside the abdominal cavity, thus creating more room to reduce things back inside. Some people will talk about visceral reduction. What that means is actually excising portion of the viscera to create more room. Again, I think that is really in patients with truly end-stage hernia disease. And once you start considering that option, that really does increase your risks of complications. And it's already fairly major procedure. And as those of you who have done those cases will know that there's very little room for error. And then also to help you make the decisions, imaging does play an important role. In our practice, we use CT scans to evaluate the incarcerated contents, as well as to evaluate the abdominal domain. Case selection that I'll talk about here, you'll see, again, this is not for all loss of domain cases. You'll see that I'm specifically talking about the cases that would benefit from what's called a hybrid approach, where I do part or all of the work through MIS, minimally invasive approach, as well as, but there's some portion of the case that do need to be done, performed through an open access, the old-fashioned way, like excision of extra skin, reduction of the content that still may need to be performed through an open approach. And you'll see in this particular presentation, the patients that I select for this approach, while they do have loss of domain, their defects are not large, and a lot of times they'll have off of the midline defects, not directly through the center. So here's the first case, and the first presentation is for giant inguinal hernias. You'll see I combined two cases for this presentation, but both of the cases are very similar. Both of them had giant inguinal hernias, and this is a CT scan of the first patient who previously had a midline laparotomy for trauma surgery, as well as a very large and direct inguinal hernia that goes below his kneecap. You can see majority of the abdominal contents are in this hernia sac. In order to prepare this patient, we had the patient lose 20 pounds before the surgery. 5 weeks prior to major surgery, we did Botox injection and IVC filter. And for the Botox injection, what we end up doing is we inject 100 units per site at 3 different spots, just anterior to mid-axillary line. And what we do is at those 3 points, we inject at the external oblique level, internal oblique level, and transverse abdominis muscle level. The 3 different points, and we spread about 100 units of Botox per side. This is done 4 weeks prior to any intervention. after we perform the Botox injection, we'll wait 4 weeks because for the Botox to take effect, and then we'll place a peritoneal dialysis catheter. We'll place a peritoneal dialysis catheter and then admit the patient to the hospital and actually perform progressive new peritoneum inflation of the belly. And prior to the day of surgery, we obtain a CT scan. This is the CT scan that you see here. And this is a CT scan that tells us whether we're going to be able to proceed with surgical intervention or whether we're going to cancel the case, because the last thing you want to be doing is going through a case that you cannot reduce things back safely. So you'll see the CT scan here was a lot of air in the abdominal cavity, but you can also will appreciate significantly more room that has been created intra-abdominally after Botox injection and progressive new peritoneum combination to reduce things back inside. This is now the day of surgery.
This gentleman had a previous midline. He has a peritoneal dialysis catheter right here. This is going to be the first port. I'm going to develop the retrorectus space here. On the retrorectus, I'm going to place port 2 and port 3. Again, he had a previous incision here. This is a relative contraindication for performing crossover. A week ago, when I placed a peritoneal dialysis catheter, I actually took any of the adhesions down. Before crossing over, in fact, in this case, I'm going to place port 4, develop the right retrorectus space. Then I'm going to cross over and connect the spaces together. This guy also has a left hernia. So before addressing the right side, I'm going to place ports 5 and 6, and I'm going to address the left side. I'm going to do a transverse abdominis or limited. When I say transverse abdominis, all I'm going to do is essentially, this is line represents the arcade line. I'm going to just divide the arcade line and do bottoms up to just up to here to develop a large space right here. I'm obviously not going to be able to reduce this hernia. We're going to make a hockey stick incision. I'm going to reduce everything back. I'm then going to be able to place my meshes, and then the plastic surgeon is going to come in and do sclerotoplasty. Okay, stop.
So now we're gaining access to the left retrorectus space. This is done with FIOS first entry port. And direct vision, we're going to place a second port. And dissection is going to be taken all the way down to the space of Retzius through the left retrorectus space. After placing an additional port, we're then going to pay attention to the medial aspect of left posterior rectus sheath as it contributes to the linea alba. And the contributions to the linea alba are going to be divided just a little bit lateral to linea alba. And this way, as we divide the posterior rectus sheath, we enter this preperitoneal space superficial to the phospholingual. So this is our crossover. The port 3 is placed next. Again, it's and then in this case, we developed the right retrorectus space already, and this is a true crossover, whereas there was a hook cautery. We're dividing now the right posterior rectus sheath. You can see the peritoneal dialysis catheter in the field. This can be pulled out, and so now we create this space of a space and retrorectus space of connecting the left and right retrorectus space together. We then are going to divide, as described earlier, the posterior lamellar thromboembolic and transversus abdominis aponeurosis, entering the space superficial to transversalis fascia. And the goal here, again, is to be able to, first of all, get a little bit of extra release to be able to reduce the contents back together without much tension, and also to be able to dissect around the actual neck of the hernia sac, but understanding that I'm not going to be able to reduce this all back laparoscopically. But because the defect itself is not very large, it's actually very difficult to work through this. So this saves me making an extra incision. But here I am. Now the retromuscular dissection is completely performed before the sac is reduced back. The next part is the open reduction of the contents. So again, at this point, what I've done is completely create a very large retromuscular space. I also prepared the left hernia. And so now is the actual reduction where the sac is open.
They come over here, bud.
And everything is reduced back intra-abdominally. And all I'll have to do afterwards is incise the neck of the hernia sac, and I am in this retromuscular space that I have created for mesh placement.
Good enough just to show. We'll get some more. You can take some pictures now.
This is opening of the sac.
So we're entering the sac now. Open this up and we'll take a look. inside to see what it looks like. All his intestines right here. And drop down in here. All right, that's good. So show me, Rob, I have a camera on. So can you show me the testicle? All right. Academic.
So the defect, the contents of the hernia were completely reduced back intra-abdominally. At that point, we have a urologist actually looking at the testicle. Of course, an argument can be made that the testicle does not need to be preserved, but in this particular case, we were able to get Doppler signals, and there were good flow of venous and arterial flow here, a little of a hydrocele here that our urologist is going to fix, and we actually preserved the testicle in this case. Again, everything is back inside, so now the only thing we have to do is place the mesh in this retromuscular space. But before doing this, the urologist is finishing their part.
Yeah, I do.
Now this is a look inside. You can see very large macroporous polypropylene mesh overlapping the whole space, and also in the right myPT orifice is completely overlapped with a 3D Max mesh. The defect itself was closed from outside from the open reduction incision, and then everything kind of gets closed down, and the air gets desufflated, and this is what it looks like inside. Now we just have to close the hockey stick incision and place the testicle back into the right hemiscrotum. Fairly dramatic difference. You can see how the belly kind of now is more rounder now that you reduced back the contents where before it used to be flat. This is another case, very similar thing. This case was not all, this was mostly his intestine, but then we went up to his knee. His actual sac went down to the ankle, but a lot of this was filled with fluid, acidic fluid, which was all suctioned out. And this is what the gentleman looks like a few months after this surgery, exactly the same procedure. And you can see again, very protuberant belly after everything is reduced back. So again, understand that the physiology of the patients is changed after you reduce everything back. So you have to get them ready. So the several months work that we had to do before really paid off here, because all those patients were, most of those patients were able to discharge within 4 days after the surgery. Another case here, very similar in nature. This is a right lower quadrant defect of somebody with history of open appendectomy that then was followed by a laparoscopic IPOM repair, which recurred fairly quickly. And then this gentleman let this thing go. And when he presented to me, he had majority of his abdominal contents through this kind of flank lateral defect, just lateral to linea seminal narrows on his right side. This is a CT scan. Again, appreciate that majority of his abdominal contents outside. Again, the defect is not large. The midline is still preserved. So again, this is a good candidate for this type of hybrid approach that we just showed you for the inguinal hernias. In similar fashion, I had this gentleman lose some weight, did Botox, did progressive neoperitoneum, exactly identical to how the previous two cases were just described. And in this case, we proceed to do the surgery robotically. And again, but before doing that, this is a CT scan. You want to make sure there's plenty of room to reduce the contents back intra-abdominally. And the CT scan that was done a day before the surgery indicates that there's plenty of room to reduce things back inside without, and the patient would be able to tolerate this procedure. See, as we'll scroll back, plenty of room for intra-abdominal contents to be placed back inside. One thing that I mentioned, I place IVC filters in all those patients as they are at higher chances of thromboembolic events as consequence of these procedures. ETAP axis approach in this case, but now robotically. This is 3 ports into left retrorectus space. In similar fashion, the medial contributions of the left posterior sheath are divided, entering the space superficial to the falciform ligament. Everything gets placed back down. Those of you familiar with ETAP axis dissection, this should be very kind of familiar view to you. This is the crossover, the contralateral retrorectus space. Kind of the space is connected together. Again, the goal is to create this large space to overlap. So there's a couple of things that, first of all, we're creating the space for the mesh and also doing a releasing incision to, again, help us reduce the contents back intra-abdominally and, again, to allow the patient to tolerate this reduction in postoperative period without significant change to his or her physiology. Transverse abdominis release is performed to get just lateral to linea semulnaris, again, to fully overlap this lateral defect that's just lateral to linea semulnaris on the right side. And you'll see that as we dissect superficial to transversalis fascia and peeling away the muscles from the transversalis fascia, we're essentially going to encircle the hernia sac. Again, we're not trying to reduce things back intra-abdominally, but if we were to reduce the contents back before performing this portion, then this portion, there would be no room to work in here. So again, these steps are making it actually easier for me to perform this type of dissection before the actual reduction is done. So I'm doing this not because it's fancy, I just think this actually makes the procedure easier to perform. This is the right myopathy orifice, the core structures are right here. And right here, you'll see as we move up, you'll see the hernia sac, the neck of a hernia sac that we're gonna address in a second. This is an old mesh here. Again, we're completely encircled around the neck of a hernia sac. So the next step is the open viscera, open reduction of the contents. So now opening the sac. And in this particular case, the patient had fairly significant intraloop adhesions, so it took some time to perform open adhesiolysis, followed by the reduction of contents. Now, this is my resident intern who is reducing things back inside. This case is actually from about 4 years ago. You can see how easily things reduce back. And the next step is all I have to do is incise the neck of a hernia sac from inside. And now I'm in the retromuscular space that I initially developed. The posterior layer gets closed, mesh gets placed, the anterior layer gets closed, and then I can laparoscopically or robotically completely assure that the mesh is sitting nicely in the flat position under direct vision. There's no guessing. And I think it's very important to assure that the mesh is nice and flat to provide adequate integration between the muscle layers. Again, the mesh circles all the way down, and it provides posterior coverage of the myopathy orifice here as well. This is a before picture, and we took a lot of the skin off, and you can see small incisions, and everything was reduced back. And this is what he looks like 8 months later. And this, again, was a few years ago, and this gentleman is doing quite well in long-term follow-up. So again, what I've talked about is MIS approach to loss of domain. This is done in selected cases. I want to emphasize this. Whenever you see loss of domain, whether you do it MIS or open, please do not rush to operate. The most important thing is setting yourself up for success and preparing the patient by losing weight, addressing their comorbidities, use Botox, use a progressive neoperitoneum, understand the consequences of using progressive neoperitoneum and risks associated with that. You know, when appropriate, consider the multidisciplinary approach. In those big cases with excess skin, I think it's very prudent to involve plastic surgeons. I also think that urology and then big inguinal scolar hernias that go down below the knee are also should be involved, especially if you need the catheter placement. Those can be quite challenging to perform. That's with that in mind. Thank you very much. And I wish everyone the best of luck in India. I wish I could be there in person, but hopefully, maybe soon that we'll be able to get over this COVID-19 pandemic. Have a good one. Best of luck. Hello. Thank you very much.
Do we have Professor Flavio for a quick comment here?
Yes. Hello, everyone.
Please.
Thanks for the Hello, everyone. Thanks for the opportunity. It's hard to make any comments after Igor's presentations. I'll try to make some few quick ones. I think the number one message from his lecture is stop and think about it. Think if you are the right surgeon for that procedure. Think that if that patient is the right fit for you, if your institution has the resources, no matter how bad the situation is, we can always make it worse. So first, take a deep breath, judge your limits, judge your resources, and then move forward. I feel that hybrid procedures are something that we don't use so often, but it's really interesting to see how MIS surgeons, and I think I am MIS surgeons, we feel much more comfortable to see and open a mesh on a space when we do a scope than just open surgery. I'm pretty sure there's a great number of open surgeons that will do the same cases that Igor presented just by open surgery, and that's okay if they really feel comfortable with that approach. I think that he brought something different, some hybrid approach to the same problems. I like that very much. I have a question for Igor that I struggle myself. Those patients, they did not have midline problems. The inguinal hernia and the right lower quadrant hernias, the midline of those patients was intact. How do you feel about transect the posterior rectal sheath on an intact linea alba to get your, on the second case, the overlap, and the first case, just the expanded cavity? And would you consider plicating that normal linea alba before a mesh, or just transect the posterior rectal sheath bilaterally and just spread the mesh open? That will be my only question.
Sure, Flavio, thank you very much for your comment. Again, very, very kind words. To answer your question, in those particular cases, again, this is completely, different cases with loss of domain. And in my mind, I want to get as appropriate of overlap as I can, as kind of the saying goes, the giant overlap of the visceral sac. So I truly want to kind of capitalize on that. So to me, this is not a big issue of, actually violating in those particular cases, the posterior rectal sheath, and then as well in all three cases that will present the at least a portion of transverse abdominal sweep, because it changes the compliance of abdominal wall and helps as well, in addition to bullets, helps expand the abdominal wall. And in addition, then everything is afterwards is overlapped with mesh. One of the cases actually had a previous midline incision, one of the giant inguinal hernia cases. And in that case, I was certainly very worried that when I reduced things, having to deal with a hernia down the road through the midline that did not have a hernia at the time of the surgery. So again, that was overlapped and in the preventive fashion as well. So no, not a great concern. Now in those cases, I think it helps. And I think the giant overlap of this area helps, and as well as it increases the compliance. So at least, especially in early periods, to help house all the visceral contents back inside the belly.
Yeah, but my question, Igor, is would you plicate posterior linea alba once you open the rectal sheath, or just leave it as it is once there is no hernia?
I got you. Okay, so if they have, in those, none of those cases really truly had a diastasis to plicate. If somebody had diastasis, yes, I would plicate that before reduction, because I would actually worry about further migration and a weakness. So yes, I plicate diastasis for different reasons we don't talk enough about. Unstable abdominal walls related to the diastasis stuff. Too great for cutting of the posterior sheath. So yes, at the time.
Okay.
Igor, we lost most of what you said.
Oh, I'm sorry. So I said, if somebody had diastasis, I was liking it, but in the 3 cases presented, the patients did not have diastasis, so I did not have to liking that. But if they had grade 2 or 3 diastasis, yes, I was liking it before leaving the operating room. Hopefully you guys heard me.
All right. Thanks, Igor, for a amazing talk, as always. I would like to introduce Lars Jørgensen from Copenhagen in Denmark, who I had the pleasure of meeting at the Romanian hernia days back when we were allowed to leave Australia. He's talking on anterior component separation.
Hello, everyone. It's a pleasure for me to participate at this workshop on loss of domain. My task has been to talk about anterior component separation as one of the measures to treat this condition. First of all, I want to say that it's quite a complicated picture when it comes to choice of additional procedure to a hernia repair in a patient with loss of domain. My task today has been, as I just said before, to talk about anterior component separation. The traditional Ramirez technique was an open approach, and it included substantial dissection, raising huge flaps in order to reach the external oblique aponeurosis, lateral of the rectus muscle and lateral to the linea semilunaris, to obtain the external oblique division and hence release. It was a very efficient technique, claiming to obtain about 8 centimeters at the umbilical level on each side. And in addition, 2 centimeters could be achieved by incision of the medial aspect of the posterior rectus sheath. And in this way, tension-free repair could be achieved. However, there is a price to pay by this wide dissection in the subcutaneous tissue. Very often, most of the perforators are divided. They originate from the rectus muscle and supply the subcutaneous tissue and skin. And it's not surprising that many old series reported a high rate of wound morbidity in 1 out of 3 to 1 out of 2 patients. So how to avoid this wound morbidity? And I would say that all these techniques that, and many of them will be covered through this workshop, are associated with a reduced risk of wound morbidity compared to the open traditional Ramirez technique. I will shortly touch upon open umbilical perforator sparing technique. This can either be achieved by the tunnelated technique, where the external oblique aponeurosis is reached through a narrow tunnel from the medial wound. And then by a blind dissection technique, the surgeon will be able to divide the external oblique all the way from the thoracic part of the muscle down to the inguinal ligament on each side. However, it's a blind technique. It's difficult to see what actually goes on there. More simple is the transverse incision technique. 2 horizontal 6 to 8 centimeter incisions are made on each side of the medial wound. And this allows to divide the external oblique from the anterior side, again from the thoracic part down to the inguinal ligament. We have worked in our institution a lot with the endoscopic technique and found a small trick to achieve a more easy approach to the correct plane. So we mark the lower costal margin and measure about 14 centimeters from the xiphoid out lateral. and 4 to 5 centimeter cranial to the lower costal margin, where there is a point there, the medial point, for 3 centimeter horizontal incision on the anterior lateral side under the thorax of each side. Why do we do this? It's because in this area here, anterior to the ribs, there is only the thoracic part of the external oblique muscles anterior to the ribs. So once you get through the external oblique muscle fibers and anterior to the ribs, you are in the correct plane and can bluntly dissect towards the abdominal region, insert a balloon trocar that you may be familiar with from TEP procedures. So this is not a subcutaneous technique, it's an intermuscular technique, because we guide the balloon trocar behind the external oblique and anterior to the internal oblique once you enter the abdominal region. This is the view on the right side of the patient. I will demonstrate this in a video later on. And it's seen from the cephalad direction. The view inside the balloon demonstrates the external oblique muscle fibers on top, and on the floor you will see the internal oblique fibers running in a perpendicular fashion. The medial part to the left is linea simulinaris, and behind that you will find the rectus muscle, which is of course not seen during this procedure. Then the balloon is removed and cautery scissors are introduced together with a videoscope. And this allows division of the external oblique aponeurosis, about 2 to 3 centimeters lateral of the linea simulinaris. And I will run through these details of the procedure. First, we mark the lower costal margin in this patient who has a 14 centimeter defect, a midline maximum defect. Here we measure, as I just mentioned, 14 centimeter in the lateral direction with reference to the xiphoid process. And importantly, you are on the thorax about 4 to 5 centimeters cranial to the lower costal margin. I have briefly marked the rectus muscles here. So this is important to get lateral of the rectus muscles. This is the view from the right shoulder of the patient. So you're looking on the thorax and you can just see the marking of the lower costal margin down there, division of the external oblique muscle, and you get anterior to the ribs, lift up the external oblique muscle so you get behind this, and dissect bluntly with a trocar, a balloon trocar, inflate the balloon so that there's no air leakage. Now a 5 millimeter trocar is introduced to allow access with cautery scissors. And here I want to demonstrate the perpendicular architecture, the external oblique muscle on top. The yellow part in the left side is the medial aponeurosis, and in the floor you see the internal oblique. So we just made this balloon dissection and we have removed the balloon and now divide the aponeurosis, which has very little vessels in it. It's also important to divide the loose alveolar connective tissue to provide enough release of the floor, the internal oblique, together with the rectus abdominis for medial mobilization. This dissection of the connective tissues is continued all the way to the mid-axillary line. More importantly, also scarpa subcutaneous fascia must be divided to provide extra release of the external oblique aponeurosis. So you get a very, very wide mobilization, as you can see here. And during surgery, you really recognize that there is a lot of tension on the external oblique aponeurosis. At the end of the operation, it's very easy to divide the thoracic part of the muscle fibers through the balloon trocar wound. This is important, as also stressed by Ramirez, if the patient has an epigastric location of the hernia. Why do we do this? This is in order to, as I said before, reduce wound morbidity. It has been demonstrated in small meta-analysis and also quite recently in a material here from America, reducing 30-day surgical site occurrence and 30-day readmission. So the conclusion is that using these perforator-sparing, minimal invasive anterior component separation techniques, you obtain less wound morbidity, even though sufficient myofascial release is obtained. No increase of cost. Recurrence rates is about the same as for open component separation, and lateral herniation is extremely rare. Last but not least, welcome to Copenhagen if you have a chance to go there in middle of October this year for the Joint Hernia Congress between EHS and AHS. Thank you very much. It's been a pleasure to contribute here.
Thanks, Lars, for a great talk. I think we're running a bit late for time, so we might move on to another friend of mine, Ramesh Punjani from Mumbai in India, who is a very esteemed member of the AWR Surgeons Group and has an extensive experience in open TAR. He's going to talk about.
We are playing my video, no? Hello.
Yes, sir. Yes.
Respected chairpersons and fellow delegates, I would thank the organizers of LOD Global Summit 21 to give me this opportunity to address this August gathering. I'm going to talk on posterior component separation, that is PCST. I am Dr. Ramesh Punjani, President of Abdominal Wall Reconstruction Surgeons Community. I bring greetings from Mumbai. I have no conflict of interest. If you see the publication which is there on LOD, so this is a chapter which is written in Textbook of Hernia Surgery Current Principles, which is Yuri Novitsky's edited books. And that says that component separation increases the size of abdominal cavity. So for the loss of domain cases, the component separation is a boon and it causes an increase in size and decreases the intra-abdominal tension, which is that is what is required. If we see, there is an evidence also by this particular paper, which was appeared in Annals of Surgery, May 2010 by Sonia et al. And they actually have measured the intra-abdominal volume in a patients who have undergone a component separation for a massive ventral hernia. And they also concluded that the component separation technique restores the lost abdominal domain by increasing its volume. So the lost domain of the abdomen, it comes back with this component separation. So the component separation do remain the answer for the patients with LOD. Now, what is posterior component separation? So that's a Professor Yuri Novitsky has actually designed, and this is now being known as a transverse abdominis release, as a TAR. And that is what has actually taken the whole world by its feet. And more people are now doing a posterior component separation rather than anterior component separation for most of the cases of LOD. So, and that is very obvious, because if we see this diagram, which is again from the same textbook of Hernia Surgery Current Principles, the transverse abdominis muscle is actually a transverse fibers. And these fibers act as a corset by creating a hook tension around the abdomen. Going by this, it is very obvious that the division of this should reduce the tension. So the moment we divide the transverse abdominis muscle, the tension inside the abdominal cavity reduces, and that will now be able to accommodate more and more viscera which has been eviscerated. And that is actually what we need in a patients of loss of domain. So transverse abdominal release is a boon for our cases with loss of domain. If we see the evaluation of anterior versus posterior repair, so this is one experimental cadaveric study which was done by Arnab Majumdar and Novitsky's group, and which actually has been published in Surgical Endoscopy 2020. And where what they did is that in a fresh cadavers, they actually did an anterior component separation and a posterior component separation. And for each of these steps of this surgery, they actually measured the myofascial release which they would be getting it. And they found these results that in an anterior component separation cadaver, The advancement of anterior fascia was with subcutaneous was 6.4 centimeter, with external oblique it was 7.8 centimeter, and where the retrorectus dissection was added, it became 8.8 centimeters. So this is where the one side of the component separation. And similarly with the posterior component separation, if you see the figures are all higher. And that especially the retromuscular one is done, it is almost 10 centimeter from each side. So almost 20 centimeter large defects would be able to close with the transverse abdominis release. And of course with the PCST, there will be also advancement of the posterior fascia to a very big extent. So this is what is the beauty of this procedure, where it is actually a more myofascial release. Now, once we decide to do an PCST, what are the prerequisites? So again, this is there in the textbook of hernia surgery, where he has written, Gregory, that patient preparation requires 5 parameters. The one is the tobacco should be stopped 1 month prior and 2 months after the surgery. The albumin, the serum albumin should be more than 3.5, and if not, then you have to do a nutritional correction. HbA1c in a diabetic has to be less than 7. If not, you have to involve the endocrinologist and make it so. Prehabilitation, the patient has to be mobile, and minimum 30 minutes of walk per day should be there for this patient for last few days before the surgery. And a BMI has to be less than 35. If not, then a diet consultation or a bariatric procedure for a very high BMIs. So these are all the different steps of surgery, which include incision, packing of the abdomen, incision of posterior rectus sheath, retrorectus dissection, TA release, and a retromuscular dissection, followed by a PRS closure with the zip sign, which you can see when you're done comfortably. When you cannot, in some patients with the intraperitoneal mesh is being excised, you may have to patch it up with vicryl mesh. So every time person doing a posterior component separation must make an availability of vicryl mesh with him. And so also the tap block before the end of the procedure, followed by insertion of a very large piece of mesh, which is usually a medium weight polypropylene, but sometimes in LOD, it could be even a heavyweight polypropylene, and then a closure of the anterior abdominal wall, followed by a perfect skin closure. So this is in a nutshell is the different steps of TAR, which will not go into details, but few important steps that we'll see is that always the sac needs to be preserved. So the sac is divided into 2 hemisacs, and one part of the sac goes along with the anterior rectus sheath, the other goes with the posterior rectus sheath, and these 2 flaps are preserved till the end of the surgery, where you can use them for a bridging if required. The another important point while doing a transverse abdominal release is that a linea alba is given a traction, so also posterior rectus sheath. Now, it has to be done in such a manner that you divide the posterior lamella of internal oblique followed by transverse abdominis. But in case the retraction by the assistant of the posterior rectus sheath is higher, you may actually slip in and may start dividing the linea seminaris. So that is one of the very, very important care that has to be taken when doing a posterior component separation. And of course, then the amount of mesh that has to be used. So typically a 30 by 30 centimeter mesh in a diamond format is used, but that's not adequate in most of the cases of LOD, and you will have to supplement by another 30 by 30 in a rectangular fashion, making it an inverted home plate, or maybe a bigger meshes of 50 by 50 that will take care of this problem. So at the end of the TAR procedure, there has to be a picture like this, where there is a big piece of mesh which is lying in the sublay position, going into the place between the divided transversus abdominis and the transalis fascia, and it reaches right up to the paraspinal muscles on either side, and longitudinally it goes from right from diaphragm to the pelvis, and that's how there is a complete giant prosthetic reinforcement of the visceral sac. Now there are certain precautions while closing the anterior fascia, and that we have to measure the plateau pulmonary pressure on an anesthesia machine. If the rise is more than 6 units, it will need an overnight ventilatory care. So this patient should not be extubated, should be wheeled into ICU, and they should be monitored overnight. If it is rising is more than 11 units, that's really an alarm, because it's a setting in of abdominal compartment syndrome. And you have to, then what you do is that you will probably untie those things and check for completion of TAR. Many times, you will realize that something more can be released by doing a completion of TAR. And if that is not so, a bridging repair is definitely an option. But then the bridge portion, now here in this patient who had a very large loss of domain with a very big defect, we could not close it by all the means. And then what we did is we just sutured the edge of the mesh with the defect, and then we covered with a thick sac which was saved. So that's how this surgery is done. For a completion of the TAR, it is usually this right and the left upper quadrant, where if you enlarge this and see, so it's a decussation of the vertical diaphragmatic fibers with the transverse abdominis fibers, and one has to separate till then. That is what actually gives a most of the time completion of the TAR, and the bridging is avoided. Similarly, near the central tendon, in the center, in the cephalad portion, when a transverse abdomen is done, this division has to actually converge. Otherwise, if you go straight, you can actually hit the central tendon and may do a iatrogenic Morgagni's hernia. Now, there are a lot of cases we have done over the last 2-3 years, and these are the patients who had a really big loss of domain with a very large hernia, practically no abdominal wall. This patient had a skin graft and then again had a big hernia. This is one more patient, who had a hernia. There's one lady who had a very huge hernia, and this is another one with a huge hernia. So we have a sizable experience of these LOD cases, and we in fact published our first 100 cases of TAR in a hernia journal just very recently. And what we have about almost 100 cases, out of which 14 had a documented loss of domain with a Tanaka index of averagely 37.5, the defect size of around 13.4 centimeter, and we could close midline in all but 3 cases. So a well-done TAR is always an asset to a surgeon, and we had no major complication and no recurrence so far. The PCST versus ACST, which is better? So advantage of PCST over ACST in cases of loss of domain is that since you're not raising any lipocutaneous flap, the skin necrosis doesn't happen. The surgical site occurrence, surgical site infection, surgical site occurrence requiring procedural intervention and therefore readmission, all is less in posterior component separation as compared to anterior component separation. You are putting a very, very wide prosthesis, and therefore the repairs are very lasting. The recurrence rates are all in single digits in most of the series. And the versatility of this procedure, that you can do this for atypical lateral parastomal hernias all across. So PCST is an ideal solution for large metal hernia with LOD. Even the lateral hernia, now this patient had a iliac blade which was removed for chondrosarcoma, and there is a huge defect with a large evisceration of the contents. And this patient actually underwent a bilateral TAR, and we could actually close the defect and bring back the cylinder back into action. And we had to use a bone anchors on the bone to really fix this mesh firmly. This patient is doing well for last 2 years. So you can see a bone anchors here over fixed. I thank you very much for giving me the opportunity, and I would be ready if there are any questions to be asked. Thank you so much.
Thank you, Dr. Ramesh. Dani sir, Dr. David, you want to have a quick comment on this?
Yeah, thanks, Ramesh. That was a great talk. I think we're going to move on now to Dr. Andrew DeBow from Edinburgh, who's talking on his peritoneal flap technique.
Thank you. I've gone live now, so I hope you can hear me. And if you don't stop me, I will keep going. So the
Go ahead.
These are my disclosures. And I guess, like many operations, the inventor is never the inventor. And I would have to say that a lot of credence has to go to this man, a Brazilian surgeon who published initially in the Portuguese literature and then the English literature. And our operation of the peritoneal flap is very similar.
Yet. Sorry, Andrew.
Yeah.
We can't see the video yet.
You'll
have to share the screen.
I have shared my screen.
No.
I will go back to share screen again. Can you see my screen?
Now it's happening, yes.
Now it's perfect.
There we go.
Sorry. Okay, so the peritoneal flaps. Sorry for taking up a bit of time with the technical hitches. These are my disclosures. And like many, as I said, like many techniques, we owe it to this gentleman. He developed this 3-layer suture technique where he used the hernial sac and part of the anterior rectus sheath and the posterior rectus sheath to produce this 3-layered suture closure. And in essence, we use the peritoneal flaps in a similar way, but we omit the middle suture repair and replace it with a mesh. Now, this is a reasonable sized hernia. It's not huge, but it's a reasonable sized hernia. And One of the real problems was calling the operation the peritoneal flap technique, because as soon as we mentioned peritoneum, people thought this was a very thin, stretchy component, and we probably should have called it the hernia sac technique. Now you can see from these sections of CT scan of the gentleman you've just seen with a very wide defect, that the hernial sac is remarkably thick. And even the area that's been skin grafted or allowed to heal by secondary intention, if you can deepithelialize that, that is also a thick layer, and there's no need to excise most of it, but keep it. And we're talking about loss of domain, and I'm not sure how you calculate loss of domain here, and I'll come back to that shortly. Is it the bit that appears to be outside the abdominal cavity, or is it the effect that once you close the circumference of the abdomen, it's everything that's outside the abdominal cavity? And here's what I mean. If we look at this sort of caricature of a hernia, the fixed black line is the abdominal wall, and the dotted line, the hernial sac. And the blue arrows identify the medial ends of normal tissue. Now, if you just bring those together and there's very little elasticity in the abdominal wall, you will reduce the circumference and reduce the radius or diameter of the cavity that you have left. And we remember that a severe, a very simple equation, is the radius to the power of 3. So it's a radius cubed. So a small reduction in radius has a big impact in reduction in volume. And that hatched area is actually the effective loss of volume. So virtually every incisional hernia where the muscles are apart and you bring them together and there's a degree of lack of elasticity of the abdominal wall, you have a degree of loss of domain. It might only be a few percent, but very quickly it adds up. And I'm not sure that these concepts are addressed by the Tanaka or indeed lots of other CT scan techniques to calculate loss of domain. But using a peritoneal flap technique, and the guy has plenty skin, which you can mobilize and bring together, you're able to reconstruct him. Yes, he still has a bit of a pudgy belly, but I suspect that was his appearance right from the start. Here's another lady, gynecological surgery. Clearly it healed badly. There's been some injury to the rectus muscle on the right. It's not there anymore on the CT scan slice. And again, a reasonable width. What's the loss of domain? Hard to say, but when you bring her together, she is likely to have significant loss of domain. But yet you can do an abdominoplasty, excise her previous lower midline scar, take away a significant amount of skin and soft tissues, do a peritoneal flap repair, and she looks pretty good. And here's a couple of years after the repair, because it's a follow-up CT scan for malignancy. Most surgery in the peritoneal flap in particular doesn't produce miracles. I can't reinvent her right rectus muscle. It's gone forever. But the fascial planes are usually there, and we have a mesh covering the space, and she is an intact functioning abdominal wall, which you can see is rounded rather than the pre-op one where there's a sort of floppiness. And that's the concept of abdominal wall reconstruction. You want to restore the myofascial ring, the cylinder that we've heard talked about. We hear a lot of nonsense too about the midline, and the midline is important. I don't want to bash the midline, but in a lateral hernia, the midline is intact, but you still have abdominal wall dysfunction. So it's not about getting the midline together at all costs. It's about restoring the myofascial ring. And with the increasing loss of domain, it's using techniques around that to restore the myofascial ring. And as you know, for many people, it's getting the context back in. And it's like stuffing a sleeping bag back into its sac. And the more you stuff it in, the more pressure you'll have within the system. Now you can make the sleeping bag smaller, and we've heard about that, weight loss. Bowel prep, we know, increases wound infection, so don't do it. And obviously chopping out bits of people does buy you volume, but it increases the complexity and risks of surgery. So the mainstay is clearly making the sac of the sleeping bag bigger. Botox we've heard about, PPP we've heard about. And then my next step is peritoneal flap. And if that's not good enough, then you can add in component separation. There's fasciotens that we've heard about. And obviously, finally, there's bridging. Now, a lot of people get quite excited about the peritoneal flap and think it's a new technique. It's not a new technique because it's based on a reef stopper retromuscular repair. And if you can do that for a midline, you can do a peritoneal flap with ease. A couple cases and you're flying. And the bottom line, without going into too much detail, is keeping the hernial sac attached to the anterior rectus sheath on one side, the posterior rectus sheath on the other, And yes, inducing a degree of divarication, but allowing a mesh to be inserted as per usual for a retromuscular repair. So let's rattle through this gentleman. He's a big tall guy, which does make hernia repair a little bit easier. Major abdominal wall defect. He did have Botox, so excise the scar, raise skin flaps back to healthy tissue. That just helps tell you where you are. And you're going to do this as part of an abdominoplasty. That's why you're doing it open. If you're not doing an abdominoplasty, try a minimally invasive technique. Laparotomy, as you've heard, through the center of the sac. The head end is the black arrow end, and take down adhesions to the anterior abdominal wall. And then, like any retromuscular operation, on one side, you're keeping the flap attached to the posterior rectus sheath. And so behind the rectus muscle, and very quickly, we've now completed that dissection. The flap attached to the posterior rectus sheath, crossing way across the midline. We're going to get this man together quite easily. On the contralateral side, you're keeping the flap attached to the anterior rectus sheath. So again, a standard retromuscular repair, and you end up with a relatively short piece of tissue at the back, as it's often the case, because you only have 6 or 7 centimeters of muscle typically anyway. So the yellow is the sac, a posterior rectus sheath. And then you start closing, and this is my preferred way of closing. The blue arrows indicate the medial end of the posterior rectus sheath. So this is flap. In this case, I'm not using all of the flap. You sort of guesstimate by pulling it together how much you need. You put your sutures in, and then you bring it together. And this is almost, as you're bringing it together over sometimes 5-10 minutes, it's almost like an interruptive fasciotens in a sense, because as you bring the tissues together, you spread the load, and it allows you to get what you think might be impossible to close together with actually relative ease and really with no change in airway pressures from the anastos. So again, I'm only using some of the sac in this case, not all of it. And then you've got closure of the back layer. The blue arrows indicate primary posterior rectus sheath to primary posterior rectus sheath, and the yellow arrows indicate the amount of hernial sac that's been used to close the back wall. Put your mesh in, drains to taste, and do exactly the same thing at the front wall. The blue arrow indicates the suture line, and the inked line is the medial edge of the anterior rectus sheath on the contralateral side, and that's the amount, about 5 centimeters of maximum width of sac used to get closure in this case. There's no way that this would have come together without some form of component separation. So it's not massive divarication you're inducing, it's relatively short divarication. A major excision of his scars, such as stoma site scar, is now touching his midline scar. And 2 years later, yeah, there's been some widening of his scar, but you can see that he's got the contour, he's got a flat tummy and a tummy that functions because the myofascial ring has been restored. What about transverse incisions? Well, you can do the same thing, particularly above the umbilicus. As you get close to the iliac crest, you have a problem, but you're working between internal oblique and external oblique. And if you have to go retrorectus, you then have to divide this slip of internal oblique that forms the anterior rectus sheath to turn that into one cavity. This has been described in our paper published in 2021. So you keep the flap attached to internal and transversus on one side and to external oblique on the contralateral side. Why that plane? Well, it's avascular. The neurovascular bundles aren't between internal and external oblique. And as we've heard already today, external oblique doesn't attach to the costal margin. So there's no hernia too close to the costal margin because you can get your mesh above that as part of the repair. So then your typical open cholecystectomy, a scar is easy to fix. And once you've got the hang of those, then you can have fun after major pancreatic surgery, a pretty large lateral hernia. Yeah, he's not going to be beautiful, but that's a reasonable result and functioning result. Is this a bridging technique? We've heard several authors, several speakers today refer to this as a bridging technique. Well, we're good at building bridges in Edinburgh. We've been building a bridge over this stretch of water for the last 3 centuries and with some success. But bridging, we know that bridging techniques don't tend to last too well and you get a fair bit of bulging. So does it work? Well, very briefly, we published results. So 2010, we've done quite a few, so we got the hang of it. We chose that period so that we had good follow-up. The minimum follow-up was 2.5 years, but just over 5 years was the average follow-up. A lot of midlines, some transverse, and obviously the openness of the surgery was because a significant number were having an abdominoplasty. And these were our results in brief, and you can read the paper for more detail. But at 5 years, a mean follow-up, 3.5% and 1% for the transverse wounds. One mesh was lost, but that will be always the situation, this sort of thing. And this was pre-Botox, so we did have some component separation, mostly anterior, because the back layer tends to be more stretchy and comes together more easily. But in more recently, component separation is virtually not done, except for TAR when there's a stoma involved, because I do think you get better lateral positioning of your mesh with a TAR in the stoma along this sort of Eric Pulley type repair. But that's all very well when you present your own data. The Scandinavians of Agneta Montgomery and Ulf Peterson developed a similar technique. They call it the modified peritoneal flap because they do it slightly differently. This is not a randomized trial, but this is 2 series of them, a conventional retrorectus repair without the flap and a modified peritoneal flap. They are not overlapping series. There's a slight difference in time, and therefore the follow-up is slightly different. But interesting, the modified peritoneal flap are slightly bigger hernias. There was more likely to be concomitant GI surgery, and there was more likely to be a stoma present, all things related to wound infection and increased risk of recurrence. So the modified peritoneal flap are set up to fail because they are bigger hernias with more complexity. And while not presented in number format, there was a throwaway line in the paper that the modified peritoneal flap also had higher comorbidity. This is the outcome. Yes, the follow-up is different, but we know 1/3 of recurrences happen within the first year, and the follow-up is 2 years. Patient satisfaction is something that was assessed as part of the registry, and the modified peritoneal flap were slightly happier. But this, really the thing that jumps out was the recurrence rate is almost an order of magnitude less than a conventional retrorectus repair, which doesn't really make sense when you're using something which you think is bridgy and is called a bridging technique. So why might the peritoneal flap be better than a more conventional retrorectus? And I don't know. There's lots of theories, lots of concepts, but perhaps the use of the flap does allow less reduction in volume of the abdominal cavity because of the loss of domain issues. I don't see abdominal compartment syndrome. I don't have anesthetist telling me, what have you done? The airway pressures have gone up, not by 6 millimeters or 9 centimeters of water, but by nothing by using the peritoneal flap. So there does seem to be some benefit there. Does it last? Well, we know that long-term follow-up of hernias is a nightmare. Patients disappear, they're not interested in coming back, they don't answer the questionnaires, but sometimes we can follow them up. This poor gentleman, a very keen squash player, Crohn's disease, multiple laparotomies. He had a bit of a bother. He was repaired. This is him a couple of weeks later. And this is him 10 years later when he brought his wife along with gallstones. Slightly unusual name, so I recognized him, and that's him 10 years later. It looks like there's a little recurrence at the top, but that's actually a Ziffy sternum sticking through, and he has no recurrence, and he still plays competitive squash. So it is an operation that seems to last. So I'd recommend to you, particularly as loss of domains increases, the peritoneal flap repair. It is our standard operation. We do this every time. If we don't need the hernial sacs, they get cut off at the end and binned, but they're always there in case you need it. Ram, thanks very much for the opportunity. An absolute pleasure to be involved. As others, be great to have you in Edinburgh. This is a hybrid meeting, so for those who can get to Edinburgh, you're very welcome to come, but it will be online as well. Thank you all for listening.
Wow.
That was great. Thank you, Andrew. So we've covered quite the variety of techniques so far. And for our final speaker, I'd like to introduce Miguel Angel Garcia Ureña, who from Madrid, Spain, who will be giving us the Madrid way. So excited to see what that is.
Thank you. Thank you so much, Ram and Jan, for giving me the opportunity to be here again. It was so nice to be here sharing with our experience with such a big stars of abdominal wall surgery. So let me share my screen, and I think now you can,
sí, perfecto.
You can see it. Okay, perfect. Okay. Okay, so this is our way to approach this loss of domain cases. These are my disclosures, of course, all of them related to messes in abdominal wall surgery. Dealing with these cases of loss of domain, the two main questions that we want to always to face with them are: if will I be able to close the abdominal wall, reducing the contents? And here we'll have three inner questions. What about the posterior layer? What about the abdominal wall reconstruction in linea alba, the anterior layer? And what about the skin problems? But not only my technique. What about the complication? What about abdominal anastomotic descents that we may have, making intestinal resections, respiratory insufficiency, abdominal compartment syndrome? That will be a specific talk about data. So probably one of the best thing has already been said during the day, is that optimization is one of the key things and is as important as the surgical technique. But I have to tell you that before going ahead, I think you have to talk with the patient and talk that probably you are not gonna be able to restore the abdominal wall like in the picture, or the case of the picture that you are watching now. You are not going to restore completely the function of the abdominal wall, but at least you may recover abdominal continence. But you have to talk about with him, but maybe it's better not to touch in very high risk patients and leave them alone, because probably there's no solution for them. So you have also to think about that. And please, during the technique, there are two added things to complex abdominal wall repair in loss of domain: is monitor your intra-abdominal pressure and monitor with the anesthesia or respiratory pressure. So that are important. Tips and tricks to make our posterior component separation. We also make this peritoneal flap, leaving half of the sac attached to the anterior layer and half of the sac attached to the posterior layer. And this is our usual way. In this very big case that we operated 8 years ago, there was no problem with the isolysis, but you can see here that we have a very good anterior flap of sac attached to the anterior layer. So to attach it to the anterior layer on one side, you have to make your posterior rectus sheath reduce the rib procedure. And then you can see that we have used here half of the sac attached to the posterior layer to completely perform our TAR. And now we are almost ready to place our mesh and trying to close this abdomen that, as you imagine, we couldn't completely close. The second thing is to perform a proper ribs retromuscular repair. And what's the Madrid TAR? The Madrid TAR is just to make the lateral posterior rectus sheath release very similar to Nowicki-Rosen technique, but when coming to the cranial aspect, we change the direction obliquely and we only detach the insertion of the trapezius abdominis muscle onto the posterior rectus sheath. And we really like to put a couple of stitches to the Cooper ligaments, because we cannot overextend the dissection in loss of domain cases in the inferior part of the abdomen. So this is the only place of fixation of our permanent synthetic mesh, and they are always there to help us with the repair. But we need to overextend also cranially. And we, as Nowicki has also advised, we follow the dome shape of the diaphragm, making this the dissection until we reach the central tendon. And here we are more than 12 to 15 centimeters beyond the xiphoid. No need to fixate. And laterally, we also like to go very, very extended to the posterior abdominal wall to reach the quadratus lumborum and psoas muscle. And I'm not happy until we reach the 12 rib and pass it over it. And cranially to the 5 and 6 intercostal spaces. And the fourth advice is I heard today about using 30 by 30 meshes, but probably we think this is not enough, and we like to use 50 by 50 PPO PVDF meshes with that should be straight enough, and we are placing it over a sheet of absorbable mesh that will reinforce our posterior abdominal wall layer, and will help us to extend laterally to these anatomical landmarks to perform a better Guyan reinforcement of the visceral shaft, as Punjani has already stated before. Yes, but the question is that following all these advices, adequate preoperative optimization, very good adhesiolysis, extensive dissection, very good TAR, I'm using beam meshes, but Dr. Garcia-Urena, I cannot close. Despite all of this, I cannot close. Why? Because sometimes simply the anterior layer, the anterior retussi lineal cannot be reconstructed like this with a recurrence after anterior component separation. And also in these cases with chronic infection of an inlay mesh, probably it's going to be impossible also to close the posterior layer. So we have to face these two problems. Unable to close the posterior layer, which are the solutions? Some of them has already been also remarked today. The use of absorbable mesh is always a very good tool in these loss of domain cases because you can breach your posterior layers with PIOA, Vicryl, or Phase mesh, as has been published. But sometimes we cannot even reintroduce that because it's a problem of volume. It's a problem that the volume outside, despite our Botox, despite our pneumoperitoneum, here you can see here that it was impossible to close the posterior layer. Well, so in this lady, we perform an omontectomy. Sometimes we have also performed a right extended hemicolectomy. I'm talking about only exceptional cases. And in this case, we finally could close the posterior layer. But when we try to perform the closure anterior, the anesthetist advised us that the peak respiratory pressure was so high, so we added an anterior component separation to the transverse abdominal release. And despite this, we breached the repair. The lady was discharged after 15 days and also added a paniclectomy. These are, of course, exceptional cases, but you have to need all this armamentarium to close your layer. As I told you, the posterior layer could be a problem, but when the anterior layer is a problem, we can, of course, breach the repair, and that could be like a stage procedure. Maybe we can result in a pseudo recurrence in the midline, maybe, but you have made some abdominal continence in the patient. But like this lady, with all the whole abdomen, it was a breach. The patient is fine after 6 years of the operation. And in some exceptional cases, Lopez Monclús will talk about this in the last talk of the day. That if I were you, I wouldn't miss it, about adding the posterior and anterior component separation technique. So also we have this also new tool in the armamentarium, Fascio10. We have started using this year, but I have to tell you, I don't have enough experience, but I can obtain 10 centimeters in my cases of approximation using these Fascio10s. So this would be my summary of in Madrid, in our Madrid team, how we deal with this patient, evaluate the risk, and talk about conservative management, preoperative optimization, with all has been said today, individualized technique on each patient, but we always try to make a step-up approach, preserve the sac and skin, ribs, Madrid TAR, and then we have been able to abdominal wall content introduce. We're really happy. But if we cannot reduce abdominal content, you need to monitor your abdominal pressure and respiratory pressures to see what is the best thing for this concrete patient you are dealing with. What can you do? You can make an external augmented resection. You can add an external only release to the TAR, and simply make a large breach or a stage repair. So monitor your intra-abdominal pressure, monitor your respiratory pressures to decide and individualize in each patient what could be the best thing to do. I don't have coffee for all loss of domain, but you need to have all these bullets in your gun trying to solve the problem to the patient. So it's not only a question of component separation, it's not only a question of optimization, it's a question of having a lot of things in your armamentarium trying to solve these very complex cases. And sometimes we have very good success, like this man with a very great loss of domain who was discharged 2 months after the operations. In this man, only at the 7th day. In this lady, lateral abdominal wall loss of domain completely reintroduced. But in some cases, like this man, this poor man that died of sepsis after anastomotic descent in a patient that despite the TAR, despite the bridge repair and a right extended colectomy, couldn't reduce, and probably the high intra-abdominal pressure produced the anastomotic descent and the patient died. So my message is, be aware, it's a difficult operation, only be performed by complex abdominal wall surgeons units. This is my conclusion: optimize, appropriate technique, monitor your pressures, right meshes, and only in exceptional cases, double component separation, visceral resection, or maybe better, a bridge repair. Thank you so much, and it has been a pleasure to be with you all, and I'm ready for your questions. And thanks for all to my masters who have taught me so much of abdominal wall surgery. Thank you.
Thank you so much, Miguel. And I'd like to thank all of the speakers during this session, and again to the organizing committee of the conference, and then to David, my co-chair. Unfortunately, for the sake of time, we aren't going to be able to answer questions. I know there are a number of questions that are coming up in the feed, but we may be able to organize a separate live Q&A in Facebook if interested. So again, thank you, and we'll move on to the next session.
Thanks, everyone.
Dave, please. Okay, thank you. Thank you, Ma'am Andrea, and thank you, Dr. Dave. Can we move on to the next session? Thank you, Dr. Raman and Ramesh, for giving me this opportunity. Good night.
Thank you, everyone, for this wonderful session. Without wasting any time, may I invite Shu Ming Ho of Australia, a great name in AWR from Australia, and my dear friend, Dr. Rahul Madar, a dear friend, a great human being, a great surgeon, to chair this session. Dr. Rahul Madar, please.
Hello, everyone. This is a great pleasure to be here with you all for this historical event, what we can say as a loss of domain, a global summit. Now here we are going to chair this session, and the speakers will be introduced by my co-chairperson. Thank you.
Yeah, thank you, Raul. Good evening, everyone in India, and very good morning now from Australia. We've well ticked over into Sunday morning. We've spoken about the pre-op and operative concerns, so perhaps it's now time to talk a little bit about ancillary concerns during an operation. And to kick it off, we've got Anthony Bonavia from Hershey. Who better to talk to us about pulmonary pressures than an anesthetist and also a critical care physician? So over to you, Anthony.
Good afternoon. My name's Anthony Bonavia, and I'm an anesthesiologist and an intensivist at Penn State Hershey Medical Center in Pennsylvania, and I'm going to talk to you in 10 minutes about pulmonary pressures. So respiratory failure is not an insignificant issue following abdominal wall surgery and affects up to 1 in 5 patients, which is much higher than patients undergoing non-cardiac surgery. And so in 10 minutes, I'm going to talk to you briefly about pulmonary physiology that is relevant for abdominal surgery, specifically the effects of anesthesia and the effects of surgery on pulmonary physiology. So any discussion about pulmonary physiology has to start with a description of transpulmonary pressure. And this is basically the difference between airway pressure and pleural pressure. And airway pressure is usually approximated by the plateau pressure in mechanically ventilated patients, whereas pleural pressure is approximated by the esophageal pressure. Now, lung compliance is intrinsically linked to transpulmonary pressure and is zone dependent on the lung. And in the diagram there, you can see the lung compliance curve, which relates volume to transpulmonary pressure. And the slope of the curve, which is the change in volume over the change in transpulmonary pressure, is termed the compliance. The compliance of the lung is usually highest at the FRC, or functional residual capacity, where the slope is highest, and that forms at approximately the midpoint of the graph. Chest wall compliance is additive, and the total compliance of the pulmonary system is the sum of the inverse of lung compliance and chest wall compliance. Now, terms that are usually used are dynamic and static compliance. Static compliance is what we traditionally understand by compliance, and it's the relationship between volume and pressure of the lungs when there's no air movement, whereas dynamic compliance refers to compliance of the lungs when there's airflow into or out of the lungs. When we talked about dynamic compliance, what we're really talking about is the relationship with peak inspiratory pressure, whereas static compliance is the relationship with plateau pressure. And the graph here shows a mechanically ventilated volume assisted breath. And you can see there's a difference between the peak inspiratory pressure and the plateau pressure. Now, what the peak inspiratory pressure tells you is the pressure needed to overcome both the airway resistance and to keep the lung distended, whereas the plateau pressure tells you the pressure that's needed just to keep the lung distended. And so the difference or delta refers to the airway resistance. Now, peak inspiratory and plateau pressures are most relevant when we're talking about volume breaths. In pressure modes of ventilation, the peak inspiratory pressure and the plateau pressure are approximately the same. Here we see two different volume breaths with two different issues. And on the top of the graph, you see that there's a resistance issue because there's a big difference between the peak inspiratory pressure and the plateau pressure. Whereas in the bottom, which is usually more relevant for abdominal surgery, you have a compliance issue since both the peak and the plateau pressure are elevated. And I'll come back to this graph a little later. Now, when we talk about determining respiratory parameters for anesthesia, we usually take into consideration, at least conceptually, this hysteresis curve. And hysteresis is the term that's used to refer to the differences in lung compliance between inflation and deflation of the lung. And as you can see, it's a sigmoidal curve with upper and lower inflection points. And it's important to at least understand upper and lower inflection points because it helps delineate respiratory parameters, even if theoretical. So above the upper inflection point, or UIP, we get concerned about over-distending the lung and causing barotrauma, whereas below the lower inflection point, we get concerned with what's called atelectotrauma, or trauma or inflammation caused by repeated opening and closing of the small airways. And so we overcome these problems by limiting our tidal volume to 6 to 8 mLs per kilo of ideal body weight to prevent barotrauma, and also using some degree of PEEP, which is above the lower inflection point, to prevent repeated collapse and opening of the smaller airways. The hysteresis curve, or the compliance curve, varies, and that's why it's important to know the baseline lung pathology of patient, because patients who have restrictive or obstructive lung disease have different compliance curves. So now I'm going to talk a little bit about the effect of anesthesia and surgery on pulmonary pressures. And the biggest effect of anesthesia on surgery is a drop in the functional residual capacity, which, as we mentioned, is the point of the greatest lung compliance. And the reason for this is manifold, but basically involves loss of muscle tone. Together with the loss of FRC, come a decrease in airway compliance and increase in airway resistance, especially of the lower airways. So much so that atelectasis develops and can affect up to 20% of the lung volume with induction of anesthesia alone, even prior to beginning the surgery. And this series of CAT scans illustrates that and shows that atelectasis correlates with shunt fraction and hypoxemia. At the very top, we have the CAT scan of an awake, healthy patient, and you see that there's no significant atelectasis. In the middle panel B, we see that there's some developing atelectasis, and this is the CAT scan of an anesthetized patient in which 0 PEEP is being used. And C shows the same lung after institution of 10 centimeters of water of PEEP and some recruitment maneuvers, and you see that the ventilation to perfusion matching improves, and the CT evidence of atelectasis disappears almost completely. There's other factors that contribute to atelectasis, including patient's BMI and fractional inspired oxygen with a higher oxygen percentage contributing to atelectasis via absorption atelectasis. And so some of the maneuvers that we use both to decrease intraoperative hypoxemia and to minimize postoperative respiratory failure is to ensure that we have an analgesic plan that minimizes postoperative splinting by using PEEP. And I try to use a PEEP of at least 8 to 10 intraoperatively, since it's been repeatedly demonstrated to re-expand atelectasis, even though atelectasis rapidly reemerges after discontinuation of PEEP, meaning at extubation, which is why it's very important to pursue postoperative aggressive respiratory therapy, mobilize the patient, and minimize the use of abdominal binder if at all possible. If the patient's still intubated and you have severe issues with atelectasis, you can deliver what's called a sigh breath using airway pressures 30 to 40 centimeters of water. It's also very important, as I mentioned, to minimize the fraction of inspired oxygen during anesthetic induction intraoperatively and postoperatively, and to minimize paralysis wherever that's possible. Now, what happens with abdominal closure and pulmonary function? So abdominal closure is usually associated with an increase in intra-abdominal volumes and concern for abdominal hypertension due to increased intra-abdominal pressures. Besides causing a loss in lung volumes, it also decreases chest wall compliance. And as we mentioned, chest wall compliance is additive. It increases peak and plateau airway pressures, as we already mentioned and will mention in a couple of slides. And this is manifest clinically by hypoxemia, hypercarbia, increased intrathoracic pressures, which cause increased pulmonary vascular resistance, which is especially dangerous in patients who have pulmonary arterial hypertension. If severe, you can also sometimes see elevated hemidiaphragms in chest X-ray. So this anecdotal evidence has been shown by a few studies over the past 10 to 20 years. This is a study from 2010 showing that after component separation, we don't really have much change in the diaphragmatic position, but we do have a significant increase in abdominal volume. And hernia volume in univariate and multivariate logistic regression, and this study from 2017 caused an increase in the odds ratio of pulmonary complications following hernia repair of approximately 1.5. Similarly, both lung and chest wall compliance severely are decreased with peritoneal closure. And we have significant increases in and progressive increases in peak and plateau airway pressures. And this study from 2012 shows pretty dramatic increase in the odds ratio of severe post-op respiratory complications following abdominal wall reconstruction, with an odds ratio of 5 with just changes, increase in plateau pressure of 3 and increasing to an odds ratio of 11.5 with change in plateau pressure of greater or equal to 9. So much so that this author mentioned that in his institution, the patients with a plateau pressure of greater or equal to 6 following abdominal wall reconstruction are kept intubated for 24 hours postoperatively, and an increase in plateau pressure by more than 9 caused them to be intubated and paralyzed for 1 to 2 days postoperatively. Now, it's important to bear in mind that this postoperative intubation is not without its cost, as prolonged postoperative intubation itself is associated with an increase in odds ratio of postoperative pulmonary complications. Again, just to emphasize, you're only going to see these changes with peak and plateau pressures in patients who are on volume cycled mechanical ventilation. And this is the graph that I showed earlier. In the red box on the bottom left is what you'll see usually following abdominal closure, which is increase in both the peak and the plateau pressures. If someone's on pressure cycled mechanical ventilation, as mentioned, the peak and plateau pressures are approximately the same, since the ventilator alters volume based on the pressures that you choose. And so decrease rather in lung compliance is not going to cause a pressure alarm. It's just going to say that the tidal volume has not been achieved. Thank you for your attention. This is my reference, and please feel free to contact me on the email below if you have any further questions about anything I've said. Thank you.
Thank you, Anthony, for your great illustration about this topic. Now we'll move on to the next lecture. Next person, the speaker is Dr. Jignesh Gandhi. He is a professor and unit in charge in a KEM Hospital, Mumbai, India. He's a great speaker and a great mentor for AWR cases and fantastic surgeon. And he is going to talk about ICG in AWR, the new black. Over to Jignesh Gandhi.
Thank you, Dr. Su and Dr. Rahul for the kind introduction. And good evening to all my colleagues for watching us live from India. So I'm going to talk about ICG in AWR, is it the new black? I have no disclosures for my talk today. So when we see a patient like this who has significant amount of flap necrosis, and then on, one after one, you have all the complications happening, you wonder whether you can prevent this in the first place. So when I started diving deeper into understanding of the ICG, the first thing came to my mind is that I need to have a green view and green perception about tissues, because that's how you're going to interpret what you're going to see during the surgery. So indocyanine green, as you know, is been used successfully in the colorectal surgeries. It's also been used for lymphatic mapping, and hepatobiliary system becomes the prime where you're going to use ICG, and it's also used to localize lesions in many cases. So the principle of ICG or indocyanine green is that once you have injected it, it binds to the plasma proteins, and then subsequently, whenever it is exposed to the near infrared, it'll have a fluorescence which will be picked up on a particular wavelength, and that's what you can see on the bottom, that you can see the picture where you can see picked up in the gallbladder and the biliary system. So ICG is available worldwide. It is contraindicated if one has got an allergy to it. The half-life in the blood is about 4 minutes, and this is where it makes it more powerful in terms of a repeated usage without causing any toxicity. It is excreted in the liver and biliary system. That's where it forms a main attention. And the upper dose is about 2 milligram per kilogram body weight. So we advocated this use and of this technique of open ICG, and we have this device which is a real-time high-definition device which has got a twin illumination part, and this is scores better than using a laparoscopic ICG, specifically when we are doing abdominal wall reconstruction cases. So in the interpretation, you have the three modalities. It is very important to interpret that. You have the SPY contrast mode, which gives you the black and white image, which tells you about the volume of perfusion into the tissues. Then you have the SPY overlay mode, where you have a transition point, so specifically when you're doing an anastomosis. And the third is the CSF, or the color segmented fluorescence, which tells you about the depth of perfusion. So whenever you're using ICG, remember that there are these different modes, and when you're going to adapt it to the hernia surgery, you're going to use this in different clinical scenarios, as I will show you. So we adapted the concept for the hernia, specifically for open surgeries, because the skin flaps was our major problem, and we divided the revision, the skin flap edges, after we could find that there was no vascularity based on the open ICG system. In laparoscopic in-cell hernias, we have identified landmarks, especially when you're doing difficult dissections. You've got dense adhesions all around, and you want to identify a loop of the bowel snaking in below the omentum. ICG becomes very useful. Also in identifying the infraepigastric vessels while doing an IPOM, because you don't want to have a tacker which will be going through that particular area and causing bleeding. And also I can tell you that in redo cases, especially the groin hernias, if you're going to use an ICG, it becomes very important because it identifies. Only thing is that one has to be very quick, and you have to see it within the first 1 minute of giving ICG. But as I told you, since the half-life is shorter, you can give more doses if required. And finally, we have adapted this also for identifying the neurovascular bundles in an ETEP or open reef tropas, purely as a teaching tool for our residents and even our fellows, so that they can understand how they look like. So it's available as Orogreen in our country, and we use in the dilution doses of 1 cc up to 5 cc or even 10 cc in a diluted doses of 0.1 to 0.5 milligram per kilogram body weight. So this was an article initially published by Dr. Igor, where they talked about ICG to predict wound complications. And recently we published our article in the World Journal of Surgery, which was published this year. And we specifically used it for cases of anterior component separation technique, because that is where we are always worried about skin flap and necrosis. And we found very good results. Our results are given in this particular paper in the depth, and it was also well tweeted on the European Hernia Society, and it was received well by authors across. And there were multiple papers also happening in the last about couple of years. So the technology is moving forwards to help us identifying those kind of patients where the problems can be avoided. So if you have a case like this, where you are worried about an elderly patient with an incarcerated hernia, this is how it looks like on the black and white mode, and then you can put it onto the ICG green mode, which we are used to it. So each one has got a different interpretation. And then finally, we talk about the depth of perfusion. So if it is absolutely gray, that means the blood transfusion is not good. But if you have red streaks like this, that means it is very, very good perfusion, which is happening in that area. So you keep on changing the mode as you go through to interpret what is happening. And then this is in the field. So it is the base of that area after you have closed the defect and you have found and you're going to implant your mesh. And this is again before the closure of the skin, that you keep on watching what is happening in the skin flaps. And finally, you can see the result, that it gives you a perfect skin area without causing any problems. And this is how you mitigate the complications in patients like this, or a lady like this, where I have this large hernia to be repaired. And I'm also going to deal along with that an abdominoplasty. And this is where I'm worried about with obesity, whether I'm going to have a subsequent skin necrosis. So in cases like this, you can see that how we use, again, the black and white mode there. We use the ICG green mode. And during that period, we can continuously spray around and we can see the flap, that how the perfusion of the ICG occurs well into this particular flaps as we go along. And then this is again the vision of the flap and understanding the depth of the perfusion. And we excise if needed. You can see the flaps there. There are a few small flaps which we have excised here because we were not very happy and we had to revise it after giving the ICG. And once you do that, finally, you look at the skin. So this is how it is just before the skin implantation. You have put in the mesh there and you move around. And again, you can see in the black and white mode. So these are all the measures utilized to mitigate any kind of complications. You can change the mode real time and you can keep on deciding what is the right way in the way you're going to close your skin flaps. And finally, it shows up very well even in the skin. You can see here, this is at the time of application of the staplers. Again, I use the ICG mode and you can see that the skin flaps also show up very well and can tell you whether you need to revise any flap of the skin, because underneath that is your mesh, which you're worried about. So this is how finally you get the result after all your revisions of using in the ICG. And this is the patient a couple of months down the line. You can see that she's had absolutely no problem. The skin flaps have healed well. The umbilicus has healed very well. And these kind of information is very, very useful for the surgeons today. And finally, as I told you, we have adapted this also for shortening the learning curve for our fellows and residents. We know that for an expert surgeon, identification of neurovascular bundles is very easy, but when you're training people by giving an ICG, it makes life so easy for them to show exactly how they look like, and you shorten the learning curve of Reeve, Topaz, and TAR surgery. So with this, I think the future is going to be go green, and ICG probably will not spare any part of the body. We're going to probably have ICG utilized for every particular thing. And ICG, I think, is the new black and green, and that's going to be the future. So I thank Dr. Ramanna to include me in this galaxy of international stars for this historic summit on the loss of domain. Thank you, chairpersons, for your kind attention. Stay safe, all of you, and I'll be happy to answer any questions. Thank you.
Thank you, Jignesh. That was an excellent talk on ICG. It's very exciting to see the applications now in hernia. With time, let's move on to the final talk in this session. And this is coming from Dr. Kelly Slater, based in Brisbane. Kelly is a general surgeon at the Princess Alexandra Hospital in Brisbane. part of the liver transplant team, but her specific interest is with regards to abdominal wall reconstruction and hernia surgery. So Kelly today will be talking to us about soft tissue considerations when operating on hernias and loss of domain cases.
We're not getting audio.
These are my disclosures. My other disclosure is that I am not a plastic surgeon. I'm a general surgeon who has a very large, complex abdominal wall practice. And as far as I'm concerned, in addition to incisional hernias, managing these patients' skin is a vital part of what we all need to be doing. This is not the typical patient that I see, by far and away. These are the sort of patients that walk through my door on a daily basis. They are overweight, they've had multiple surgeries with many different types of incisions, but all of them have excess skin that will be present even when you return the viscera to the abdomen. And I've developed some techniques to address this skin at the same time as I repair their incisional hernia. Excess skin is a huge problem in loss of domain hernias, with the sac acting like a tissue expander. And at the end of the operation, you're going to need to do something to address this skin so it doesn't fill up with seroma that has a potential to get infected and cause significant morbidity and cosmetic problems for this patient. This is also the other subset of patients that we are seeing very frequently, is patients who are post-bariatric surgery, and along with excess weight loss comes redundant skin, and the patients want this addressed. And this is the final group of patients that I look after, those people with morbid aprons. These are people who are excessively overweight, and for some reason, a lot of it will collect in their pannus. This patient on the left came to see me at 300 kilos, and you can see they were wheelchair bound and had a terrible quality of life in their 40s. And losing a significant amount of weight will improve their risk overall. However, their aprons won't disappear, and you need to do something about it for these poor patients to have a quality of life. So you can see here what a difference 100 kilograms of weight loss will make, and I successfully removed this lady's 30 kilo apron, and this enabled her to get out of her wheelchair and get back to looking after her small children. I'm sure I don't need to convince hernia surgeons that these patients are an eclectic and diverse group that need a range of techniques to fix their abdominal walls. It's really important that you think about the skin. General surgeons have to know about abdominoplasty, because after the operation, the patients don't want to look like this. They want to look like this and go back to having a great quality of life. There are lots of reasons to consider doing an apronectomy at the same time as you fix an incisional hernia. You will improve these patients' function out of sight. It can be really life-changing and is probably the most satisfying operation I do. It improves patients' hygiene, decreases their risk of fungal infections under the flaps. Their self-esteem will improve out of sight. Some of these patients have not left the house for many years, and it makes it really easy to do big repairs. There are possible disadvantages, and I have come in for some criticism about doing such large skin removals at the time of the operation. However, when you think about it, all of these complications can happen through just a midline incisional hernia repair. They're probably slightly higher because these are bigger wounds. However, I would suggest to you that the complications are usually relatively minor. They involve dressings at home, and the patients will trade them off every day of the week if you can transform someone from looking like this to this. There's lots of evidence in the plastic surgical literature that a pediculectomy can be done quite safely during a hernia repair. The other advantages are excellent access to the entire abdominal wall. Because you're removing all the skin inferior to the umbilicus, you can appreciate any occult defects, and it also facilitates the external oblique release without compromising the skin flaps from lateral undermining. This is illustrated really nicely in this video. I've been doing a traditional abdominoplasty here where I've lifted the skin up towards the head, preserving the vascularity on the intercostal vessels. The external oblique is fully on view, and I'm able to release it in literally a matter of minutes and get a very wide external oblique release to facilitate bringing the rectus muscles to the midline. This is illustrated really nicely in this video. I've been doing a traditional abdominoplasty here where I've lifted the skin up towards the head, preserving the vascularity on the intercostal vessels. The external oblique is fully on view, and I'm able to release it in literally a matter of minutes and get a very wide external oblique release to facilitate bringing the rectus muscles to the midline. Before you do these types of operations, it's really important that you understand the blood supply of the abdominal wall. The tissue inferior to the umbilicus, marked here by the red ellipse, is completely excised. Superior to the umbilicus, however, the undermining will stop about 2 centimetres superior to the umbilicus. It's important to preserve the periumbilical perforators to give the superior flaps an excellent blood supply. To facilitate the hernia repair, you're able to undermine completely to the xiphoid in the midline, as this plane is relatively free of blood vessels. At the end of the operation, the patient is put in a beach chair position to bring the superior skin towards the pubis. This is the operation that in the beginning of my practice I used probably most frequently, which is a simple amputation of an apron using a Patangi technique. This is where there's no midline incision and it gives a very acceptable cosmetic and functional result. The fleur-de-lis incision, however, has become the workhorse of my practice, especially for patients with redundant skin superior to their umbilicus. It gives amazing access to the abdominal wall for incisional hernia repair and will give a large anchor-shaped incision, such as the one you see on the right. It will also give you an amazing cosmetic and functional result. The fleur-de-lis is also very useful to deal with a previous cocker incision. The concern with the cocker incision is that the skin inferior to the old incision is at risk of ischemia, especially if it's previously been undermined and the perforators are compromised. To deal with this, you turn the cocker incision into a midline using a fleur-de-lis technique. And you can see here on the right-hand side, this has been done, and then our previous transverse infracostal incision is now in the midline. This is the second technique I use to deal with cocker incision, and I excise all the skin inferior to the cocker incision using a fleur-de-lis technique. However, I'll use a flap from the left-hand side on a perforated pedicle and use it to bridge the defect that the cochlear incision has left. This will also work very well. The third strategy for dealing with a cochlear incision is a reverse pediculectomy, where the skin of the upper abdomen is excised and the apron is brought superiorly towards the ribs. This patient had a midline umbilical hernia, a hernia through the cochlear incision, and also a hernia through the phalansteal incision. And this upper abdominal incision was an excellent approach to reach all three hernias. Don't forget, you can just come straight across the mid-abdomen and excise the redundant skin, and this is what we did with this patient who had a very large umbilical hernia with loss of domain. The markup is really important. You stand the patient up and you sit down right in front of them. You'll mark the midline. The first incision will be done across the suprapubic line. So you'll ask the patient to lift the apron up towards their head and make this mark. The lateral extent of your incision will depend on the skin folds. It's very important to not go too posterior, and at the end of the operation you can take into account the dog ears and make sure they're nice and smooth. Mark the midline both superiorly and inferiorly down into the mons pubis, so you can bring these two areas together at the end of the operation. Because I have a high volume practice performing 3 to 4 of these operations a week, I find it very impractical to coordinate the hernia repair with the plastic surgical team. So this is why I've adopted this technique. To improve my efficiency, I'll have myself and my resident working on the skin at the same time. We'll use 2 cautery pencils and a ligashore for the perforators. That could be considerable in these patients who've formerly been very large. It's also important to put them on the break in the table, so at the end of the operation they can be bent in the middle slightly to facilitate approximation of the skin flaps without tension. So this is how we'll shape the flaps at the end of the operation. The patient has been undermined to the umbilicus with a small midline extension. I will approximate the skin using sharp towel clips, and allowing for a tension-free closure, I'll amputate it, and my lines of preoperative marking are usually correct. You get a feel for this as time goes on, and you can usually judge pretty well where the amputation will be. Somewhat controversially, I'll use SteriTalc. I believe it makes a huge difference in seroma rates, and I would find it pretty difficult to work without it. I'll put 2 10 French drains in the subcutaneous space and relatively simple closure of 2 ovicral to the Scarpa's fascia, approximately every 2 to 3 centimetres. This is the workhorse of the closure, and then the skin is closed using a Stratafix continuous subcuticular suture. We work on the dog ears when we get out to the lateral extent of the wound, because this is what the patients will complain about, and I'll talk about that in a moment. I'll then use a Prevena dressing, which has a little bit of silver impregnated in it. This will stay on for 5 days, and we'll use this as a quasi corset. In Australia, it's very hot and the patients are very oddly shaped, so I find binders or corsets do not work very well at all, and after 5 days I'll take this dressing off and we'll leave the patients to wear their normal underwear and leave the wounds open. So this is how we'll shape the flaps at the end of the operation. The patient has been undermined to the umbilicus with a small midline extension. I will approximate the skin using sharp towel clips, and allowing for a tension-free closure, I'll amputate it, and my lines of preoperative marking are usually correct. You get a feel for this as time goes on, and you can usually judge pretty well where the amputation will be. Somewhat controversially, I'll use SteriTalc. I believe it makes a huge difference in seroma rates, and I would find it pretty difficult to work without it. I'll put 2 10 French drains in the subcutaneous space and relatively simple closure of 2 ovicral to the Scarpa's fascia, approximately every 2 to 3 centimetres. This is the workhorse of the closure, and then the skin is closed using a Stratafix continuous subcuticular suture. We work on the dog ears when we get out to the lateral extent of the wound, because this is what the patients will complain about, and I'll talk about that in a moment. I'll then use a Prevena dressing, which has a little bit of silver impregnated in it. This will stay on for 5 days, and we'll use this. There's often a lot of talk to these patients about their umbilicus. Many of them already have them missing, and I am very happy if the patients want it removed altogether, and I'd say 90% of my patients will go for that option. You can reimplant the natural umbilicus, however, I don't like the way it looks, and I often discourage patients from doing that. And it also can increase the risk, if you're using synthetic mesh, of having a potentially ischemic area and contaminated deep umbilicus. The patients who wish to have an umbilicus, I much prefer the technique of neo-umbilical reconstruction, and I'll show you how I do that in a moment. So this is the typical appearance if you get rid of the umbilicus, and I think it looks great. I really don't like the telltale oval appearance of a reimplanted umbilicus, so not many of my patients will go for that option. I love this pumpkin tooth technique, where you will create a new umbilicus for the patient using little skin tabs that you secure to the anterior abdominal wall to create a divot. And I think this makes a really natural looking umbilicus in the middle of a scar, and it can be done at the time of the operation, or it can be performed at any time in the post-operative period. However, I rarely find patients miss their umbilicus, and but it's an important discussion point prior to the operation. Not many of my patients will go for that option. I love this pumpkin tooth technique, where you will create a new umbilicus for the patient using little skin tabs that you secure to the anterior abdominal wall to create a divot. And I think this makes a really natural looking umbilicus in the middle of a scar, and it can be done at the time of the operation, or it can be performed at any time in the post-operative period. However, I rarely find patients miss their umbilicus, and but it's an important discussion point prior to the operation. So this is what a pumpkin tooth umbilicus will look like in the post-operative period. The dog ears and the mons pubis are really important to address at the time of the operation. You can do a 3-hour complicated incisional hernia repair, but all the patient will care about is what their dog ears look like and what their pubic area looks like after the operation. So it's important to take a few minutes to get this right at the end of the operation. And I'll explain to all the patients that at 6 months post-operatively, if there's any issues, we will do small revisions to improve the cosmetic appearance. I have strategies to hold these aprons up. Even small aprons are quite hard work, and if you're about to do incisional hernia repair, you need to look after yourself. I'll set them up with a simple square drape, and I'll tape down the sides of the drapes, as they tend to be very low and they will gape with the fluid running down if you don't secure them. I'll also use fluid pouches, because these operations will get very messy and fluid continuously runs down the side of the table off these big incisions, and you can get yourself in quite a mess. We wear Wellington boots and aprons, and this keeps us clean and dry during the operation. It's important to warm these patients, and but with inferior and superior bear huggers, I use a Graze retractor that I borrowed from my liver transplant work, and I'll use the fixed bar to retract the apron upwards. I'll perforate the skin with drains and I'll secure it to the fixed retractor superiorly, so I'm retracting the flaps up towards the head. This takes a lot of pressure off your arms and stops the need to have poor residents pulling flaps up for long operations. And finally, I'd just like to discuss my results. So I've done 146 of these cases with simultaneous ventral hernia repair and pediculectomy. Patients are in their late 50s and there is a propensity to a female group. And that makes sense because women tend to carry their weight in their aprons. Their mean BMI is 35 and I've become much stricter about weight loss prior to surgery. So 59% of my patients will have lost some weight prior to the operation. You can see the group that have done it through diet and lifestyle changes lose an average of 21 kilos, and about 44% of my patients have had bariatric surgery prior to their operation and they have lost up to 50 kilos. My practice now is largely using bioabsorbable mesh with excellent results, and in the early part of the series I was using retrorectus polyester mesh and a small numbers of intra-abdominal mesh. I will use a retrorectus approach in the vast majority of patients, and my mean hernia defect is 106 square centimetres. I'm doing component separation in almost 30% of patients, and more I'm using preoperative Botox to facilitate getting the rectus muscles to the midline. The vast majority of the wounds are clean. However, I will do paniculectomy in dirty wounds, especially if the apron is contaminated, and I think it's a much better approach to remove all redundant skin to improve the risk of post-operative wound infection. Median weight of my aprons is 3.2 kilos and my operative time is just under 3 hours. The median length of stay is 6 days, which is pretty reasonable considering where my patients come from is a state larger than Texas, and I keep them in a little bit longer because they have vast distances to travel post-operatively. My total number of wound events is 34%. The risk of cellulitis is very low. I look after these patients intensively post-operatively and they'll see me in the first week, and I'm very vigilant about recording their wound-related issues. I try to not have them go to their GPs because invariably they are started on antibiotics no matter what is wrong with them. So I'm fairly vigilant with looking after them. The surgical site occurrences requiring procedural intervention are in the order of 15%. Again, I have a very aggressive policy about draining retrorectus seromas, and I'll do a CT scan at 6 weeks post-operatively for all of these patients. If the seroma is there, I'll aspirate it because I think the bioabsorbable mesh requires apposition of tissue on both sides for good incorporation. My recurrent hernia rate is 9 patients out of 146, making it approximately 6%, and my median follow-up is 632 days, and I will see these patients once a year with a CT scan to record their outcomes. I've had 2 deaths in my series. This is very early in my experience when I was not paying the required amount of attention to preoperative workup. These patients were too obese and passed away with conditions related to compartment syndrome in very complicated hernias. So thank you for your attention. It's my belief that abdominoplasty needs to be part of the armamentarium when repairing hernias. It can be performed very safely with low complication rates, and it really will improve your quality of life, access to your abdominal wall, and your cosmetic outcome. Thank you for your attention.
Thank you very much for that, Kelly. That was an excellent talk. Always good to remember what to do with that excess soft tissue that we have left after a giant hernia repair. We are running very short on time. We're about 45 minutes over time now. So I think we're going to skip the questions again, and we're going to skip right on to the next session. So again, thank you very much to all the speakers in the session. Moving on.
Thank you very much.
Thank you. Thank you very much.
Thank you
very much. Thank you.
This has been a wonderful session, and we have 7,000 people online and counting. So it's very heartening to see such a response. Moving on quickly to the session after the surgery. I would like to invite my chair people, Dr. Pramod Shinde from Maharashtra and Dr. Vivek Bindal from Delhi. Both of them have done phenomenal work in AWR. It's a pleasure to have you here, sir. Let's start, please.
Thank you, Dr. Soumya. It's indeed an honor and pleasure to be here to chair this session along with my co-chair, Dr. Vivek. This historic event arranged by Abdominal Wall Reconstruction Surgery and all our friends and associations across the world. It's an even greater pleasure to invite and introduce my friend, Dr. B. Ramana, who's the founder president of AWRSC and to whom this part of the world owes the beginning and the progress of abdominal wall reconstruction surgery. He's a leader, an influencer, a teacher, and a mentor to many. And he'll be talking to us on abdominal compartment syndrome, diagnosis and management. Over to Dr. Ramana.
Thank you, Pramod. I'd like to share my screen now, and I hope you can see my slides moving.
We can see the slides.
Make them moving.
They're not moving at the moment.
No, that's because, yeah, I got it.
Yeah,
the play button was hidden by the Zoom button.
Yeah.
Anyway, so today I talk about abdominal compartment syndrome, a condition which was reducing in incidence because we were getting to know how to manage trauma and fluid resuscitation better. But with the advent of newer abdominal reconstruction procedures, wall reconstruction procedures, we may be seeing a surge of abdominal compartment syndrome, henceforth titled as ACS. So ACS is defined as sustained intra-abdominal hypertension with organ system damage. Now, every one of these words is important, and because it is important, I'm going to modify this definition slightly and say that ACS is sustained intra-abdominal hypertension with new organ system dysfunction. So there is a change, and that change is intentional, because when you say it's new organ system dysfunction, it means that the patient may have had pre-existing organ dysfunction. And for example, if the patient had a creatinine of 1.8, 0.3 milligrams per DL increase in creatinine would be a significant change. And dysfunction is what you want to diagnose before organ failure. So you don't want to treat and diagnose end-stage ACS. You want to detect it while it's still happening or beginning to happen. So intra-abdominal hypertension is when the intra-abdominal pressure, which is normally around 5 millimeters of mercury, is exceeding 12 millimeters of mercury. And ACS is when the IAP is more than 20 with organ dysfunction. So these two basic things have to be very clear. Intra-abdominal hypertension, when it goes beyond 20, is ACS. Now, the grades of intra-abdominal hypertension are 4, 12 to 15, 16 to 20, 21 to 25, and more than 25. And these are defined by the World Society. So we just have to quickly move on through this because there are far more important things. For example, ACS affects mainly the heart, lungs and kidney, but also affects the bowel and the brain. In what situations do we see abdominal compartment syndrome after AWR? This is what is now known as the quaternary abdominal compartment syndrome. The primary, secondary, and tertiary are different clinical situations. We are not going into that because of lack of time. Quaternary essentially means post-AWR abdominal compartment syndrome. Now, in which situations would you expect it? One, the obese. Normally, the intra-abdominal pressure in the obese may be as high as 14. And so in AWR patients in the obese, there's a higher chance of ACS. Loss of domain, of course, we know it. When the abdominal wall is extremely stiff and refuses to stretch, and when you have pre-existing organ damage, the chance of organ failure happening is much higher for a given rise in intra-abdominal pressure. And when your closure is tight, you would typically know it if you have experience, and that would be the setting for ACS. Now, in addition, if there is a retromuscular bleed in a given patient, it might increase your chances of ACS. This is typically, excessive fluid loading is typically an important cause of ACS in patients of trauma or burns, but not so much in AWR. I will discuss this point in a bit. And significant ileus may cause rise in intra-abdominal tension. Now, this is a CT of a retromuscular bleed, and you can see this is pretty significant and may account for ACS. Now, the classic clinical picture is post-AWR. The patient has a cylindrical belly, low urine output, hypotension, and the airway pressures are high. But remember one thing, don't read too much into this cylindrical belly thing, because the clinical features of an ACS may not be that accurate. So this is an important consideration. So we need more to diagnose ACS. One of the additional features of ACS is when you do a blood gas, you find metabolic acidosis. The lactates may be going up, and that would be an important thing. So how do we diagnose this? Let's look at what pressures we could check. The intravesical pressure is a pretty standard way of measuring intra-abdominal pressure. So you put in a three-way Foley. The patient has to be supine. The head end has to be at the level of the heart. So no head up, because that would raise the intra-abdominal pressure. The patient's pressure is measured at the end of expiration, and not more than 25 ml of sterile water is pushed inside the bladder to measure the pressure. So how you measure the pressure is important if you want an accurate reading. And mind you, this is not done one time, but repeated periodically. So every time has to be done properly. Now, this is getting far more traction because the abdominal perfusion pressure is truly a functional parameter. Now, how is this a functional parameter? Now, this is not jargon, but this is something which can be easily understood even if you're not familiar with it. So abdominal perfusion pressure is mean arterial pressure minus the intra-abdominal pressure. Now, what does each of these mean? Now, the abdominal perfusion pressure is basically the pressure of the blood which supplies the viscera inside the belly cavity. And the mean arterial pressure, for those of you who have forgotten what it is the systolic pressure plus twice the diastolic pressure divided by 3. So you may have a machine which tells you what the MAP is, or you could just manually calculate it this way. Now, abdominal perfusion pressure, therefore, is the pressure of blood supplying the viscera. And if this pressure is more than 60, it is possible to survive ACS. Now, if you look at this image, it shows you the 3 different pressures, and it'll make it more apparent. The mean arterial pressure is what is pushing against the walls of the vessels and pushing the blood towards the viscera, whereas the IAP is trying to compress it And so the abdominal perfusion pressure is basically the difference between these two pressures. So if you push in more fluids, your mean arterial pressure is going to increase. So it's like you push in more fluids, your blood pressure increases. So therefore, if you want to increase the mean arterial pressure in a way of fighting ACS, you have to push in more fluids. If you want to reduce the intra-abdominal pressure, you have to paralyze the patient, because if the abdominal muscles contract and the patient is conscious and aware, the pressures are going to rise and they're going to compress on the vessels. If you open up the cylinder, which is under tension, the intra-abdominal pressure is going to reduce. So these are simple ways in which we can figure out what's going to work in which part of this equation. Vasopressors can increase the perfusion pressure, but at the cost of vasoconstriction to the splanchnic vessels, and it might be a double-edged sword. Now, intra-abdominal pressures are often considered to be secondary to the airway plateau pressures. So we nowadays tend to measure the airway plateau pressures and use that as a surrogate for intra-abdominal pressure. Now, once you diagnose ACS or raised intra-abdominal pressure, what are the things you can do as part of non-surgical management? This is pretty much standard for all ACS causes. So you manage shock. So you manage shock by pushing in colloids or hypertonic saline. You monitor the intra-abdominal pressures, and generally things like putting in a CVP line or checking for the IVC diameter on ultrasound or a pulmonary capillary wedge pressure, these things are not that important. What is more important is monitoring and pushing in fluids. That's as far as the management of the shock is concerned, and pressors are necessary for some time, but try not to go too high because that becomes dangerous. Now, how do you improve the abdominal wall compliance? You have to paralyze the patient, sedate the patient, give analgesia, and keep the head end flat. So these are fundamental things which you do. And the volume inside the abdominal cavity, inside the stomach, colon, small bowel, these are reduced. So flatus tubes, enemas, neostigmines can reduce the colonic volume, and NG tubes can decompress the stomach and duodenum. If there are collections inside the peritoneal cavity, you can reduce them by putting in drains. But what is an important component of treatment now is ventilatory support. And obviously, I'm not an anesthesiologist or a critical care expert. So I'll just say that these patients have to be paralyzed, and it's important to share this information because this is post-AWR, quaternary abdominal compartment syndrome. The patient needs to be paralyzed, cannot be awake and breathing with a little support. That doesn't work. Now, what about the surgical management? You open up the patient's wound and see, is it stained with bile or succus or any other sinister content, blood? So you open up and see what's going on. One of the most important things to do is to check for bowel injuries. So this is a case where the bowel was extensively adherent and is just looking a little jaded, but that's normal. It's not really anything significant, but we're just checking for bowel injury. But sometimes, or rarely, you might find an enterotomy which was missed, and which is actually the cause of the patient's downward spiral. And this needs to be addressed immediately. So the mesh is explanted in that setting. And then you don't close the abdomen, but you put in a vac and come out. So this is just one of the ways of managing this. Now, the end stage ACS is where you actually find severe organ damage. Splanchnic vasoconstriction, small bowel is gangrenous. You can find that parts of the colon are gangrenous. And you can see this is patchy, but across all the territories, celiac, supramesenteric, inframesenteric. This is end stage and fatal. Once you complete your procedure, you should have a closure plan for the patient. So this is one of the patients who survived and many complications after an AWR, and then subsequently she's alive, though half her abdominal wall is gone. Now, let's come to real life situation where you've done AWR and the patient is showing signs of ACS. So what would you do? So here is a practical guideline for those of you who may not be familiar with it. So classically, the first thing I do is talk to my anesthesiologist and find out how much of fluids they have pushed in. And many experienced surgeons surreptitiously, after the case is done in the recovery, they push in 1 liter of extra fluid, because typically the fluid that surgeons want in AWR cases is more than what the anesthesiologists tend to give. So check the fluid intake and see whether the patient might need more fluids, because the abdominal cavity, when it's open for 6 hours or so, there's a lot of evaporation and the fluid requirement is underestimated. So get more help. So obviously you can't handle this situation alone. A multidisciplinary team is called for. And this is not something which you should handle by phone. This needs you to be on site, hands-on with the management of the patient. Now, arrange for re-exploration as soon as possible and ensure that everything else is there, ventilator, dialysis if required, etc. Keep the patient warm and arrange for wound wax, biologics, meshes, whatever is necessary, right? Now, do we really need re-exploration? This question is very important. One of the reasons why this question has come up is because studies have shown that significant intra-abdominal hypertension occurs transiently after AWR. And because these patients are not victims of burns or trauma, they have a better tolerance for raised intra-abdominal pressure. So the question comes, why not conserve these patients? Why should we re-explore with all the attendant downsides of re-exploration? Now, the problem is that we do not know the answer. If you try to conserve a patient, the patient has a risk of dying. And we do not yet have an algorithm of which patients can survive and which patients will deteriorate with conservative treatment. So I personally do not know an answer to this. And my understanding is nobody really knows, but might have a working idea. So chance of the patient dying with conservative treatment is significant. So what we could do is, first of all, if you're the surgeon, how did your procedure go? If your procedure went well, I think, and you have experience, you could be confident and say, okay, I'm going to watch this patient and see whether the pressure improves, the parameters improve. And if the pressure goes higher or the ABG shows that there is increasing acidosis, press the trigger. And if the patient's showing significant signs of ACS, do not wait. So patients have shown pressures up to 18 millimeters of mercury, and then they come back to normal overnight. So this is something which is confounding this entire subject, because virtually every patient after AWR has raised intra-abdominal pressures, but almost all of them have normalization of those pressures after overnight support. And 38% of the cases in Cleveland Clinic study showed significant pressures which are in the ACS territory. So the key points, ladies and gentlemen, is early recognition of ACS or intra-abdominal hypertension is key. Do not let the first 6 hours slide by with the patient going into oliguria, hypotension, and acidosis. This period is very, very crucial. Mild to moderate rise of pressure is tolerated in many patients. We simply don't know who tolerates it and who doesn't tolerate it. That's kind of a very tricky situation. So these 4 things are what I keep in mind for ACS, and I've already mentioned this. Critical care support, of course, this is a given, but has to be mentioned. You should not do it in centers which do not have critical care support. So decompression is life-saving, obviously, but the important thing is ACS kills. It's a deadly disease. Do not underestimate the impact of ACS. The only way we can truly prevent ACS and death is by not operating on complex hernias and loss of domain cases. Now, in a given case, maybe that's the best option. So that is one of the things which I want to share as someone who has seen ACS more often than he should have. I truly want youngsters and those beginning the AWR journey to learn from the mistakes made by others, including me, and not venture into ACS territory. Thank you very much.
Thank you, Dr. Ramana, for that in-depth and a very practical talk, very useful to all of us who are doing abdominal wall reconstruction. And if Dr. Fernando is here, I would like to invite him for special comments on this topic of immense importance to all of us who are abdominal wall reconstruction surgeons. Dr. Fernando? I'm sure he's here.
Unmute yourself, Fernando.
Yeah.
He's muted.
He's muted. Yeah.
Fernando.
Can you hear me now?
Yeah.
Yeah. Hi, guys. Excellent talk, Professor Ramana. I'm in my car, so excuse me for the image in the back image. Anyway, very quickly, when you're doing abdominal wall reconstruction, and as Professor Ramana well stated, we need a lot of humbleness, and that has been shown with this talk. And I've been doing this for 13 years, and what I found was in the beginning, no one cared, no one was interested, and then all of a sudden, more and more people started to become amazed with the results and the lives and the quality of life that we have given. And myself, I've always looked at the patient's safety, and I just put out an article which Professor Ramana commented recently, a few days ago, upon. And like you said today, Professor Ramana, it's very important that if things are not going, that recuperation of the hypertension, of the abdominal hypertension, is not getting better, things are not working well, you just can't look aside. You have to be attentive, pay attention to these patients, because something might be going wrong, and the slightest lactates which are going up and they're not getting better, the acidosis. I also look a lot at the enzymes of ALT and AST, which are not only liver enzymes, they are also let out when you have an enterotomy, unknown enterotomy, or if you're having ischemia. And, you know, even with all of these care and precautions, you may lose a patient. You know, I was listening to Professor Ramana, and in the article that I put out in the World Abdominal Journal of Hernia Surgery, the patients we had, the only death, it was a beautiful surgery. I have the pictures, excellent outcome. And, you know, I sometimes have nightmares thinking that I was too cocky. That's the word, you know. Not that I'm a young surgeon, but I was just, you know, maybe too proud of my work. I don't know. It's very scary. And I think this was an excellent talk. We should pay very much high attention to this type of work, and we are getting more and more to the extremes of in the past inoperable hernias, which are now operable. Congratulations.
Thank you.
Thank you. Thank you, Dr. Fernando, for those nice words of advice and comments on looking at the enzymes and not being too cocky, being afraid more than being cocky. Thank you. Dr. Vivek?
Yeah, I think after this wonderful talk by Dr. Ramana, we'll move on to Dr. Charlotte Horn from Penn State Health in Hershey, US. So she is a fellowship-trained abdominal wall reconstruction surgeon from Cleveland Clinic, and she is going to talk on post-operative management. Dr. Charlotte, please.
Good afternoon and good evening. I'm just going to share my screen so you can see my slides. Awesome. First off, I'd like to thank Dr. Ramana for inviting me to talk today. It's truly such an opportunity to be able to meet all of you and learn from all of you. And I also like to thank him for his talk as well, because I think mine is a really good continuation of what he talked about. And so today my talk is on the postoperative management of patients that have loss of domain hernias that have undergone an abdominal wall reconstruction. I have no relevant disclosures, but I am a lecturer for Medtronic. And so I think a lot of times we spend a significant amount of time pre-operating the patient, making sure they're ready for surgery. We certainly work very, very hard in the OR to ensure the patient had an excellent operation, but then the surgery ends. So what's next? And I think caring for these patients is very, very challenging. And I think the one thing that I know for sure is these certainly are not ERAS patients. Here in the US, we have really adopted these pathways, but these patients are very, very complex for a lot of reasons. And the one thing that we know for sure is there's actually not a lot of data out there that supports what we should do and how to care for these patients. And a lot of the things that we rely on are just expert opinion alone. We do know, however, that if you have a significantly large hernia with greater than 20% of your abdominal contents outside the abdominal cavity, that you're a much higher risk for a postoperative complication. So I think a lot of the postoperative care for these patients is just trying to predict and mitigate any postoperative complications. And as Dr. Ramana so astutely said, these patients are kind of sitting in this borderline of almost abdominal compartment syndrome. And so what do we need to do in order to get them through the acute postoperative period? In my opinion, I think it's the first 48 hours that matter the most. Because as he stated, these patients do actually have a good physiologic response, and their body can adapt to the changes in intra-abdominal pressure. So I think the things that we need to really consider and focus on in the postoperative care of these patients are the respiratory mechanics, volume status, nutrition, VTE prophylaxis, and then lastly, skin and soft tissue. So as Dr. Ramana mentioned, intra-abdominal hypertension is very common. And so Peter et al. Showed that up to 92% of patients had marked or elevated intra-abdominal pressures after surgery. But the good news is often this resolves in the first 24 hours. And we know that patients are at a much higher risk of this, the bigger the hernia is. And so how can we use this information, knowing that this is something that's going to happen, and kind of sit and deal with the acute changes in physiology to get people through the postoperative recovery? And I think one of the first things that we need to talk about, and has been mentioned in previous talks, is the respiratory complications associated with this situation. Obviously, when you have a large loss of domain hernia, pushing the abdominal contents back in results in acute change in pressures. And unfortunately, you have a bony pelvis and things can expand there. So the diaphragm receives a lot of the pressure. And so there's been a lot of data that has showed that there is a bar where you should actually have people that remain intubated after the operation. And what we always do is when we are closing the abdominal cavity, right before we have the anesthesiologist perform an inspiratory pause and give us a plateau pressure. And we know if we change from a initial to a post-closure of greater than 6, those patients should be taken to the ICU, intubated postoperatively. The nice thing that Peter et al. Showed is that these patients can be safely extubated 24 hours postoperatively. So this is an acute change, And I think aggressively extubating these patients to prevent prolonged ventilatory episodes is very important in order to get these people back to normal quickly. I think the other thing that is really, really hard in these patients is trying to figure out where they are in terms of volume status. Certainly, these are long operations. The patient has their bowel eviscerated for a large majority of the operation. Blood loss can be significant. And so in the OR, the insensible losses are extremely hard to measure. Additionally, once you take these patients back to the ICU where they're being cared for, traditional ways that we use to measure volume status can be difficult. Obviously, an IVC ultrasound in someone with a large body habitus and multiple layers of mesh is not going to be very reliable. And so the other problem is a lot of times people have respiratory issues. And so for someone that isn't aware of some of the complications and physiological changes after these repairs, there might be suggestions to diurese these patients because they're having difficulty breathing. And the poor urine output either maybe just poor perfusion, or we're on the spectrum of abdominal compartment syndrome. So it's a very, very delicate balance that you have to maintain in order to make sure these patients are safe. And so what we do know is restricted fluid patterns in these patients is not something that we should do. This was a randomized controlled trial performed by some anesthesiologists that looked at major abdominal cases, and they compared a restrictive resuscitation strategy versus those that had a more judicial. So it was 0.8 cc's per kilo per hour versus 1.5 cc's per kilo per hour. And certainly a lower resuscitative fluid was actually associated with a higher incidence of acute kidney injury. And so their recommendation is that patients receive about 10 to 12 cc's per kilo per hour while in the OR, and should get about 1.5 cc's per kilo per hour in the 24-hour postoperative period. So it's really important to ensure that you are constantly assessing these patients to determine what their volume status is and determine if they're fluid responsive. And I think, the way to do this is try to get as much information as you can as possible. And so I queried a whole bunch of anesthesiologists and said, hey, if you could give me the best measure of volume status, what would that be? Would it be a SWAN? Would it be a CVP? And the answer is there isn't one that's very, very good. So the best thing to do is to get as much numbers as possible. So patients should have the appropriate lines, a CVP catheter, A lines. Some things is easy as just a passive leg raise will be able to tell us if the patient is volume responsive. And so especially in the first 48 hours, minimize diuretics even if they require some ventilatory support, and then continue to maintain euvolemia as much as possible. I think another thing that is a hot topic is these surgeries can be long and maybe bloody, is what to do about VTE prophylaxis in these patients. Janis et al. Showed that an incidence in just straightforward ventral hernia repairs was 2.3%. And in the retrospective analysis of our patients, while I was a trainee, we had a big problem with it was actually PEs with a rate of 4% after posterior component separation. And so we changed our regimen and actually were more aggressive with our VTE prophylaxis, and all patients got heparin before surgery. And then if their kidney function dictated so, they would get Lovenox the night of surgery. And I think, certainly there was a higher incidence of bleeding complications, but especially in patients where they're already having to deal with respiratory issues because of the repair, a PE can be absolutely devastating. And unfortunately, sometimes can't be a lot to do with those. And so it is my practice, despite Caprini scores and all the things that we have, to be aggressive about VTE prophylaxis up front. Give them daily Lovenox if that's possible. And if there's any signs of bleeding, then that can be stopped. And it's important to monitor kidney function because that can often change. And so whether or not you need to switch from Lovenox to heparin, but in general, it is indicated. And I would say try to be a little bit more aggressive than maybe you feel comfortable with, because that's probably going to be the best for the patient. I think another thing that is really hard to kind of determine what to do is what to do about nutrition. Certainly there is a lot of data in the critically ill septic patient that early enteral feeding is beneficial. But again, our patients normally come into the OR pretty well. Nutrition standards are pretty high, as we are very cautious about who we choose to operate on. So I think determining how the operation went, if there's serosal injuries, enterotomies, anastomoses that you have made, I always put an NG tube in these patients because I think, it's almost expected that there's going to be an ileus. And so that kind of saves significant bowel dilation, which can actually also significantly increase intra-abdominal pressures. Additionally, if there's any deep serosal injuries or enterotomies, I often give those people 24 hours of perioperative antibiotics. But what to do about feeding? I feel like this is a constant conversation that we're having with our ICU providers that are helping care for our patients. And while, you know what, these trickle feeds or, you know, baseline enteral feeds, although we do know that enteral feed is definitely better than parenteral nutrition in the long term, I think in these patients, you know, it's safe to go ahead and say, listen, nothing to eat or drink for at least 48 hours afterwards. If, you know, you see a patient that is developing an ileus, there is some data that suggests that early introduction of IV nutrition is actually helps improve morbidity. So I think, you know, if it's day now 3, day 4, you haven't been able to feed your patient, using parenteral nutrition is safe and actually may decrease morbidity, but certainly, you know, these are not the population that you're doing early enteral feeds on, and it's okay to kind of take a step back and wait for there to be some return of bowel function before you initiate enteral feeding. And the last thing I want to talk about is sometimes maybe the last thing we think about is obviously you're dealing with a patient that is, you know, maybe still intubated. You're dealing with swings in blood pressures. You've got hypotension, maybe hyper or hypovolemia. You've done an extensive operation and maybe there wasn't a lot of soft tissue coverage. And now you have to deal with maybe a devastating skin complication. And so how do we mitigate this from happening and what to do once it has happened? And so I think, you know, as always, it's really important to try to keep that patient as physiologically stable as possible. So make sure that they are euvolemic. A lot of times people feel that their maybe pressors should not be used in these patients, but certainly if you're hypotensive, pressors can actually probably help perfuse some of the soft tissue. And then sometimes loss is just inevitable. And so what can you do to salvage any of the skin that's left behind? We have used leeches pretty aggressively, and it's actually shown to have pretty good outcomes, especially if you have a congested flap, maybe a congested hernia sac that you use to cover. The leeches can be very beneficial. Other things that can help are, you know, vasodilatory paste like NitroPaste. And then lastly, if you have complete skin loss, then early use of skin grafts can help cover that piece of mesh that you have there when the patient is stable. So in general, again, these are tough patients to care for postoperatively, and I think it's really just trying to predict what complication and try to mitigate that complication before it even starts. In general, we do have pretty good evidence that patients that have a plateau pressure increase after fascial closure of greater than 6, those patients should go to the ICU intubated for at least 24 hours. Do everything you can to keep these patients euvolemic, avoid diuretics, but make sure to give them maybe a little bit more fluid than we're used to. Initiate VTE prophylaxis early, limit enteral feeding in the early post-op period, but be cautious about how long they've gone NPO for to ensure that they're getting some nutrition. And then lastly, you know, especially when you have swings of blood pressure or persistent hypotension, beware of soft tissue perfusion and ensure that you are concerned about that and then can appropriately care for that if anything happens. Thank you so much for inviting me to talk today. It's been an absolute pleasure.
Thank you so much, Dr. Charlotte. Dr. Pramod, you are muted actually. Dr. Pramod?
Should have had enough practice unmuting yourself over the last 2 years, Pramod.
Yeah.
That was a wonderful talk, Charlotte. We enjoyed every bit of it. Very practical things. And I know that you worked a lot on the enhanced recovery after surgery pathways and published as well. So I think that was a wonderful talk. Dr. Shinde, can we move on to the next talk, please? Can we move on to the next talk, please?
Yeah. I'd like to now invite Dr. Jenny Shao, who's from Charlotte, USC, who's been trained at Carolinas Medical Center, doing excellent work on MIS, GI, and abdominal wall reconstruction. She'll be talking to us about outcomes after surgery. Dr. Jenny, please.
Hi, I'm Jenny Shao with Penn Medicine at the University of Pennsylvania, We'll be talking today about outcomes after surgery for loss of domain and how to optimize the outcomes. These are my disclosures. And how to optimize the outcomes. These are my disclosures. As you've heard from many of our previous speakers, loss of domain is a unique challenge that faces hernia surgeons and comprises some of the most difficult hernias that we fix. Ultimate goals for hernia repair centers around improving quality of life and gain of abdominal wall function for these particular patients. Much like other hernia patients, as we assess outcomes for loss of domain hernia surgery, we define our successes and goals in several different ways. Not only are our goals and successes measured by prevention of complications, hernia recurrence rates, and decreasing postoperative complications, it's also defined by gain of function and improvement of quality of life and cosmesis for our patients. These key areas are important not only for surgical outcomes, but for long-term patient-reported outcomes and quality of life. Many of our patients often belong to a special and unique patient population, representing the sickest patients with the most complex problems. Many of these patients are obese, have had multiple prior abdominal operations, have required damaged laparotomies, emergency operations, or even prolonged hospitalizations for critical illness. And therefore, fixing these hernias present much of a challenge. And because these hernias are so unique, many of the case studies examining the outcomes out there are very heterogeneous in terms of the patient populations seen, and can be compounded by the fact that many of these are also small patient samples that comprise of many different surgical approaches and techniques that are required to fix these challenging hernias. But despite the heterogeneity in the studies, there are some common themes that we can see in these particular case series. We see that due to the increase in complexity of these surgeries and the different techniques required to fix these operations, sometimes the complications can often be compounded. Each successive addition to the procedure is not without additional risk. An additional component separation, paniculectomy, or flap can increase risks and potentials for complications after the surgery. As we can see, many of these patients can develop very specific wound issues, contamination, fistulas, hernia recurrence, and need for reoperations. In this one particular study in 2016, in patients undergoing loss of domain surgery with progressive pneumoperitoneum, we can see that complication rates range anywhere from 32 to 43%, and recurrence rates can be as high as 57% at 18-month follow-up. And based on the overall complication rate seen, the majority of patients experience some sort of postoperative issue, even if many of these were clavien-dendo grade 1 to 3 type complications. So we note that these patients are more complex, but how much does size actually matter? And how much does loss of domain actually impact hernia outcomes? There's definitely a trend for increased hernia size leading to increased complexity, increased operative time, need for component separation, surgical site infection, and potential for postoperative respiratory failure. In one particular paper in 2019, examining volumetrics and 3D analysis of hernia dimensions, the Carolinas group found that increase in hernia size, as determined by certain principal hernia dimensions, are markers for increased size and complexity, which leads to some of these other factors and potential for risk. They define the hernia principal component as several factors comprised of hernia volume, subcutaneous volume, intra-abdominal volume, hernia volume to intra-abdominal volume ratio, BMI, and defect size, and found that these collinear variables are representative of patient hernia size and complexity. What they found was that all of the hernia component actually significantly impacted rates of fascial defect closure, need for component separation, need for paniculectomy, and increased operative time. They also found that increasing complexity and size led to increased length of stay, increased rates of wound complications, 30-day readmission rates, reoperative rates, and recurrence rates. Unsurprisingly, a multivariate analysis, we also see that these hernia principal components lead to increased odds ratios for reoperation, readmission, and wound complication rates. The extra abdominal volume principal component also led to increased rates of wound complication, which is unsurprising as this represents increase in subcutaneous volume and BMI, and that is seen similarly in other hernia outcome studies. What is really interesting on this multivariate analysis is that despite the increased size and complexity, the recurrence rate for these hernias and the odds ratio was not necessarily impacted by hernia size. It was actually impacted by other variables more significantly, such as previous hernia repair and rate of contamination. Unsurprisingly, mesh placement in these patients decreased risk for recurrence. So overall, we find that in similar patient populations, especially in this one particular study, where you examine over 1,000 hernia patients with large hernia volumes, we see that increased defects and increased hernia volume and increased hernia volume to intra-abdominal volume also leads to respiratory insufficiency and potential need for reintubation after hernia operations. This correlates very similarly to other studies seen and potential for respiratory complications postoperatively. But despite all these failures and risks, there are many success stories for patients undergoing loss of domain hernia operations. Patients are not statistics, and therefore each success story represents somebody whose life has been changed by a good operation. And so knowing these loss of domain complications and knowing that these patients have increased complexity, how do we minimize these risks and achieve the goals that we set out to do? How do we go from point A to point B and avoid all these potential pitfalls? So I think the answer could be potentially twofold. I think number one definitely comes with prevention of hernias. As we talk about optimal techniques in abdominal wall closure, we often talk about advances in open abdominal surgery and damaged laparotomies and prevention of fascial retraction and improved techniques to increase fascial closure rates. It also comes from prehabilitation, which really centers around investment and management of comorbidities for patients and prehabilitation prior to surgery. Decreasing each potential layer of complexity can decrease the exponential increase in complications faced when all of these factors compound on top of each other. The other key importance is having a complex multidisciplinary team involved to help solve complex issues in these particular patients. And so overall, optimizing these outcomes is recognizing and minimizing the risks, really understanding all the technical challenges that we face in this complex patient population, and utilizing all the resources available to do a good repair for our patients. And ultimately, focusing on patient goals and patient care will be important in helping improve the quality of life for these complex patients. Ultimately, more research and quality improvement will also help in developing new and novel techniques to prevent and mitigate some of these complications. I'd like to thank my colleagues as well as my mentors for helping me get to where I am today. And I'd like to thank the Abdominal Wall Conference Group for inviting me to give this talk. Thank you so much for your time. I'd like to thank the Abdominal Wall Conference Group for inviting me to give this talk. Thank you so much for your time.
Thank you, Dr. Jenny, especially for a very good short talk and also highlighting that outcomes depends on many factors, not one, and outlining so many of them. Thank you for that nice talk. And
thank you so much for having me.
I would like Dr. to introduce the next
thank you so much
part of the conference.
For having me.
Yeah, thank you.
So I think tech team has to work on the echo. There is an echo there. The tech team needs to work on that echo. Now we need to move on to the next session, which is a very interesting session after the surgery. We have a panel discussion, and we have Professor Ali Sheen from Manchester University. He is a very well-trained senior hernia as well as HPV surgeon who is going to moderate the panel along with Dr. Sharad Sharma. Dr. Sharad Sharma is a senior surgeon, AWR surgeon from Mumbai, and he's the backbone of this entire event. He is the organizing secretary, and he has always been, putting heart and soul into any event of AWRSC. So over to Dr. Sharad Sharma and Professor Ali Sheen, please.
Hello, Professor Sheen, are you there?
Hello, yes. Can you hear me?
Yeah, so Professor Sheen is the president of the British Hernia Society, and I request him to please introduce our next speaker. It's going to be an interesting session, I feel. Professor Sheen.
Excellent. Thank you very much. Well, this is a good session because it's after the surgery. And after the surgery, I tend to just go home and leave my trainees to actually close the abdominal wall. And hopefully they won't call me. And it's that fatal call at midnight, which we all worry about. So we have an exciting group of experts. I think Eric Pauli is first from the United States. He's from the United States. He's very well known. He's an abdominal wall surgeon. And he's going to give us his take on what happens after the operation. Thank you, Eric.
Happy to be here. Thanks for the introduction, Ali. I just need to share my screen, guys, so I can put up my slides. All right, so well, we're going to do some unique clinical scenarios. I asked Ramana if he wanted me to do a post-op complication in an adult or a pediatric loss of domain patient, and he suggested we do the pediatric case. So let's get into it. This is a 2-year-old male with a history of an omphalocele that was managed initially with compression gauze and petroleum due to the large size of the defect. And so he's now 2 years old with this hernia. And you can see that he's got a very wide gap between his rectus abdominis muscles. And actually the insertion of the rectus is very far lateral, almost at the costal margin. It doesn't really insert at the junction of the sternum and xiphoid. You can see on the laterals there as well. Here's the size of the defect. And what I'm pinching here is actually where his rectus inserts. So you get a sense of the large size of the defect on this very small child. And so we approach this with the knowledge that despite the fact that the defect is big, unlike in a lot of the adults that we've been concerned about abdominal compartment syndrome and pulmonary mechanics, that the plasticity of this 2-year-old would allow us to perhaps do some things that I don't think we would ever get away with in an adult. So we gained peritoneal access here, as you can see, and I'm doing this with Dr. Brett Enbreck, one of our pediatric surgeons who used to be here at Penn State, and we're finding the edges of the rectus muscle there. And we're kind of pulling to say, hey, like, is this gonna come or is this not gonna come? We tried to do some things to minimize the risk of future problems in this child. And so we took a page out of Andrew DeVoe's playbook here and decided to not really do any formal component separations, but rather to simply use that hernia sac that had built up over the omphalocele and to simply do a very wide pre-peritoneal repair in a method of a herniaplasty. And I think Dr. Todd Henneford is coming up in a little bit. And I have a new appreciation for all of the pre-peritoneal reconstructions that they do in the Carolinas, because this is not easy. And this is a child who's got very plastic peritoneum. So I can imagine that doing this in adults is even more challenging. We went extremely wide. And, you know, the same way that we would do a wide preperitoneal dissection in the upper abdomen for a subxiphoid hernia or for a Morgagni hernia, we did those same maneuvers here. And notably, not seen on the CT scan is the fact that his diaphragm did not really insert normally because there was no rectus muscle in the midline. So the diaphragm actually inserted into the peritoneal sac of the omphalocele. This is the inferior part of that preperitoneal dissection, which as we got down to the level of the arcuate line became a lot easier, just like it does in any adult patient. And here you can see a very nice posterior layer for sublay placement. Contralateral dissection was essentially a mirror image. The hardest part of this operation was, again, that upper abdominal component where the peritoneum was taken down off the diaphragm all the way up to the central tendon. When we do that dissection in adults, I sometimes remind my residents and fellows that somewhere up there is the middle hepatic vein, although I've never seen it in an adult. And I kind of reminded our pediatric team the same thing. Hey, this is where we're headed. And then minutes later, we actually saw it. So we knew to stop the dissection at that level. This is simple closure of the posterior layer. We did have a couple small holes out lateral where the peritoneum was pretty thin. And again, those were closed with some running absorbable 2O suture here. This is us reapproximating the rectus in the upper abdomen. You can see in the midsection there, we actually had the diaphragm. And so the diaphragm itself is free floating. We want to reinsert that. There was also a fair bit of tension still on the rectus coming to the midline. So again, in an effort to avoid any component separation, we simply moved on to raising some very large skin flaps and undermining the skin. And again, when we did that, we've got a large space for mesh overlap. And we also were able to alleviate enough tension just by making skin flaps that rectus now comes together. This is a piece of bioabsorbable mesh. It's a 4-hydroxybutyrate. We elected to use a mesh in this circumstance, given the amount of tension that the repair was still going to be under. And given that it was a child, we did not want to use a permanent synthetic mesh. So this was our choice that we had talked with the parents ahead of time. So this is essentially us securing it with some fibrin sealant. And then here we are reapproximating the rectus. And at the same time, we are reinserting the lower slips of the diaphragm back into the rectus muscle themselves. We elected to do an interrupted closure here, as I do in adults when the defect is under tension. And then we moved on to doing some skin work. The lecture earlier on paniculectomy and on creation of neo-umbilicus was great. I definitely remove many more umbilici than I create, but we elected here to do a simultaneous formation of a neo-umbilicus, given that this is a child who the cosmetic appearance of this obviously matters. As my pediatric surgeon I was working with said, every kid deserves to have a good looking belly button. So they recreated an umbilicus and we simply closed the remainder of the skin in a standard fashion. You can see how thin he is and the drain there. He stayed intubated only overnight. After that, he was extubated and quickly moved to floor status. He was in the hospital for about 5 days post-op total, mostly for pain management, and otherwise has done well. He's now 2 years out from this operation without any significant problems or complications. So I think the unique parts of this case are the child, the fact that this large defect was able to be closed without component separations. And I think his ability to tolerate this speaks a lot to the plasticity of the child abdominal wall in compared to the adult abdominal wall. Thank you.
Thank you.
Thank you very much.
Dr. Eric, I think it was a great case that you have demonstrated. I think it was the first pediatric LOD discussed in this particular conference, I think.
I think that's why Romano wanted me to do it.
True. Can we move on to the next speaker? I think we will have another interesting case from Dr. Hari Kumar Ondiviran. He is the president of Canadian Hernia Society, and I appreciate his very practical approach to hernia surgery. Professor Hari, please take over.
Hi, everybody. I hope you guys can hear me.
Yes, we can. Yes.
Yeah. So just wanted to share a couple of patients. One is a case I did, and not everything is bad. We do a lot of abdominal wall reconstruction, and most of the time things go well. This is a case I did earlier this year. This is a 68-year-old lady who had developed a massive right flank hernia. Can you guys see my slides?
No.
Oh, okay. Let me try put it up. Oh, sorry. I'll give you a couple of. So this
It's
is
working, Harry.
It
Pardon?
works. It's okay.
Amazing. So this is a lady who's a 59-year-old lady who had a previous hernia repair with recurrence and an EC fistula. So she had come to me, she had loss of domain. While I was working her up, I found that this is why I still believe in the old-fashioned listen to your patient's heart. And we found a murmur. Eventually we found that she had a left atrial myxoma. She had that repaired, and about 8 months later, I did her. This was her CT before the surgery, and as you can see, she does have significant loss of domain. I've become a believer, and Jan, I hope you are appreciative of Botox as well as progressive preoperative pneumoperitoneum. And I do that about a month before the surgery and about 3 weeks of pneumoperitoneum. And this is what it looked like when I took her to the operating room. As you can see, one of the benefits of pneumoperitoneum is it really helps out with the lysis of adhesions. Post-operative, I managed to put her back together, did a TAR on her with a large home-based mesh placement. 2 days after surgery, her hemoglobin plummeted down to about in the 50s. And I was worried she was having an intra-abdominal bleed. But again, I did a CT, and as you can see, she had a huge subcutaneous bleed, which we managed non-operatively. I thought about taking her to OR, but we managed to just deal with it. She is about 8 months out of surgery now, and she's doing well. She's very happy with her repair. She's got her life back. And yes, there's a complication after surgery, but most of the time we can handle these things. The next case I like to share, if I can find it, is sorry. I don't seem to be able to share. Okay. I'm sorry, guys. The next case is actually a lady that I did a flank hernia repair on. And this lady had a loss of domain. I'm going to stop sharing for a while. Pull up my other slides. Yes, a 68-year-old lady who had developed a massive right flank hernia after a partial nephrectomy. She was morbidly obese when she came to me. And I must confess that we do not have bariatric surgery in our place. So it is very hard to get bariatric surgery for weight loss. So I talked to her about lifestyle modification. We had a big discussion. She left my office in tears. She came back about 2 months later with some weight loss, and eventually she managed to lose 70 pounds all by herself by lifestyle modification. So again, this is a lady I did 3 weeks of Botox and pneumoperitoneum. Interestingly, the defect was between the 11th and 12th rib, and these ribs were splayed apart. So I reached out to a friend, and this calling a friend really helps. This time it was Vedra out of Carolinas, and she mentioned that she had been doing some of the flank hernias with using rib plating so that they can bring the ribs close together. And together with my thoracic surgeon, we did that. So this was the preoperative CT before the surgery. And then we did the rib plating, bring the ribs back together. And this is her CT about a month after her surgery. As you can see, we have reduced everything. Her abdominal wall integrity is back to normal. Again, another lady who is extremely happy with the results of what we were able to do. I must stress in both these cases, weight loss was an important part of the repair. Without the weight loss, I don't think we would have been able to put them back together, put the abdominal wall back together, and both of them went on to lose a significant amount of weight before we could repair them. So these are two of my successes so far in loss of domain, and I've become a believer of the combination of Botox and pneumoperitoneum prior to surgery. And with that, I would like to just show one more case for the rest of the panel to see whether they can help me out with this patient.
I can't say this.
I've got another lady who has a huge hernia, and her BMI is 50. Her hernia is down to her knee, and
Hari, you have to share your screen and then you have to hit play in the presentation.
yes, I'm trying to get my screen out. Sorry, guys. So again, trying to share again, it's just they are placed in different places. Sorry, here we are. So it's a 61-year-old lady who had a bariatric bypass done about 15 years ago. From a description, she ended up having an open surgery at some point due to complications. Her current BMI is about 47 or so. This is her CT scan. If you guys can see, this is how big the hernia is. This is down to her knees. And as you can see, almost everything is out in the hernia. And I've been trying to get her to lose weight. She had bypass done. Those of you who are bariatric surgeons, what would you suggest? I'll throw it to the rest of the panelists there. And with that, thank you guys. And thank you, Ramana, for inviting me for this wonderful session, because I've never attended a meeting of surgical importance with 7,000 people watching. And one more thing for those of you in India, happy Independence Day, which is tomorrow.
Thank you.
Thank you very much. Without further ado, that was very nice, Harry. Thank you very much. We've got Javier Lopez Monclus. I hope I've pronounced that correctly. Hola, ¿cómo está? And bienvenido, gracias. He's a liver transplant surgeon from Madrid, Spain, but he also undertakes some abdominal wall surgery. Gracias.
Thank you.
Okay. Sound.
Sound, Javier.
We have no sound. Unmute yourself, Javier.
It's a video, so I'm waiting. They are running it with the audio.
It will work.
Hello, everybody. Here I'm going to present my clinical case. Important. I'm telling what I did in this case, but it doesn't mean I am right. It's a 47-year-old male with a right post-traumatic diaphragmatic hernia who was operated by our esophageal surgeons, and they performed a prima closure of the defect, and they had a problem closing the abdominal wall, and they closed with a PTF mesh with an IPON technique. I met the patient in the year 2017, no comorbidities, BMI 30, almost 30, And here you can see in the CT scan, really important subcostal bilateral incisional hernia with loss of domain. You can see how the liver, the gallbladder, the stomach, the duodenum, almost all the small bowel and part of the large bowel are displaced in the hernia sac. So what did I do? Operation or optimization? Well, we all know the answer, of course, the loss of the main pre-op package, Botox, percutaneous catheter, respiratory physiotherapy. This is a picture the day before the surgery with the pneumo catheter. And well, the control CT scan was not too good. And you can see how the pneumoperitoneum in this case didn't work so well, didn't perform the mechanical adhesolysis that it might perform in other cases. So with this CT scan in my hand, I could guess that surgery was going to be a little bit difficult. What did I find? There was a 25 times 35 centimeters abdominal wall defect. There was dense bowel adhesions despite the pneumo, and the previous mesh was impacted in the transverse colon. Long surgery, almost 9 hours. I performed extended right hemicolectomy with an ileocolic anastomosis and a posterior component separation with a really overextended preperitoneal dissection. I placed 2 absorbable meshes, one 50x50 synthetic permanent mesh and another 30x30 polypropylene mesh to restore the facet transversalis. And despite the component separation, I had to bridge. I had a large bridge. This is the picture of the colon. This is the reconstruction over the meshes of the abdominal wall with the bridge and covering the bridge with the rest of the sac. Everything was fine during the postoperative period, but when he was going to be discharged from the hospital in the 10th postoperative day, he started with fever. And here, this is what I found in the CT scan. There was a leakage of the ileocolic anastomosis with gas in the subcutaneous, some liquid in the rest of the hernia sac. So the question here was, what do I do with this complex patient? He's stable. Should I operate or not to operate? Well, finally, I decided to operate. I approached through the previous laparotomy. I cut the polypropylene mesh. I removed the non-integrated absorbable mesh that was over the infection. And I saw just a small, really small leakage. It was less than 1 millimeter defect. So I just decided to suture this defect. It's important to see how the meshes were already in the 10th postoperative day integrated. If we take a closer look, you can see how away from the infection in the 10th day, the meshes are already integrated in the native tissue. I was a lot. I placed drains, I placed another absorbable mesh, and I resuture the polypropylene mesh. In the postoperative period, there was no complications. He was discharged in the 12th postoperative day of this second surgery. And after more than 5 years follow-up, we don't have any incisional hernia recurrence. He works as a mechanic and the abdominal wall is functional. Thank you. Hello, everybody. Here I'm going.
Thank you very much. I think Gerard's going to introduce our last speaker.
Thank you. I would like to invite our very senior surgeon, Professor Valentin Oprea from Romania. He has great interest in the hernia surgery. He is at the Dr. Constantin Papilian Military Emergency Hospital at Cluj-Napoca. Welcome, Dr. Valentin. Please give your presentation.
Thank you for inviting me to this gorgeous symposium. I want to slide my shares if you don't mind. Because, can you hear me?
Yes.
Yes. I want to share my screen, but it seems that it's not possible.
It already did.
No, my presentation is without comments, and I wanted to do it live.
Yes.
You can share it now, sir.
Yeah, you can do it.
Okay.
Now, put it full size, Valentin.
Yes, full size.
In the bottom, yeah.
It's about a 71 years old lady. It was admitted in our Department of Surgery 5 years ago for abdominal pain and a large irreducible bulge in the right inferior quadrant with a BMI about 30, 31. She has a very rich surgical history with a lot of surgical procedures in the last 30 years with an open cholecystectomy and multiple failed repair of recurrent incisional hernia. Medically speaking, she has diabetes, a compensated diabetes, a controlled arterial hypertension, and COPD relatively controlled under her medication, with not excessive alteration of respiratory function, and with normal values of blood gases. CT scan show a loss of the main with a peritoneal index with Sabach formula of about 0.43 and multiple defects summing 21 centimeter width and length and an area about 350 square centimeters. Large amount of small bowel and also large bowel were present in all the defects. We do it, we try to optimize the patient, but at that moment, Botox wasn't available for us. We have 2 failed attempts of inserted pneumoperitoneum catheter because we were afraid about intense adhesions. Intraoperatively, it took almost 2 hours to take down all the adhesions. And after that, it was quite difficult to reduce the hernia content. Here is the defect, a lateral defect, bridged with a midline by a small component of tissues, as you see here. We proceed with posterior, bilateral posterior component separation with a large dissection almost to the posterior axillary line. And we insert a double gilted mesh about 30 centimeters, both of them, medium weight macroporous polypropylene mesh. And fortunately, we were able to close the anterior fascia also. We have a moderate raise of intra-abdominal pressure in the first postoperative day. And immediately after the closure of the fascia, increasing of the plateau pressure was not larger than 5. So we don't have any reason to believe that the outcomes of the patient will be unfavorable. But in the third postoperative day, intra-abdominal pressure increased to 22. Also, we have increased dioxide of carbon. We have a decreased oxygenation and an increased lactate. So we have a lot of reason to intubate it and mechanically ventilated this patient. Fortunately, renal function was not very altered, and we have a very good abdominal perfusion pressure. So after 5 days of increased positive end expiratory pressure, the patient was recovered. We can extubate her, and it was discharged after another 10 days. we believe that these unfavorable outcomes are mainly due to impossibility to locally optimize the patient, being aware to the fact that intra-abdominal pressure and post-operative intra-abdominal pressure and plateau pressure are strictly dependent on the incisional hernia volume and of the peritoneal index. Thank you for your time, and I'm happy to be with you today. And don't forget, we are invited to Romanian Hernia Days in October. We hope to have a live session for all of you.
Excellent. Thank you very much. I mean, all four speakers were outstanding. Thank you to Eric, Javier, Harry, and Valentin. I just have one question for all of you. That is, what percentage of patients you turn away for loss of domain surgery and the commonest reason why? Just to close this meeting. Thank you.
If I can go first, I actually don't turn away anyone unless they refuse to stop smoking or they are not going to be involved in pre-operative optimization. Those are the only ones I won't do. The others, I will try my best to give them a better quality of life than what they have.
Okay, the screen is completely blank, Tech. I don't know if that's intentional.
Well, it's Valentin's. Unshare, please.
Right, okay.
I don't operate on patients with oxygen at home. And in last 2 years, if I cannot optimize them, I refuse to operate.
Okay.
In my case, I don't smoke in this situation in extreme complex abdominal wall patients. I wouldn't operate in smokers, and well, in extremely frail patients, I insist on not undergoing any procedure if they can do a regular life. But it's a patient decision. Many patients say that, well, if I have to live this way, I want to take the risks. And in that situation, most of the cases, finally, I perform the operation.
I have a question.
Sharad, you're on mute. Sharad, you're on mute.
So you're on mute, Sharad sir.
I said, I believe there is a term called end-stage hernia. Does anyone believe in such a terminology?
Who doesn't?
I do look after quite a few of them with that kind of issues, but I think before I say it's end stage, it is probably because of the fact that they have a whole bunch of comorbidities that prevent you from trying to get them into OR to try to do something for them. You can't just look at the hernia as one entity. You have to look at the patient, and that's sort of where I look at the patient and say, you know what, you living with this is going to be better than trying to do something and shorten your life and make your quality of life worse. And that's
so
sort
Harry,
of
Harry, forgive me, if you're a smoker and you have your hernia carried around in a wheelbarrow in front of you, you will still offer them surgery.
No, they have to stop smoking. They have to. I think all of us are agreeing on one thing, that pre-operative optimization is what is the important thing. And if we cannot optimize the patient, then we should seriously consider not doing the surgery. And
there is one,
and all those kind of things.
There is one funny thing about these giant hernias in elderly patients, is that many times I have find that in the patient clinic, I start talking and telling the patient, the old patient, the fragile patient, why I'm not going to operate the huge hernia. And in many cases, after 20 minutes talking, the patient says, no, I don't want to undergo any surgery because for my life with a binder, I have a good life, but it's my physician who insists in that I have to go to the surgeon because I have a large hernia. So that's something important. I think really important to talk a lot with the patients. Yeah.
So we have to move on.
Yeah.
I'm sorry to be a party pooper, but it's we're really beyond time. So we'll
Thank
please
you very
start
much.
with the next
Thank you for the
session. Thank you so
invitation.
much.
Absolutely.
Thank you. Thank you. Over to Brijesh.
Yeah, thank you, Soumya. Good evening, everyone. I'm Dr. Brijesh Dubey from AWR Surgeons Community, and I hope you all are in this feast of AWR today. We are now into the last session of this global, and it's called Advanced Technical Aspects. Chairperson for these sessions are Dr. Ramana, the founder president of AWR Surgeons Community, and Dr. Arun Prasad. He is a prominent core member of AWRSC and pediatric and robotic consultant at Apollo Hospital, Delhi. Dr. Abhay Dalvi, he is the president of Association of Surgeons of India and is the head of the Department of Surgery in KM Hospital, Mumbai. So I hereby invite the chairpersons to take over session. Thank you.
All right. Thank you very much. Without further ado, let's invite Dr. Todd Henneford, who is a living legend in abdominal wall reconstruction surgery. And we are all eagerly waiting to hear from him about the technical tips of managing large hernias. Todd, are you here?
I am. Can you
Yes.
hear me?
Absolutely.
Yeah, fantastic. And then how about seeing my slides?
It's all right. It's perfect.
So if there's any delay, if there's a problem, guys, just switch to my
don't
videotape session. Great. And Ram, thank you for the invitation, the organizing committee. It really is amazing how you keep churning these things out, and tens of thousands of people actually come in and listen to this. It's the change in hernia repair over the last 20 years is just amazing. And it's not just the techniques and the technical considerations and how we treat our patients, it's the interest. And through things like this, we can absolutely improve care. You asked me to talk about large hernias, and I think that there are so many things we could talk about in loss of domain, large hernias, and you've covered so much of this today, and the program's been extremely well designed. But I think one of the things that's terribly important is to always center on the goals that you set for the patient. One of the most important ways to define or to have success is with the patient. I mean, of course, I think Jenny Shao gave a beautiful talk earlier about the measurement of success. Mine mimics hers very much. It's not just about recurrence, and it's just about complications. It's also function. It's also talking to the patient. It's a measurement of the patient's quality of life. It's the patient's goals, and also their understanding of these goals. They're not being unrealistic when they come to a specialist, come to a surgeon to help them. And then another way, of course, to measure success is the use of your resources. How to use these resources, for individual patients versus your whole patient group. And different patients will have different goals, different considerations of what their quality of life is, and different thoughts about how they want to improve. And then you can tick off these boxes with the patient. But I think education and understanding and setting goals, therefore you can set success, what success is. First, I mean, someone did describe or talked about who should be doing these. Ram gave a comment or two in his lecture that if you're going to be doing bigger operations, loss of domain operations, first you need to be doing these. It needs to be done by surgeons who would do a lot of them. If you only do a few or have the opportunity to do a few of these a year, that's probably not something you should be doing. And also, the consideration of like the hospital. Ram mentioned the ICU support. Absolutely. In our group, about 7% of these people will at least spend a part of their time in an ICU, whether it's due to pulmonary insufficiency or other issues. If you have loss of domain, you need to be ready for this. And I will tell you, the dividing line is if you have about a third of your intestinal volume outside of your abdomen, that tends to be a dividing line for us where these patients become higher risk. I think that you should consider not doing these operations in patients who don't understand the significance of the operation. Of course, very easily, patients who don't tolerate the repair. And I also think one of the assessments that was made in the last session is it's about the patient's quality of life. If we're not going to significantly impact the patient's quality of life, then perhaps we shouldn't do the operation. These large defects, most of them are not at risk for bowel obstruction and other problems because of the defect. Some data that Mike Liang presented And I'll say it's as good a data as we have. It's not great. Defects between about 2 centimeters and about 7 centimeters are the ones we need to worry about. These massive defects typically do not keep people in trouble. So, and we are quality of life doctors. We have to set this. You have to approach this with these patients. It's not a hole that we just have to fill. It's about setting expectations, and truly, it's about the quality of life of our patients. And I frequently now walk into the room and tell the patient, "I'm your quality of life doctor." And so, I'll talk to patients like, "What do you do now?" And they'll say, "Well, I sit on the couch and I eat potato chips and I watch Netflix." And what are you going to do if I fix your hernia, this massive hernia? Well, I'm going to sit on the couch and eat potato chips, watch Netflix. If I'm not going to make a change in their life, then perhaps we shouldn't do it at all. To emphasize the consideration of how complex these patients are, we published a paper, and this is Sean Maloney, one of our former residents, published this paper in Surgery a couple of years ago, where we looked at 775 consecutive component separations. The problem with this, and everybody's talked about this, there's such a huge difference in hernia patients. And so what we try to do is we'll present the broad group, but then what we try to do is narrow the focus down to some of the less complex patients, or chip off the ones that are outside the standard bell-shaped curve. And so what we did in this group is we looked at patients with no diabetes, no tobacco use, BMI less than 35, which is still big, and we were able to get the fascia closed and non-contaminated. And so if you look at this group, this was only 22% of that 775 patients, emphasizing the complexity of these patients. And if you look at our outcomes off to the side over here, if you give me a non-complex patient, even who needs a component separation, our outcomes can be pretty damn good. The problem is that about 80% of these people are complex, and we have to be ready for it. I think what I start off with is I want to know what the previous operations are. Especially most of these will have had previous hernia repair failures, and I want to see at least the last operation. And if I get all the operative notes, I want to get them. Do your homework. The imaging, you need to review imaging, and almost all these people will get a CAT scan. It's not available everywhere in the world, but it's pretty dadgum ubiquitous, and a CAT scan certainly helps me. And I think the treatment of patient comorbidities, and I'll talk about that in a second, but we have to plan. You have to have a plan to get the fascia closed. And if you haven't planned to get hope is not a plan. It's weight loss, and then the consideration of Botox, consideration of pneumoperitoneum, which we've had the lectures about this morning, and then of course the addition of component separation. I will tell you, we work hard not to do component separations if we can help it. We want to preserve the abdominal wall, the functional abdominal wall as it is. So we do work hard to prevent us from doing that. Eric gave a wonderful lecture on preoperative CAT scans and the use of CAT scans, and I think it absolutely is super helpful. And it's so often that you will get a CAT scan, you get the operative notes, you get the care records, and then you compare it to a CAT scan, and they don't match. A CAT scan to me is it's like when I played football in high school and college. You would see the video of the play, and it's the eye in the sky doesn't lie. It's kind of like the CAT scan. The things that tell the truth: small children, drunk people in yoga pants. And I'll put on here CAT scans, because like this person has a massive ventral hernia, and you can see that previously had a documented external oblique release, and you can see the external oblique fascia. Even if you look in the corner down here, you can actually see the external oblique fascia still intact in this patient, which does impact my operation. For this gentleman, this patient had a bilateral TAR. Of course, the surgeon cuts completely through the simular narrows, translate all the vessels to the and nerves to the rectus muscle. And so it's about function, and it's about setting expectations. And when you get in the operating room, you know what you found here. Of course, the midline's still intact in this patient, but they've blown out their sides, and the rectus muscles are never going to work again. But it helps us set expectations and what I'm going to do in the operating room. Lastly, I review the CAT scan again while the patient's going to sleep. And I do that, first and foremost, a complete reexamination, make sure that I see all the defects, and frequently the abdomens are large or thick, and you can't feel all of them, so I know what I'm going after. And then also getting in the abdomen safely. Where do I get in the abdomen safely and not causing an enterotomy? And then, of course, defining the non-starters. This gentleman comes into clinic, multiple failed hernias, and you get a CAT scan like this, where I've never seen someone's vena cava trying to get out of their abdomen. And so he has his distal esophagus in his abdomen. He has one kidney in his abdomen and his rectum. And so things like this, again, just planning, keeping yourself out of trouble. We talked about, and it has been discussed, getting your patients ready for surgery. Many of these patients are complex, and I try to get them from being so complex to a less complex animal before I operate on them. Smoking, obesity, diabetes, we have these things, and these risks for complications are well described in our CEDAR app, which is free and available on the Droid store and the Apple store. But also, like intraoperatively, not having an enterotomy, careful, safe surgery, as well as getting these patients ready. But everyone talks about getting these patients ready, and it makes a huge difference. You develop a wound complication. This is something we presented to the American College of Surgeons a couple of years ago, when we looked at our patients who developed wound complications versus those that did not develop wound complication. You looked at their quality of life 6 months after surgery, and it dramatically impacts quality of life. So it's about your outcomes. Wound complications yield a threefold increase in chance of failure. So if you're going to not get your patient ready, just increase your chance of wound complications by 3x. And then it also impacts their quality of life. This is an article that just came out recently, last month, as a matter of fact. And of course, these surgeons, this is done by Dana Tellem at the University of Michigan. And the surgeons know that they should be doing preoperative optimization, but they have all of these excuses why they don't do it. And this is a famous quote by John Maxwell, this kind of leadership guru, where he talks about the effectiveness of something is about the quality times the acceptance. Of course, we know that getting people ready is effective and helps us. We know that the quality of data is really good and people accept that it's true. But the problem, I'll add one more thing in here, and I'll add performance, because if performance is zero, effectiveness is zero. And for me, if you're going to be a specialist, be a specialist. If you're going to do abdominal wall reconstruction and mean it, then do everything. Don't just learn the tricks and the tips in the operating room. It's about the whole care of the patient. And it is about their quality of life, and it is about cost, and it is about your final outcomes. But all of that has to be meshed together. I know Sean Ornstein gave a talk this morning about exercise prior to surgery. There's great data that demonstrates, how far someone can walk in 6 minutes. Their walking speed for 6 minutes predicts outcomes in higher risk patients. And we've just started this in our own clinic. We've learned so much from all of those articles, and we keep changing. And so our average age in this, we got a grant from the American Hernia Society. The study is prospectively 69 years old is the average age for this. We don't do this with people who are otherwise have no problems with walking. We've had 100% patient compliance. In 6 minutes, within 6 weeks, in 6 minutes, they've increased their walking distance by 900 feet and a mean weight loss of 15 pounds. So we've now started this with all of our patients. And if you want, and I can get this to you, Ram, if you guys want this protocol, we can certainly share it. Educating our patients. We've now put together booklets about, everything from your prevention of DVT, what your folded catheter is like, and send a spirometer, taking care of your drains, taking care of drains at home. We try to eliminate patient factors which decrease our effectiveness in taking care of them, and also impact our outcomes. Again, we've published just recent data on this, and looking at patient education, and this is in opioids. And Dr. Slater gave a great talk earlier this morning about planning your incisions. And this is all of this is about improving your outcomes and having a true strategy when you go to the operating room. One of the things that we've done recently is we're now trying to give cephalosporins to our penicillin allergic patients. And I'm not sure how it is around the world, but our first line drug for these clean operations is cefazolin. For contaminated, it's cefazolin plus Flagyl. But if someone is penicillin allergic in the United States, and that varies around 11% or so, people will say they're penicillin allergic, we give clindamycin or vancomycin, which are not very good drugs. Let's just say it, they're not. And so cefazolin is a much better, much more aggressive antibiotic to kill bacteria. And so there's really good data that demonstrates, even if someone is penicillin allergic, not that they say they're penicillin allergic, if they are penicillin allergic, it's about a 1% chance there's cross-reactivity with the first generation cephalosporin. And so why haven't we been more aggressive in giving cephalosporin in these patients? And in the United States, it is not the standard. And so Katie Schlosser, and many of you will know that name, she's did some great work in our lab, and now as a resident of Ohio State, and we'd be joining Alfie Carbonell and Will Cobb in Greenville for fellowship. She looked at our penicillin allergic patients, and 85% of them did not receive a beta-lactam antibiotic. We had higher SSI, higher surgical site occurrence requiring a procedure, and higher 30-day readmission in these patients. And this is not just in hernia, it's now replete in the literature. And this is just one study showing in various operations, it makes a huge difference. It decreased wound complications in this group by 50%. And in colon surgery, it's like twice. It will decrease it by twofold. And so we need to do this. So we've now started this in our hospital. We give them a cephalosporin questionnaire to determine what their actual risk is. We put them through this algorithm here, and what we'll see is about 80% of our patients now, 85% of our patients receive a beta-lactam, and we believe this will significantly improve our outcomes. Again, looking at what impacts our outcomes surgically, wound complications, we've talked about that. We know about anterior component separations versus posterior component separations, and a posterior component separation has been a shot heard around the world, and people have just really picked this up, and a lot of it for the right reasons. But wound complications are higher in anterior component separations, and there's no question about that. And if we get a wound complication, and this is our data from that 775 component separations, we get a wound complication, we get a 5-fold increased chance of a hernia recurrence in this 775 patients, 5-fold. So if 1 + 1 = 2, then anterior component separation causes wound complications, which causes hernia recurrence. So therefore, we shouldn't do anterior component separations. But even more important than doing an anterior component separation is getting the fascia closed. You can see the bottom down there. If we get the fascia, recurrence rate is really small. We use huge pieces of mesh. We line the abdomen, get the abdomen closed, try and take care of the wounds. But if we don't get the fascia closed, our failure rate is 16%. So yeah, wound complications are important, but getting the fascia closed even more important. And this is my algorithm that I wrote for one of our fellows a couple of years ago. He just asked me, I just come out after seeing a patient, this is what I think we want to do. And he said, can you just put this down for me? And so this is what I came up with, less than 8 centimeters, no loss of domain is dealer's choice. Less than 8 centimeters and massive loss of domain, I tend to do preoperative Botox in those patients. And I also do pneumoperitoneum. When I have small hernias, pneumoperitoneum to me seems to be more effective. If I've got really big defects, it seems like I blow up the skin. I make this stuff really stretch the skin. And so I tend to go with smaller defects like massive loss of domain in inguinal hernias, pre-op Botox and pneumoperitoneum. The go-to move for me. Moderate sized defects, no loss of domain. The first thing I try and do is I'll cut the posterior rectus sheath. I do a preperitoneal dissection, and then so I can do any component separation I want. I do that first, and then I'm closing the abdomen. Bilateral posterior rectus sheath release of the rectus. If that gets me together, then terrific, I'm done. If it doesn't get me together, if it's greater than 6 centimeters, I get to an external oblique release. I believe I get more release with an external oblique release, especially if I've already cut the posterior rectus sheath. If it's less than 6 centimeters, and this is putting tension on it and pulling. And if I'm pulling and it's greater than 6 centimeters, I'm going to an external oblique release. And then I'll do it. I'll do one side and quit if it gets me together, or I'll do both sides. It's necessary. And then for these massive loss of domain patients, of course, we really press on weight loss. Everybody, we want to lose weight. Everybody want to lose weight, trying to prevent a component separation. And then, of course, it's preoperative Botox for a massive hernias with loss of domain versus using pneumoperitoneum, which is, again, my bias in that consideration. We do a preperitoneal dissection, so we can put a huge piece of mesh in. You can wrap this around to the kidneys if you want, to the xiphoid, to the pubis, over the diaphragm, etc. And so, again, we can put in large pieces of mesh there. A couple of more things, and I'll stop here. Katie Schlosser, again, work that Katie did. What does weight loss do for us as far as decreasing our need for component separation? She measured intra-abdominal volume, hernia volume, sub-Q volume in almost 1,200 patients. And these patients had at least 2 CAT scans 6 months apart, and just 11 pounds of weight loss, 5 kilograms of weight loss significantly impacted the intra-abdominal volume and the total visceral volume. And also the subcutaneous fat volume. Does weight loss matter? It does. Unfortunately for men are on the left side, women on the right. Men carry their weight in their abdomen, so they lose a lot more volume in their abdomen with weight loss. Women still lose volume, but they need to lose more weight than men because they distribute their weight. And yet a patient like this, 15 centimeter defect, moderate loss of domain, she's going to need a component separation to get her together. 34 pounds of weight loss later, her defect is still 15 centimeters, but we easily close her abdomen. Of course, she chose to get a paniculectomy at that time because of her weight loss, but no component separation for her. One other thing that weight loss does for us, and this is a study we did a number of years ago, we put catheters, Foley catheters in patients and measured bladder pressure. And we had them doing different exercises, normal weight individuals versus morbidly obese individuals. And you can see the huge difference in intra-abdominal pressure. You know, hernia failure, I mean, it's a physics equation. It's wounds, of course, and wound healing, but it also is a physics equation. If you don't have pressure on your abdominal wall, it's not going to pull apart. People who are morbidly obese have a dramatic increase in intra-abdominal pressure. The arm curling 20 pounds, you can see the difference. It's 2.5-fold increase in intra-abdominal pressure. Similar to bench pressing 25 pounds, 3 times increased pressure with that. A standing cough, standing Valsalva, even just going from a sitting to a standing position, it's almost 2.5 times increased pressure. So weight loss, super important in taking care of these people. There were 13 people who were morbidly obese. They underwent gastric bypass. They served as their own control. We repeated the study, and you can see the difference in intra-abdominal pressure in those patients. So weight loss matters. So a patient like this, she lost weight. Of course, she lost 47 pounds. We did a transverse abdominis release on her, got her completely back together again. So weight loss plus a transverse abdominis release. How about Botox? Real quickly, I'll just say, we now have 108 patients that we've done Botox in. Jenny Chow and Eva Derenberg actually studied these patients very closely for us. And what they found, I think, is super important. First and foremost, we're really putting a challenge to Botox here, 15 centimeter defects. You can see the mean defect size. The hernia volume is tremendous. And you can, most importantly, the hernia volume to the abdominal volume at 0.86. So these are really big defects with real loss of domain. So we're putting it through its paces. We got 91% of these patients got their fascia closed, but we had to add component separation to a number of these. And I'll just tell you, the Botox does not work very well for M1 hernias. Just put that in. Now, if you've got a hernia that goes up and down the abdomen, wide at the top and all the way wide at the bottom, it helps us get together from M2 to M3 and M4 and M5. But we tend to do an external oblique release high to get the muscle off the costal margin to get people closed. Just my 2 cents worth about that. One other thing is, I think it's super important, came from Chuck Butler, is doing a vessel preserving external oblique release. And of course, you can see these perforators that come from the deep epigastrics. Here's a deep epigastrics, beautiful CT scan showing these perforators. Most of them are peri-umbilical, 2 centimeters above, 5 centimeters below the umbilicus. So instead of blowing through the abdominal wall like I used to do, we now look for these perforators. Even when I'm just mobilizing skin flaps and not doing an external oblique release, I save the perforators and I look for them. And what you can do instead is 2 centimeters above, 5 centimeters below, just create a wedge-shaped section of tissue. Don't look for the perforators and just do your external oblique release above and below, just making a tunnel. And does that make a difference? And so it actually really does. So Charbel Elhaj, one of our residents in the lab, looked at this, the perforator sparing anterior component separation versus the TAR. The defect size was very different. Operative time was a little longer for the just because of the larger defects in those patients. But if you look at our wound complications, they're exactly the same. So we're no longer avoiding an external oblique release if we think it's going to get the abdomen together. We just do a perforator sparing. Just these guys, they've just made us better surgeons. So you got to take a patient like this with marked loss of domain. And as you can see here in his lower abdomen, the only thing he has in his abdomen is just his mesentery and his rectum. And so in my working with him, he lost 37 pounds, he got preoperative Botox, and then intraoperatively, he got a component separation. So he got the trifecta. And of course, this is a total preperitoneal dissection in these patients. You can take the peritoneum right off the skin graft. People say, well, you can never do a preperitoneal dissection in these folks. I'll tell you, I'd love to share it with you. Come to Charlotte and let us show you. But this came, the mesothelium came right off that skin graft. We never saw the intestine, total extraperitoneal, external oblique release. And this is what it looked like when we completed the operation. One last thing, this is a patient with a massive peristomal hernia. She also has a Band-Aid where her mesh fistula is here. This is a case I did with Ava Derenberg and Jeannie Schau, and this is her in the operating room. You can see her, this is her midline hernia, midline incision. This is her peristomal hernia, and this is her mesh fistula here, putting on Steinman pins. And this is a combination of weight loss. This is a combination of a external oblique release. And then, of course, some of the things that Dr. Slater showed earlier today in moving her stoma. And I'll just tell you, doing these types of operations, changing people's lives, it has been a calling, and I appreciate the opportunity. Thank you guys very much. And I'll just leave you with this statement, which is one of my favorite statements ever that someone interviewing with me gave me at the interview, Jeannie Schau, who presented earlier. And surgery is the most optimistic field in medicine. And thank you.
Thank you, Todd. Another exceptionally high quality talk, and it is so amazing to hear people from different parts of the world talk about their experience and their understanding of the subject. And people seem to be doing different things and yet coming to the same place. I mean, we have someone like you, and you've just detailed about what you have done. And I've heard similar things from others. For example, recently, Mike Rosen did a talk for the AHS. And though some of the things he said were different, but more or less, he still says 90+% facial closure, doesn't use Botox, but does something different. But essentially, I think there is a common theme. There is more that is common between all of you, in fact, many of us. And we shouldn't focus on the differences. We should focus on the commonalities. Some of them, which you've already mentioned, is weight loss and the rest of it. We'll move on for the next talk. Eric Polai is standing by to talk on what happens when things go bad and you have to explant, and what can you do then.
Hey, thanks, Ramana. I think we're going to show the video since I'm
Hello, my name is Eric Paulai. I'm a professor of surgery at the Penn State Hershey Medical
give
Center.
it live, right, Eric?
Delighted to spend some time at the conference today speaking with you about mesh explant and beyond. What now? These are my disclosures. I will use generic brand names for mesh whenever you see them listed in the talk. So we're going to spend an entire conference on loss of domain. I've been listening to some exciting talks today, and I'm very bummed that no one talked about The Lost Domain, which is my second favorite book about owls, or The Lost Domain, which is my first favorite Swedish hard rock band. We've only been talking about hernias today, and I will continue that trend. We've heard some data about loss of domains being rarely related to primary, mostly related to unrepaired incisional hernias. But I'll point out that many of the patients that I see have already had multiple prior attempts at repair, and many of them have mesh in situ, as these two patients did. To further complicate matters, some patients have mesh-related complications, like this patient with a loss of domain hernia and a mesh-related fistula, and this patient who has a loss of domain hernia and a small area of exposed infected mesh. And so we're going to spend some time today talking about these issues. Number one, what are the best practices when removing mesh in a loss of domain patient? We'll talk about the literature on redoing component separations in these circumstances. And we'll talk a little bit about mesh selection during non-definitive and definitive management of loss of domain hernias. So let's start with mesh removal during a loss of domain repair. What do we know? I'll say a few things which are not really scientific, but which are just things that I think about. This part of the operation is one of the last things that I let my fellows and my chief residents do independently. And that's because the goal of a complete mesh removal and the goal of abdominal wall preservation are often at odds. And it can be a challenge to do this. Obviously, if the mesh is in a sublay position and you've got layers of the abdominal wall on both sides that you're trying to preserve, this becomes even more challenging. I think to add to this, the easiest plane to dissect is not always the mesh tissue interface. In some circumstances, a layer of tissue wants to come down with the mesh, or you're actually dividing the mesh into a bilayer, leaving synthetic material behind. I often do complex repairs with a team, sometimes with the GI tract surgeon, or I'm managing an abdominal wall defect while an oncologic operation is happening. If I'm working with the team, I always show up at the start of the case and I do the mesh removal part of the operation up front so that nobody is tempted to do it on their own. That allows me to have some control over the manner in which the mesh is removed to preserve as much of the abdominal wall as possible. What does the literature say about mesh? This recent publication by Ko et al. From the Carolinas Hernia Group looked at 1,904 patients who were having mesh removed. And this was an ACHQC study where they propensity matched patients based on complete or incomplete mesh removal. They noted that complications were significantly higher after partial mesh removal versus a complete mesh removal. That included surgical site occurrences requiring procedural interventions at 24 versus 9%. And in patients who had infections or fistulas, there were even higher rates of SSOPIs at 46% and reoperations at 21%. And so in these circumstances, complete mesh removal appears to have an advantage in infection and reoperation rates. When they looked at an odds ratio analysis, partial mesh removal increased the likelihood of a procedural intervention for a surgical site occurrence by 1.5 and the risk of a reoperation by 2.2. And so the authors advocate for complete removal of previously placed mesh. But I'll remind everybody that this is not a beauty contest. We often see pictures that look like this of these, beautifully removed meshes. And I have to say, I definitely take some pride in getting out the mesh in one piece. But I remind people that A, this is completely unnecessary, and B, it may not be the easiest way to remove it. And so this, 7-piecemeal removal of mesh on the right-hand side here is just as fine as the other two. Just get all of it out. It doesn't really matter how you do it. Let's talk about redo component separation. With a growing number of component separation hernia repairs happening, we see two things. One is an increasing number of incorrectly performed operations. I don't think there's any doubt about that. But I think secondarily, we're seeing some patients who have correctly performed operations who subsequently have a problem like a mesh fracture, which is not truly a technical complication, but rather a mechanical complication. And what you wind up with are some large hernias like these. Here we see a rectus abdominis muscle and a semilunar line injury separating the transversus, the internal and the external oblique. Here we see something very similar. This patient has some onlay mesh and some fluid around the mesh here. So very challenging hernias occurring in lateral positions after components have already been separated. We looked at performing posterior component separation, or TAR, after patients had already had external oblique releases. Our initial publication at 29 patients. Most of these were lateral, most of these were midline, although some were lateral, and about 14% had both midline and lateral components. And I'll point out that about 40% of the cases or so had some degree of contamination, so not clean cases. These patients all underwent open TAR, and we heavily favored permanent synthetic mesh in that sublay space. But I'll point out that 45% of patients had a surgical site occurrence, 28% of those were infectious in nature. There were 17% 90-day readmissions, and one patient had a colotomy with an organ space infection that required mesh explant, and that ultimately led to a recurrent hernia. So can you do it? Yes. Is it challenging? Absolutely. And I think importantly, out of a risk of destabilizing the abdominal wall, if you're going to do this, you've really got to cover that semilunar line from under costal margin all the way down past the inguinal ligament. Mike Rosen and his group at the Cleveland Clinic recently looked at their experience of redoing transversus abdominis release. So here we see a patient who's got a posterior sheath breakdown. You'll notice that there's also a midline breakdown and some lateral hernias. So 3 different types of hernias here after a TAR. They had 65 patients who underwent redo TAR with a median hernia size of 25 by 16 centimeters. And again, their components included mostly semilunar line injuries as the largest group, but also mesh fracture, patients with infection after TAR, and then posterior sheath disruption, as we just mentioned. So how did these patients fare? Well, surgical site occurrences were about 33%, surgical site infections requiring a procedural intervention at about 17%, and notably a recurrent hernia rate at 22.5% at 12 months with clinical follow-up. Now, while these patients did have clinical recurrences of their hernias, many of them had significant improvement in their hernia-related symptoms, so these patients were objectively better after the repairs were done, and also subjectively better. But again, I'll point out that these are expert hands performing this operation, and these clearly are challenging operations to do. What about mesh selection during a loss of domain hernia repair? Well, I'll remind people, we've been talking a lot about ways to get the abdominal wall definitively closed, but not everybody needs a definitive reconstruction in the first go-around. Here we see a patient who has obviously a fistula here. He has a mesh-based complication. He's already had an emergency operation to remove his infected mesh, partly, and that has left him with this fistula. This is kind of what it looks like when you pull that pannus back up. This is the remaining mesh that he had to in situ. You can see 20 by 14 and 14.5 by 12.5 was what was left behind after a big shark bite had already been taken out of the mesh. And once we removed all the mesh, did some bowel work, what we were left with was basically a 30 centimeter by 30 centimeter full thickness abdominal wall defect. And in the setting of a patient who has an infected mesh, who had a fistula takedown, who was on TPN and is a bit malnourished as a consequence of all of that, I think that doing a definitive reconstruction in this patient is probably a bit of a disservice. And so in this particular patient, we elected to perform a staged intervention. You can see we closed the bottom part of his defect just primarily. The upper part is a bridged, slow absorbable synthetic mesh or reconstruction of about 15 by 15 centimeters. This patient had enough local soft tissue that we could rearrange over the top. Here you see him at the closure of the case, and here he is back in clinic several months later with no surgical site occurrences and an extremely high risk of getting a hernia back. But when he gets his hernia back, A, it's much smaller than it was. B, there's no infection and there's no fistula. And so we've kind of downstaged his hernia here quite substantially. And so I think that we need to keep this strategy in mind, means of non-definitive reconstruction. If you're curious as to what that looks like on a CT scan, you can see that he's got this section here, which was read by our radiology team as a diastasis of the rectus. But you and I both know that that mesh does not wrinkle like this. I'm sorry, fascia does not wrinkle like this. This is mesh in a bridged reconstruction fashion. Here's another patient with a poly-4 hydroxybutyrate bridge and a loss of domain flank hernia repair. And this patient had a large acute abdominal wall defect as a result of a thoracoabdominal aneurysm repair. And you can see that her retroperitoneum is infected, and there's a bunch of pus coming out, which led to this mesh being infected. This is about 5 months after her repair. She's had a vac on this for quite a while. It's clearly not going to granulate in, but it gives us the opportunity right in clinic to simply remove it. This patient actually saw plastic surgery about a week after this, was put on some antibiotics for this ongoing retroperitoneal infection, and is going to get this area skin grafted in the upcoming weeks. So it gives you some options, even if it gets infected. And you can certainly bridge with a lot of different types of mesh. Here's a patient who had a had a mesh-based repair of an umbilical hernia. This is clearly infected and necrotic. He got all of this taken out, and I show you this is just what a biologic bridge would look like. Obviously, you can bridge in a variety of different ways with these meshes. I simply choose to run it directly to the edges of the fascia because it really burns almost no bridges. And I'll point out that even when this fails and the wound opens back up and you're staring at biologic mesh, you can certainly place a vac on this. Is the mesh infected? Sure. Is it going to dissolve? Sure. So long as the patient doesn't get a fistula, we can deal with the hernia that's left behind after this type of a repair. You can certainly also bridge with a Vicryl mesh, and there's no reason not to do it. It is, of the 3 temporizing meshes to bridge with, the least expensive. I will point out that it also lasts the least amount of time And by 6 weeks, you're already reforming a large hernia, which is part of why I don't like to use it for those circumstances. But I definitely do use Vicryl as an absorbable mesh bridge in other loss of domain circumstances. So we looked at 36 patients undergoing TAR who had significant loss of their posterior layer of the reconstruction, such that we didn't have any other options for repairing it. We didn't have hernia sac, we didn't have momentum that could be used. And so we looked at patients who had a bridged reconstruction with Vicryl mesh. So essentially the posterior layer is bridged with that piece of Vicryl, and then a piece of permanent mesh is placed in the standard sublay space. Here you see what a patch of that Vicryl would look like in a patient who had a large lateral defect in their posterior sheath. I'll point out that our experience demonstrated that about a 20% surgical site occurrence rate, and 14% of those patients were surgical site infections. We also had 13.9% recurrences in this small series. 2 of those were peristomal patients who I think we would expect to have a high recurrence rate. But again, this is a challenging patient population for sure. What about the definitive mesh for these reconstructions? Well, I'll point out that there's a lot of conflicting data, and certainly people have their opinions. Our initial look at this favored the use of synthetic over biologic mesh because there was a 46% relative reduction in surgical site occurrences, 61% relative reduction in infections, including a 75% risk of deep infections being reduced, and a 66% relative reduction in hernia recurrence. But this is at the risk of putting permanent synthetic mesh in a non-clean circumstance. Warren and the folks at Greenville also looked at this, looking at 541 cases, and broke the contamination down by wound class. Mesh was in a sublay space extraperitoneal in the overwhelming majority of patients. When they did suture repairs and looked at surgical site infections, it was 17%, biologic mesh 36%, absorbable synthetic mesh 32%, and the best performer in the group, permanent synthetic mesh at 14% surgical site infections. What about recurrences? Similar story. Suture repair 28%, biologic 26%, absorbable synthetic 31%, and permanent synthetic mesh only 10% recurrence. And so I think that you're seeing some emerging data to suggest that even in these challenging circumstances, you can use a permanent mesh. So how do we put it all together? Let's talk about all of those things. Here's a patient of mine who has had a previous external oblique release. The posterior sheath was harvested bilaterally and swung up as a trapdoor to help get the anterior fascia closed. There was mesh placed, it got infected. The patient then had 2 pieces of permanent synthetic and 2 pieces of biologic mesh placed in with wound debridement, skin grafting, and she currently has exposed actively infected mesh. We did a reconstruction including a biologic mesh bridge, and unfortunately we had evidence of a missed enterotomy. And so here you see us taking her back and opening up. We see succus in the posterior layer. We took out the mesh that had been placed, and you can see that there's succus coming out at the junction of our Vicryl mesh and our native posterior sheath. So we took the opportunity to simply open that Vicryl in the midline, find and repair an enterotomy, and then close the Vicryl back together in the middle, replace new mesh after antibiotic wash, place additional drains, reclose the fascia. And so you can see that all of these tools are useful and can be done and redone even in the setting of a challenging complication. So I'll conclude by saying that complete mesh removal during a loss of domain hernia should be attempted, but it does take skill and effort. Redo components certainly can be performed, but even in the best hands, there's high rates of infection, surgical site occurrences, and recurrences. And like any repair, mesh choice depends on the nature of the repair that you're doing, where you're placing the mesh, and obviously your tolerance for risk as a surgeon. Thank you very much. Looking forward to answering your questions.
All right, thank you. We'll move on to the last talk. Javier has a talk. I think that's the last talk of this session. And following that, maybe we can have a little bit of Q&A at the end of it. So Javier, please go on.
Thank you. about. Thank you very much for the opportunity to present the work of our Madrid group about the double component separation technique, this controversial technique. Maybe instead of talking about eating the forbidden fruit, which sounds more like being in heaven, something celestial, I can tell you that when you are deciding to perform this technique, you feel more like in hell when you are in the OR. So maybe the most right title would be double component separation. Darn it, what else can I do with this patient? These are my disclosures. And I'm going to try to answer to these questions during the talk. Who are the patients suitable to perform a double component separation technique? Of course, we have been dealing with this patient the whole day during the talks. They are patients, extreme cases of abdominal wall reconstruction with severe loss of the main incisional hernias. And we have to insist again in the patient's peculiarities. They are really technical, complex patients. There are many technical concerns related with the difficulty, multi-recurrent hernias, previous messes, previous abdominal wall resections, previous cutaneous graft, but also there are really important biological concerns. And these biological concerns are more related with the possibility of death after the procedure. And why performing a double component separation? Well, we start doing this technique because it was a technical necessity. In really extreme patients, the performance of a standard component separation was not enough to restore the abdominal cavity. So then we start doing this because the objective in complex abdominal surgery is reconstructing the abdominal wall with fasciotomies over a large peritoneal mesh. These fasciotomies allow us to medialize the borders of the abdominal wall, but they also increase the diameter and also the compliance of the abdominal cavity to reintroduce the bowel that is placed in the sac. So why not associating the fasciotomies performed both in the posterior component separation and the anterior component separation to get the most tissue that we can get from the abdominal wall to reconstruct over the mesh. So we combined the medial posterior rectus fasciotomy with the lateral posterior rectus fasciotomy of the transversus abdominis release, and also the external oblique muscle fasciotomy of the anterior component separation. Yeah, but what about the axioma that says that abdominal wall instability may be produced after combining both component separation techniques? Well, it might be true from the anatomical point of view, but this is not an anatomical repair. This is a prosthetic repair, so the intact internal oblique muscle is reinforced by a large peritoneal mesh. And secondly, there isn't a large overlapping, or there is even no overlapping at all between the anterior component and the posterior component separation fasciotomies, and it has been published recently by Dr. Zayas, Winder, and Pauli. When should we perform this technique? Well, no doubt, in complex abdominal wall patients, all they should follow an adequate preparative optimization, as we have been talking during the whole day. So you have to buy for all of these patients the whole loss of the main package. And well, the moment to decide that you are performing this technique is in the OR. We usually follow the same systematic algorithm managing complex abdominal wall patients. We always start performing a retromuscular dissection. In many patients, it might be enough just with a rib stopper repair. If it is not enough, then we perform the transversus abdominal release or the modification of Madrid. And in some patients where all these techniques are not enough, then we perform the external oblique muscle fasciotomy and the double component separation technique. How do we perform the technique? Well, nothing new. We are just adding a posterior component separation with an anterior component separation. Dr. Garcia Ureña just talked some minutes ago about the posterior component separation, the tips that we should follow. I just want to just remark 2 points. First, we should use at least 50 times 50 centimeter meshes. The smaller meshes are not enough because they won't cover and overpass the fasciotomies. So it's not a good idea to do a double component separation with a 30 times 30 mesh, because there will be some areas of weakness where the fasciotomies are not reinforced by the mesh. And second, our recommendation is to perform instead the traditional or standard transversus abdominis release. We think that it might be better if you are performing a double component separation to medialize the incision in the upper part and to perform a posterior rectus release, as we described in our modification. That way, the incision will be further away from the external oblique fasciotomy, and the transversus abdominis muscle will remain intact in the costal insertion. And about anterior component separation, nothing else. I cannot tell you anything new. It's a standard external oblique fasciotomy. And of course, in patients with large subcutaneous flaps or in whom we are going to associate underdermal lipectomy, we'll do an open anterior component separation. But in patients with minor subcutaneous flap dissection, we can perform a minimally invasive, as it was described by Dr. Jorgensen. Our results were published last year in Hernia Journal. Our first 12 patients undergoing this double component separation technique. You can see how there was a lot of comorbidity, high risk of complication, and technical difficulty due to the characteristic of the incisional hernias. Complex patients are related with high risk of complications, of course. So you can see that we had 2/3 of the patients with any surgical site occurrences. The most frequent were seromas, but we had 1/3 of the patients with infections. We had also systemic complications. The most dangerous were the respiratory insufficiency and one cardiac arrest, but we didn't have any death in this group of patients. And after a mean follow-up of 2 years, we didn't have any clinical recurrences. Really important, thinking about quality of life and function of the abdominal wall. All the patients improved in the quality of life scales, in pain, in restriction, and in the cosmetic score. And about function, you can see here a CT scan of our youngest patient undergoing this double component separation. You can see here a large transverse defect over 25 centimeters. And you can see how after the double component separation, we restore the anatomy of the abdominal wall. And this patient who likes to play sport, he played tennis. Nowadays, he can keep playing tennis without any problem. So it works. In conclusion, the double component separation technique is feasible, safe, and it has good functional results. But nevertheless, it's not an standard technique and should be performed in exceptional cases of abdominal wall reconstruction. Thank you very much for your attention. And again, I would like to thank the organizing committee and to give all my admiration, because a meeting with more than 10,000 people, it's unbelievable. Thank you.
Thank you, Javier. I wonder if Professor Abhay Dalvi, who is the president of the Association of Surgeons of India, if you would like to make a comment or something?
Definitely. Thank you, Dr. Ramana. I've learned some lessons out of this, hearing this for last 2 hours or so. Number one is not all patients should be operated if they are going to be Netflix operators. Not all surgeons should be operating these sort of complicated cases. Better overall management, pre-operative, intraoperative, and post-operative helps in patients coming back to work. Multimodality treatment is going to help. So not only the surgeon should dominate all these things. Involve in discussions as far as complicated abdominal wall hernias are concerned. Controversies are going to continue and newer modalities are going to come up in loss of domain cases. Let better sense prevail as far as surgeon community is concerned in embarking on treatment of loss of domain people. As far as the president of ASI is concerned, We have more than 28,000 members, and you have a audience of more than 10,000 that have registered and possibly have been seeing all over the world what is going on. Our membership is only second to the USA as far as the numbers are concerned. Let me take this opportunity as an Indian to celebrate, because it's beyond 12 o'clock, the Indian Independence Day. My congratulations to AWR community from India for a wonderful program that has been envisaged. It has been explosive last session, which have again embarked onto newer things that are going to be spelled out in the future. But the one that proper surgeons take on to embark on some procedure which is described as XYZ, but it's not a cup of tea as far as loss of domain is concerned. It's good to hear what is good for the patient and when to retract by the surgeon or by the patient. Thank you so much.
Thank you for excellent comments. Rather than any of us talk any further, let me invite Charlotte to wrap things up from your perspective, Charlotte.
Well, it was just such a wonderful opportunity to be a part of this. And I think, you know, as more people are fixing hernias, more people are doing more complex stuff, and we've learned that there are options for some of these more complex things. I think, you know, really learning how to take care of the patient in entirety, looking at all the options to get them optimized preoperatively, get them ready for surgery, do safe surgery in the OR, and then on top of that, be aware of kind of the post-operative things that are unique to these super complex hernias. And so it was just an absolute pleasure hearing everyone's experience, hearing everyone's advice. And I think, you know, it's really these meetings that allow us to see what the options are, because that truly allows you to know, you know, what's safe, what's not, what's the data. And so I think these are great things to be a part of and great things to participate in to really advance your learning, because you get to learn from people all over the world.
Thank you. Jan Kukleda, you're still up and you're still full of vim, vigor, and vitality. So,
well, I wrote to everybody now, this was not a marathon, but a terrathon. But as you see, it only shows that there are several disciplines. When you go through the whole day program, you know, it's very difficult for one person to cover it all. With all the data, like Charlotte said now, you know, it was, by the way, a fantastic talk. I just didn't want to interfere, but yeah, I'm very happy that 7 weeks ago we decided to do it and not to think of it. Ram.
Absolutely, absolutely. And it's just something that we thought we should do. This came out of an idea from Dr. Kanagavel just to have a discussion on this topic. And naturally, being a little crazy, I kind of dug into it, and this thing blew up and became
a little crazy.
So I think at this point of time, we are looking at a very interesting phase for many surgeons across the world. And I wouldn't say just Indian surgeons or Asian surgeons. I think across the world, including in the US, people are still coming to terms with the bewilderingly fast changes happening in the field of hernia surgery. And personally, I'm witnessing so much happening. And one of the things which I'm personally concerned about is that all of us who are serious students of hernia surgery should be looking at quality outcomes. And one of the important considerations for a country like India is that we need to have more credibility with our data. So the AWR surgeons community has gone all the way now to start a registry for hernia surgery, and we should be implementing the registry soon. And we are looking to get the support of all the major surgical organizations in India. So that way, a bulk of the surgeons, if they start registering their data, then have quality work coming out of India in the coming years, especially for the coming generations. I think it would be extremely important for them to have more data coming out. So thank you, everybody. I can't tell you how grateful I am for all that you have done and all the importance that you have given to this meet, every one of you. I must share this. Eric Polai was holidaying with his family and got stranded in Florida because of a hurricane. And he took a premature flight, not home, but to Charlotte, because otherwise he would have been in the flight or he would not have been able to attend this conference. So he took a flight to another city and he stayed in a hotel with just one t-shirt and one hoodie. And he spent the entire 7 or 8 hours that we've been here. He's been here throughout. And that is the kind of commitment, the kind of friendship and bonding that is so moving. Words are not enough to express all this. For this, we need physical meetings, lots of spirits and hugs. All right. So thank you again. And I think it's good time to say good night and see you till next time.
Thank you. Thank you,
everybody.
And good night.
Happy Independence Day.
Yeah.
Good night, everyone.
Happy Independence Day.
Enjoy the night.
Good night, guys.
Good night.
See you, everyone.
Bye-bye, Pramod.
Goodbye.
Bye-bye, Brijesh.
Good night, Jan.
Rahul.
Enjoyed it.
Yeah, good night.
Good night.
Good night, Ram.
Good night, Brijesh.
Good night, sir. Good
Sharad.
night.
Good night.
Bharat.
Sharad, good night.
Good night. Good night, man.
Sharad, good night.
Ali Sheen is
Good night,
still
sir.
with us. Ali.
Ali, good night.
Hi.
I just want to say thanks, everyone, and good night. And I hope to
Thank
see
you.
you all
Thank you, Ali.
in
Thank you.
Copenhagen. Okay.
Thanks for being